First of all, I would like to thank Dr. Sarup, Dr. S.K. Singh sir for this kind invitation. Good morning, everyone. I will be presenting a case of infected trachea with pathological fracture of distal femur. This is a case of 53-year-old female with past history of bilateral single-stage trachea done elsewhere in suburbs of Maharashtra 18 months ago. She developed some infection wound healing issues on right side within 6 months and underwent a staged, probably she's in the history she was giving two surgeries was done 1 year ago. She doesn't have any old records or any old x-rays during this period. During this 1 year after second stage surgery, she was on antibiotic suppression therapy. She had a trivial fall 1 month ago, and since then she was unable to walk on her right lower limb. Patient does not have any significant past medical history. She is not diabetic, not hypertensive, and this is her X-ray. For left seeing decently fine, while right there was a comminuted distal femur fracture. We did got a CT scan done, but the CT images are not available as of now. In lab reports, the hemoglobin was 10.2, WBC count was paired with polymorphs of 71%, CRP level was elevated by 96, and ESR was 68. Now, as per Philadelphia, because patient had on and off pain inside the knee and her CRP level was elevated, we thought in terms of infection in the knee. We did a joint aspiration for the same. The synovial CRP was positive, and the cell count was raised more than 10,000. But the culture report didn't show any growth. Even the extended culture didn't show any growth.
So it was a post-traumatic fall. Did she have any pain before the fall?
So she was on antibiotic suppression therapy, but before the fall she had
so
on
it was
and off
infected beforehand only. It was diagnosed case of infection.
Yeah.
Then she had a fall.
She had a trivial fall and she developed.
Okay. Then it's fine. Yeah.
And even her culture report was negative, but her CRP level, blood CRP level, as well as synovial CRP level was elevated.
Okay. And did you do a leukocyte esterase test?
A leukocyte esterase test?
Yeah.
No, but at the time of
because you have done aspiration, correct?
Yes.
Okay. So if they elevated ESR at CRP, next step is to aspirate, and aspiration. Nowadays, leukocyte esterase test is very easy. Urine sticks, those sticks can be taken and tested immediately. Within a minute, you'll give the diagnosis. Okay.
As soon as we took her for debridement and cement spacers, this was her initial intra-op radiograph where everything seeming to be loose. And as soon as we removed the implant, it came out in the hand, and there was thick biofilms and infected junk inside the knee. The cultures from 5 different sites were obtained during this stage, and we did a thorough debridement and a pulse lavage on both sides with something like a dikane solution, mixing hydrogen peroxide as well as chlorhexidine in the solution. Although we had planned for some mobile spacers, but due to lot of bone deficiencies, we had to opt for a static spacer in this. This was her initial picture. We kept her on IV antibiotics for 3 weeks, and thereafter for oral antibiotics for 3 weeks. And in the extended culture, the first post-op stage, the E. coli was grown in one of the cultures, and appropriate antibiotics were given. After 6 weeks, the CRP started to return to baseline of 5, but the ESR was still high, and the joint aspirate at that time, after stopping the antibiotics for 7 days, was sent, and even that came to be negative. And at this stage, we planned a revision for her. And this is her in the intraoperative photograph with multiple scars. At this time, we went, as soon as we opened the joint, we did a synovial Shore. We had access to synovial Shore test. Did a synovial Shore test which came out to be negative, And even we did a leukocyte esterase test as sir told, and even that showed light purple color, which was not evident of any existent infection. We didn't have access to frozen section, that's why we didn't did that. And as soon as
most important thing is here is the clinical evaluation on the table. Was there any granulation tissue anywhere, or any frank pus? That is more important. Is the joint looking dry? Okay, all these tests is okay.
Yes, at the joint, as such, the joint fluid was very, very minimal, and there was some amount of debrima which was visible, fairly visible. We did a thorough debridement at that time as well. Although we had planned for both, we have kept on table both, something like LCCK, revision LCCK neck system, and also LPS distal femur, considering the fact that distal femur was not good. At the time of implantation, due to huge loss, we have to opt for distal femur replacement in this case. And this was her intraoperative tracking. She had a fair range of around 60 degrees intraoperatively. We had resorted to some patella. We did a relief sutures. We have put a prophylactic sutures on the patella tendon, and after implant placement, we did supplemented here with a Simlan kit with heavy loaded dose of antibiotics. And this is her post-op images.
You didn't resurface the patella. Normally you don't do.
No, we didn't resurface the patella, sir. We didn't resurface the patella in this case, even after the debridement. Because the patella thickness was very less, sir. She was a thin, fragile lady. And this is her post 3 years follow-up. Still walking, but I've still kept my finger crossed. There is no discharge as of now, and patient doesn't have pain. But still, there was evidence of some osteolysis seen surrounding the stem, and even the proximal femoral stem. There is some evidence of perforation. But still she is doing well. As of now, she is 5 years post replacement, post this LPS replacement.
Is it how many months or years follow up this one?
This is 5 years, sir.
5 years follow up.
Yeah, we have that in 2017, sir.
Okay.
Proximal, yes, sir. It's a cemented stem, sir.
It's a cemented stem.
It's a cemented stem, and it does have only uncemented rim, so has to get incorporated inside the sim. Synovial short test is an alpha defensin test. It is done inside the synovial fluid to confirm whether there is infection or no infection intraoperatively while you are performing the second surgery. It is available in Bombay, but the cost is like very high. It's 13,000 rupees per kit. 13,000. Yeah. So if the synovial CRP is raised, it is more confirmatory that the infection is inside the joint. If the blood CRP level is raised, it might be due to some other infection or other localized infection in the body. But if the synovial CRP is raised, then it is more confirmatory that the joint is infected. No, IV antibiotic for 3 weeks, oral antibiotics for 3 weeks. E. coli was sensitive to imipenem group of drug. So we have kept her on meropenem initially for 3 weeks, and then tablet ferropenem for another.
Almost 20% of the joint infections, sometimes it's difficult to find a bug. They are culture related.
Even we were very desperate, sir. Even we were very desperate pre-operatively to know the bug. We did aspiration. We waited for extended culture even in those cases, but there was no infection.
Correct, because 20% of the cases you don't find a bug and you are in dilemma,
One sample growing E. coli with extended culture, no other sample is growing.
No other sample of color.
So,
it's difficult to predict.
that may not be a diagnostic of infection.
No, but sometimes, see, these patients come to us when they have received multiple dosages of antibiotics by the other physicians, and then probably the scenario what you got is not unusual. When the bug gets sort of noticed after extended culture. So I think your microbiologist should be also very good and a friend of yours, so that they continue to culture it.
You have called him at least 6 to 7 times to keep it for extended culture for 2 weeks, not
Correct.
of only for 3 days.
Correct, correct.
Bone scans in a diagnosed case of infection, it will be a very costlier affair to diagnose the infection. As such, patient didn't had any, if she had a multiple space infection, or if all the other tests were seemingly negative, and still I was clinically more oriented towards infection, I would have definitely opted for that.
There is no role of bone scan now for diagnosis of infection. No PET scan, no indium scan, no technetium gallium scan is diagnostic of infection. There is only one role of bone scan for diagnosis when your implant is well fixed, both sides, and you are not planning to explore that joint, and you have put whatever antibody, ESR, CRP, blah blah, everything done. Still you are doubtful, then you can just do a bone scan at that time. Otherwise, there is no role of bone scan now. Rather, nowadays leukocyte history is very useful. Heuristics tests are available very cheap. One bottle costs around 200 rupees, where 100 sticks are there. So you can do immediately within 1 minute you will get the result. And the signable CRP, if it is available, many laboratory it is not available. It is more diagnostic of joint infection at Dr. Singh told you. No, not diagnosis of infection.
For diagnosis, only to check for the ligament status, maybe we can get it done. Thank you.
Thank you, Dr. Vijay. And now for the second case, I request Dr. Chandan Kishor to come on the dais and present his case. His case is on total knee replacement in tibia with stress fracture.
Very good morning, all of you. This is my case. 55-year lady presented with this X-ray. You can see the stress fracture on left side. So I advised total knee replacement, but she refused. She came back with this X-ray 1 month after, and again I advised total knee replacement. She refused and went to some other local doctor, and he applied a cast.
Now at this point of time,
Sir.
How did you diagnose in the first case? The X-ray, it was evident. Did the patient tell you anything in addition to the knee pain? What complaints
she had severe pain below the joint line.
Okay. So this is important. In many varus knees, severe varus knees, the patient complains of shin pain, and there you clinically palpate, look for the tenderness. Even if the X-ray doesn't show, many times there would be occult stress fracture. If you do not put a stem extender in those kind of cases, then what happens later on? They come with a frank fracture after you do a total knee replacement surgery. If you find there is a localized tenderness below in the upper part of the tibia, go for an MRI that time to diagnose that stress fracture. So clinical examination is more important. Here it is evident that there is a cortical break, but one must keep in mind in severe varus knees. Oh, yeah, that is true.
Now in this X-ray, she had fibula fracture also along with recurvatum at the fracture site. Again, she refused knee replacement, and this is 2 months she was still not ready for replacement, and she was working on it. And this is 1 year. Now she came for the knee replacement. So what I did is not important. I just want to discuss what should be done now.
Now, first thing is whether the fracture is united or not.
Sir,
united.
it is immobile at this stage.
Yeah, that because fibula is united,
Yes.
it will be difficult to assess clinically whether it is united or not.
Yes.
But anyway, treatment is straightforward. That you have to do a fibula osteotomy,
Osteotomy.
and then put a stem extender.
Sir, the limb is in internal rotation, and there is recurvatum at fracture site. So how to manage
There is no
that
recurvatum
challenge
at the
during
fracture site. Rather, there is a varus deformity in the coronal plane.
Sir.
The sagittal plane, I think the alignment is pretty good. That's not a problem.
Okay, so sir, Mohanty sir,
Yeah.
so how to proceed? What are the steps we should follow in this?
Yeah, let's ask our delegate, sir. Anybody wants to take? Yeah. Let's involve everybody. Let's take opinion from our. Okay, if you can tell, then we can discuss amongst our faculty.
Sir, first I do fibular osteotomy, then see the mobility at the fracture site, then go for, if mobility is there, then go for TKR.
Yeah, how will you take the tibial cut? It's a mobile, tibia.
Sir,
If you put the jig, it will move.
no sir, 3 plane mobility I check manually at the time of fibular osteotomy.
Fibula osteotomy you did.
Yes sir.
How will you how will you take the tibial cut while doing the TKR?
Sir, first I, yes sir, medial side से one plate produce करेंगे, उसके बाद sir tibial osteotomy.
So you will temporarily put a plate
Yeah.
on the medial side, stabilize the fracture, and then you will do all after doing a fibula osteotomy. Anybody differs? Anybody wants to do differently? Okay. Okay. Hello. Okay. Well.
Yeah. Even if there is robotic, but the fracture malalignment has to be corrected.
Yes.
So probably if you use intramedullary jig for tibia, it will automatically correct the alignment, and then you can go ahead with the cuts. But as you told that you can also temporarily use a plate, unicortical screws, to correct the alignment, and then you can do. Only thing is that then you have to open the fracture site also. Okay. So easier thing will be to use a intramedullary tibial jig.
No. Not necessarily. You have to see whether the fracture is mobile or not. If the fracture is mobile, then you can put an intramedullary jig. What happens without opening the fracture site? When you ream the canal, those reamings acts like a callus. That will help in the callus formation. And already callus is forming, so there is no need of opening unless there is a instability at the fracture site.
Actually, it's hypertrophic non-union, elephant hoop. So once you put a rod, once you get a purchase down, in fact, what I do, whatever condyles you cut of the femur, especially the chamfers, make a small incision at the non-union site, very, very small incision, and push that cancerous graft. It's the best graft, very small incision. You can incorporate through your own incision of the TKR, fine. Otherwise, take a very small incision on the medial side, put
Okay,
will discuss,
so what I did, I put two midline K wires in the proximal tibia in the single vertical axis, and used that K wire as a reference to put my jig. And I took the tibia cut and prepared the femur also. Then I did the fibula osteotomy. But after fibula osteotomy, the tibia fracture was not coming in line. So I opened the fracture from the lateral side, removed some amount of bone from the lateral side, and then I reamed the canal, and I did the final placement of implant. This is the immediate post-op X-ray.
Yeah, looks good. Very good. And you use those callus as bone grafts
Yes,
locally also?
yes.
Okay.
Yes.
Now the question that how long a stem extender you will put? There are stem extenders available, 75 stem extenders which 135, all these in different companies have different stem
This is
extenders.
150, sir, and this is fluted rod.
Okay.
I kept plate also on the table, but it was stable, so I didn't apply the plate.
Very good.
And this is the 2-month follow-up, and this is the 5-month follow-up.
Very good.
This is WhatsApp X-ray, so X-ray quality is not good.
So points from this case that you have to do a fibula osteotomy, do a intramedullary jig in order to take the cuts in the tibia. You can put a temporary plate unicortical on one side in order to stabilize the tibia, and the stem extender has to be at least 2 cortical diameters beyond the
Yes.
stress fracture site. And if your stem is not snugly fitting inside the tibia, still you find little instability. In addition to that, you can put a plate and a screw unicortical in order to stabilize that. But the stability has to be perfect. If there is no stability at the fracture site, it will not unite. It may give rise to problem later on. And after doing this, you can give immediate weight bearing
Yes.
to these patients.
That's what I did.
Okay.
Thank you, sir.
Thank you.
Yeah.
When you putting the cement in the intramedullary canal,
Yeah.
did you have any worry to come the cement into the fracture site? Or
Actually-
how did you fix the distal part?
That is fluted rod, what I said. And actually you put cement in the proximal part only. You don't cement whole of the medullary canal. If you are putting cement proximally, how it will go at the fracture site? No, it's not like that.
Actually, you do a hybrid fixation here. You cement the base plate, but the stem remains uncemented. So that is the way. So that cement will not go into the fracture site. So whenever you do cement on the base of the platform of the tibia, and take out little bit cement from the canal. First put the rod inside, and you also pre-coat the prosthesis, and then cementing will be only at the base plate level. So what is known as a hybrid fixation.
Thank you, sir.
Now I request Professor Sanjay Yadav. Professor Sanjay Yadav is professor in Trauma Center IMS BHU. He will be presenting his case, total knee arthroplasty in a complex varus knee. Dr. Yadav, please.
Thank you, Dr. Sarup and SK Singh, sir. So on behalf of the Varanasi Orthopaedic Association, of which I am the scientific secretary, I welcome all the senior faculty from outside. Welcome especially Dr. Mohanty sir, who has come here before to teach us the nuances of joint replacement. So actually a lot of things have been covered in the previous two talks. This is a very simple case which we have prepared last night. So just there are only pre-operative x-rays and post-op x-rays and things we can discuss. So Dr. Puneet, who is my junior resident, he has helped me in this presentation. So this is the first case, around 65-year-old male with bilateral knee pain. So of late we get patients with severe deformities. As Dr. Chandan told, they don't get convinced in one go. So this is a pretty simple X-rays to visualize with grade 4 osteoarthritis with the intra-articular stress fractures. So what Dr. Chandan showed was an extra-articular stress fracture. What this X-ray shows are intra-articular stress fractures with bone defects. So I'll go to the post-operative X-rays. So there are two concerns in these cases. One is the soft tissue management and other one is the bone defect management. So intra-articular fractures, stress fractures can be corrected with by the level of the tibial cuts.
Let's discuss first, then you will show what you have done. Yes, anyone wants to take up?
So
How to
just
go
for sake of discussion, any specific things which you'll keep in mind?
Here it is not examination. We can discuss, friendly discussion. No problem. Before you, Dr. Vijay Singh wants to speak.
The X-ray shows if there is a gross varus with uncontained defect. I will be anticipating we have to do good amount of varus release on table. I will keep stem extended as well in tibia, so as to prevent.
First of all, will you do a CT scan in this case, or it is not required?
I don't think so. CT scan. I will more eager to do a scanogram rather than CT scan.
Okay. Anybody will do a CT scan? Yeah. So all of us agree. I think we should do a CT scan. Before that, in a simple way, even there is a severe varus deformity with bone defects like this, sometimes you will do a scanogram, but weight-bearing X-ray doesn't give you a true picture. So in these kind of patients, especially you have to take a X-ray by correcting the deformity, how far deformity is correcting. So give a valgus stress and take a AP view. That will give you a rough assessment how much the defect. That is the first thing. Those are beginners, you must remember.
Sometimes in varus knee, the lateral ligaments may be stretched, but here in this case there is more of bony defect and the lateral ligaments are not so much stressed. So that way you can decide that whether you're going to take more cuts or less cuts.
Those are the important points. Yes, sir.
That is more in the valgus knee, that is medius structures are more stressed in the varus knee. Usually we found that the lateral ligaments are quite lateral supporting structures are quite thick and there are multiple like LCL and the posterior corner and all these things. So I think it is more with the valgus knee rather than the varus knee.
What Sekhar is going to point out that he was pointing out that rather than ligament stretched, it is the bony defect which is contributing to the deformity rather than stretching of the ligament. And probably I would do a CT scan, as all of us agree, I would do CT scan to assess the bone defects and plan our surgery. Yeah, Vijay, then you can proceed. You will keep a stem extender.
So intraoperatively, I will anticipate that I will require a lot of release medially.
How much cut you will take on the tibial side?
That will depend upon
standard 8 to 10 millimeter from the unaffected side, or you want to?
If there is a lateral laxity intraoperatively, if I find that the lateral joint is opening too much, I will take a minimal cut. Will reduce the amount of cut.
So to begin with, do not take a directly 8 to 10 millimeter cut from the unaffected side. You will land up in a big gap, and that may occur because polyethylene and joint may become unstable. So preferable to take at least 5 to 6 millimeter cut, something like that, so that then you can proceed. And you may keep a stem extender. How will you build up the defect?
So it will depend upon the amount of defect, and as it is mostly I anticipate it's an uncontained defect. If it is up till 5 mm, I will only cement it. If it is more than 5 to 10 mm, I will prefer to put the screws and cement on top of it. If it is more than that, probably wedges on table will be required.
Or will you put bone grafts?
Bone grafts on the lateral femoral condyle can also be.
Yeah, usually if you want to put a bone grafts, the posteromedial cut is a good chunk of bone to put it there. And if you put a bone graft, then you need a stem extender to be put. Now question is, suppose you are building up with a screw and cement, will you put a stem extender or will you not put it? Only
intraoperatively, if my tibial base plate, I will just put the thumb rule. The thumb test was there. If it is not lifting off with the simple pressure of thumb on the medial side, no stem extender will be required. If it is still lifting off, then probably stem extender will be done.
A rough rule is that you rotate the tibial component, trial tibial component on the tibia base. If you are able to rotate it, then you have to put a stem extender. That is number one. Number two, how much is the posteromedial defect? If it is 20% or less, usually you don't require a stem extender. But if you see the average surface of the tibia, take it as 100%. The defect is more than 20%. It is better to go for a stem extender. We'll go ahead.
Yeah, so I think a lot of points covered. So sir suggested we get CT scan for better qualification of the bony defects, and then if patient walks and walking video there is a lateral thrust, which is a good possibility, then ligamentum balancing will be a problem. If there is a lateral thrust, then we need to start with the minimal cuts, like say 5 or 6 mm cuts, and then we can always increase as we, if needed. Then of course you should have additional armamentarium like screws which are compatible with the metallic components of the implants, stem extenders, SOS.
Can you have the slides, please?
Yeah.
So what you did, you just described by the time slides.
Yeah, so we proceeded with the standard knee replacement because we have a lot of constraints on us. Usually the patients are coming with the government schemes, and also we did with we bailed out with a standard knee replacement without any kind of stem extender. We build up with like a bone cement. So in this particular case, the reduction was little difficult. So while checking the final reduction, the medial condyle actually chipped off. So that we did lateral slide, and then we had to put a screw for that.
Okay, this was not planned.
That was not planned. That was not planned. So we were little aggressive on the minimal cuts. So probably we could have cut a little more.
Yeah.
Yeah. So a lot of things to learn from. So just like if we, so this was we used the part of the bone graft to cover the defect, and then this side picture shows the medial condyle we have fixed with the screws. So this was the post-op X-ray we could get. So, and so another case, just 3 slides, just like this. So this was another case with bilateral severe deformities, patient walking like not willing to get undergo surgery. Sir,
can you go with the post-op X-ray?
Post-op, yeah. Please, yes.
Are you happy with the slope, tibia slope?
Maybe neutral if it's not posterior.
I think it's reversed.
Slightly reversed, okay. Yeah, agree.
Maybe 1 or 2 degrees you could see very carefully.
Okay.
Rather, the other thing is that, can you have the slides?
Pardon, sir?
In case there is a fracture like medial epicondyle, how will you pass the screws? The screw looks little posterior, isn't it? So when you pass the screws obliquely, because there is an intercondylar notch there, okay? So the screw will likely to hit. So you part it obliquely towards from inferior to superior aspect and from posterior to anterior aspect. So you avoid the neurovascular bundles behind. So even if it comes up little anterior, it doesn't matter, but posteriorly it should not go. So from inferior to superior aspect and from posterior to anterior aspect, the screw should be passed.
So this regarding the slope, I think the system was the jig for the tibial one has 2 lines. One was the anterior margin, and 2 or 4 mm behind there was another black line. So startingly that black line has to be on the anterior wedge, and what we were doing was keeping the anterior border. So that's why you can see the stem has reached the limit. So this is another case with the similar this thing. Again, the patient was not willing, came very late, and with lot of comorbidities. So similar kind of pattern in a different this thing. Again, same discussions which we have done. So this was the CT scanogram which is available, and this is the post-operative X-ray. So we did one case was done around 3 months ago, and next case was done after that when the patient came. So again, the patient was not willing for stem extender. Also, the tibia was in vara, and it was we thought that putting a stem extender will be a little tricky in such cases. So we tried to manage without a stem extender in such cases, and the defect was managed with probably bone cement and screws. So these are the challenges: middle contracture, soft tissue release, balancing, bone defect management. You should have extension rods or osteoporosis management. Also in such cases, the physiotherapy should be supervised with gradual rehabilitation. So with this, I thank you audience for patient listening, and thank you for all the inputs.
Thank you. Any questions for this case? Okay, we conclude the session then.
Thank you, Mohanty sir. And I hope there was learning for everyone in the case presentation. So we move to the second slot. So now we have Professor S.S. Mohanty sir. He does not need any introduction. We all are fully aware, and he is a great teacher. And his sir will be speaking on the understanding of gap balancing technique and measure restriction technique. So I hand over the podium to sir. And I request Dr. Uttam Garg sir and Dr. D Tripathi sir to moderate the session, please.
Thank you. So I request Dr. Mohanty sir to present his topic on the knee arthroplasty and understanding of the gap balancing and the measured resection technique. Welcome, sir.
Thank you. Thank you, Uttam. Thank you, Tripathi sir. I thank Dr. S.K. Singh and team, Swaroop, Anup and others for inviting me here. So this is very basic thing that always it is confusing to whether to go for a gap balancing or measured resection techniques in total knee arthroplasty. As you know, the goal of total knee arthroplasty is restoration of the alignment and balancing of the ligaments. So restoration of the alignment, this problem we have solved more or less. So now we have mechanical alignment now we have kinematic alignment and restricted kinematic alignment, adjusted mechanical alignment. So more or less alignment issue has been solved, and whatever alignment do patient will do well, provided your joint has been balanced well and it is stable. So the aim is to provide the good exact flexion and extension gap, equal flexion and extension gap, and that depends on the femoral component rotation. That how you put the femoral component in proper rotation, that decides about your balancing of the gap. So normally in about say 95-96% of cases you do a 3-degree external rotation, but in about 3-4% cases you may have to do a little more external rotation, depending upon it is a valgus knee or post-traumatic arthritis. Special situations you have to adjust the rotation accordingly. And gap balancing basically depends on the precise soft tissue balancing. So before you take the bone cuts, you do the release the ligaments, balance the gaps, and then you do the bone cuts. Whereas measured resection technique depends on the accurate bony resections before doing the soft tissue balance. That means you take the cuts, balance the gaps, then you adjust accordingly that how to balance the flexion and extension gap. So let's come to the gap balancing first. Here, as I told you, that ligament releases are done prior to the bone cuts. So it corrects the fixed deformities and bring the limb into correct approximate alignment before determination of the femoral component rotation. So in some companies, some manufacturers, they recommend you have to do flexion gap first, and some manufacturers do a extension gap first, but basically it depends on the surgeon's choice that whether to go for a flexion gap first or a extension gap first. So the people who follow flexion gap first, what they do, they take the proximal tibial cut first, then they take the AP cut of the femur. So they see that the flexion gap, balance the flexion gap, then take the AP cut of the femur, and then third step is to take the distal cut of the femur, and then they balance the flexion and extension gap. So first take the tibial cut. Your tibial cut has to be absolutely perpendicular to the mechanical axis and anatomical axis of the tibia. So if you take a varus tibial cut, there are chances that your femoral component will go into internal rotation, and if you take a valgus cut of the tibia, your femoral component will be externally rotated. So that is why all the gap balancing method, the crux is that you have to take a proper tibial cut. Of course, whatever slope you give in the sagittal plane doesn't matter, that depends on the manufacturer again, but you have to give maybe around say 3 to 5 degree or 7 degree in Zimmer system. So you have to give whatever slope you give, but your coronal plane, in the coronal plane, your tibial cut has to be perfectly perpendicular to the shin of the tibia or the axis of the tibia. So after you take proximal tibial cut, then you check the flexion gap. So in check the flexion gap, if it is equal, then you can adjust your gap accordingly, release the ligaments or whatever, and then you take the AP cuts, and finally next you check the extension gap with some kind of device, your tensioner or whatever, and then you do the rest of the things, implantation of the component. Whereas the people who follow extension gap first, like I follow always extension gap first, so this is more precise and reproducible. So you take the proximal tibial cut or distal femoral cut, whichever way. If you are doing distal femoral cut is also okay. So whatever you do, take both the distal femoral and proximal tibial cut and first check the extension gap with your spacer or whatever. Next you go for the flexion gap with a lamina spreader or a spacer like this, putting the jigs there, so you can check the flexion gap afterwards. So how do you check that gap? So either you can use these spacer blocks which are provided by the manufacturer, you can use some kind of tensioner like this, or you can use some kind of lamina spreaders like this used by the spine surgeons. Those are the things will provide you in the gap, how it is equal on both the sides. Now the advantage of gap balancing method is that you have a precise soft tissue balance without need for any significant release. So you just adjust the gap. There is consistent equalization of flexion and extension gap. The published advantage of literature that the reduced femoral condylar lift-offs in a gap balancing method, and it provides a better coronal stability. So that problem which we tell mid flexion instability, it's better addressed in a gap balancing method. That is what is recommended, especially Buchel Papa knees. If you have heard about Buchel Papa knee, they do the first flexion gap, and that's why the mid flexion instability to a greater extent it is addressed. Whereas the pitfalls, what are the disadvantages? You have to have an accurate tibial resection. If your tibial resection goes wayward, then everything goes wayward and the whole surgery will be jeopardized. So you have to have an accurate tibial cut just perpendicular to the shin of the tibia or the axis of the tibia. Next you have to have a good collateral ligament integrity and function. If the collateral lacks or collateral is affected, like in valgus knee, medial collateral is compromised, in those kind of cases gap balancing will be detrimental to do, and you'll have a difficulty in doing those kind of cases. And always remove the osteophytes from the earlier part of the surgery. This is extremely critical. Take out from the femoral side, take out from the tibial side, because unless you have taken out the osteophytes, you will have a wrong erroneous impression about the gap balancing, and later on when you take out the osteophytes, it becomes there will be gross imbalance in the knee, and you may have to put some constant knee. And there is a possibility of joint line changes. Restoration of the joint line may be difficult in a gap balancing method. So these are the pitfalls of the gap balancing method. Now you come to measured resection technique. So in measured resection, what you do, you take the bone cuts are initially independent of the soft tissue resection or release of the soft tissues. So with the bone cuts only, you adjust the flexion and extension gap. But the problem is that in case of valgus knees, where the posterior lateral condyle and the distal part of the lateral condyle is hypoplastic, in those kind of cases, if you take the posterior condylar axis as a landmark, then there is a possibility of your internal rotation of the femoral component. So here you have to take a inter-epicondylar axis. In our patients, sometimes there is a severe advanced osteoarthritis where the intercondylar notch is not there. So how will you take the anteroposterior axis? So how will you take the gap balancing? In these special situations, you have to be extremely careful when you are doing a measured resection technique. So what we do, what I do, what is the best? The mix of both the philosophies, both gap balancing and measured resection, recheck one with the other. So I'll show you that how I do. then go back a step. If there is moment you feel there is some outlier or some problem, then you can always correct it. So each step you check the balance in each step of your surgery. So each case is a different, so customize your technique as per the case, individual cases, plan your surgery accordingly, and then you go ahead with it. In case of primary care, okay, in case of primary care, this video is not working. Okay, so whether the knee is correctable, as we are discussing in the case presentation, whether it is a correctable deformity or it's an uncorrectable deformity, that you decide on the table after giving anesthesia to the patient. Because after that muscles gets relaxed and you will properly judge that whether it is correctable or not correctable. Then only you decide that how much cut you will be taking. So this is a one demo surgery in our KEM Arthroplasty course. So first you take out the osteophytes, next you do a proximal tibial cut, then I do a distal femoral cut and check the extension gap and the alignment, of course. So after checking the extension gap, then you do a femoral component proper rotation depending upon the interepicondylar axis. Then you check your flexion gap and before taking the anteroposterior cuts. So you check your flexion gap, take the AP cuts, then after taking the AP cuts, then I put the trial components there, and at that time I do soft tissue release, not that from the beginning. So put the soft tissue release, do a pie crusting of medial collateral ligament. So after putting the trial component, then gap is balanced in both flexion extension, then I cement the components in. Whereas in revision situation things are a little different. In revision situation, what I mean, there is bone loss in the distal femur. So I check the flexion gap first. So put the spacer block, see what is rough estimation of the flexion gap. After checking the flexion gap, next you see the interepicondylar axis and then see the how much femoral component rotation you are going to give as per the interepicondylar axis. Next you restore the joint line. Restore the joint line from the medial epicondyle, lateral epicondyle. You measure that how far it is there. The joint line has to be at least 25 millimeters from the medial epicondyle, and restore the joint line, and finally check the restoration of the flexion and extension gap after putting the trial components in. Okay, so if you have done a good job, suppose a patient like 72 years female, recurvatum deformity, and this is just a 8 years follow-up of this patient, that even with the primary components, if you have balanced your gaps well, the patient will have a good function and he can climb up and down the stairs and get up from the bed without much more any difficulty, even using the primary components in there. So take home message: one should follow mixture of both the philosophies, gap balancing and measured resection. Recheck one with the other. Check at each step after taking the bone cuts, after putting the trial components, and after cementing also, that you check that your components are well placed and your gap is balanced. And keep constant implant always standby. In case you do a over release, there is a possibility of use of constant implants. And remember, each case is different and you need to customize your technique. I thank you for a patient hearing, and I request all of you to provide your kind support for my candidature for the Vice President of IOA this year. Those who are members, I request you to cast your vote in September, October when the voting process starts. Thank you very much.
Thank you, Dr. Mohanty. It was a very wonderful and comprehensive lecture on the bone cuts. Question from the house, please.
Ideally, you should measure it rather than eyeballing. Many people also do eyeballing, I know. But ideally, you have a scale on the table. You can measure it with the scale also. Just give little traction and measure on the medial side as well as the lateral side. And you can measure it with a lamina spreader also. But sometimes, osteoporotic bones, the lamina spreader that damages the porotic bones. So what I do, I put the spacer blocks which is provided by the company and then do it. But while doing this flexion gap, some companies do not have that thinner blocks, because the shock capture is there. So shock capture occupies some space there. So you have to have a minus spacer block in order to assess that. If it is not there, always you can assess with a scale. For example, J&J system, they do not have a minus spacer. So what I do, I put a 8 millimeter, aiming for 10 millimeter, I put 8 millimeter spacer there and just check it like that.
Mohanty sir, if there is a lot of flexion deformity, then there is mismatch between the extension and flexion gap. Can you just elaborate how to manage that?
Yeah. See, flexion deformity, always the flexion gap becomes more than the extension gap. So earlier part in the surgery, normally I do posterior cruciate in sacrificing knees. So in the earlier part of the surgery, take out all the osteophytes and posterior cruciate ligament, etc. Meniscus also you take it out. And after taking the bone cuts, I check the extension gap. Usually the extension gap will be tight compared to the flexion gap. So at that stage I release the soft tissues, especially I release the posterior capsule of the femur. Last resort I keep to take extra bone cuts from the distal femur. So release the posterior capsule from distal aspect of femur. Most of the time your flexion gap gets corrected. And how I do it, I take a wet gauze piece and put a curved periosteal elevator protecting that gauze piece, and with a cautery bend the cautery about 45 degrees and thus release it gradually and push it the gauze piece with the periosteal elevator. That is how I release the posterior capsule from the femur.
And tibia, from the tibia?
Sorry?
Posterior capsule from the tibia?
Yeah, if there is a varus deformity, then posteromedially, you can do a little pie crusting. If there is valgus deformity, posterolateral corner, you can do pie crusting with a 18 gauge needle.
And head of gastrocnemiae?
Sorry?
Head of the gastrocnemiae, do you cut that?
Usually it is not required. Usually it is not required unless it is a very, very severe flexion deformity beyond 90 degrees where it may be required to release. Otherwise, most of the times taking out posterior osteophytes and the posterior capsule from the femur, it gets released, and taking a extra distal femoral cut about say 3 to 4 millimeter, 2 millimeter fast, then again 4 millimeter usually it happens. In a very severe flexion deformity, we had done a hemophilia case, 120 degree flexion deformity, we had published it also. That there we did a 3-stage surgery. First stage, what we did, we released that gastrocnemius from percutaneously and did a serial cast correction. So from 120 degree we reached until about 80 to 90 degree, and then we did a total knee replacement. After that, doing also there was around 40 degree of residual flexion deformity because of severe reduction in the extension gap. So after that, post-operatively, after doing total knee replacement, in the 3rd stage again we did a serial cast correction, and we could correct it until about say 10 degree of residual flexion deformity, and we achieved a range of motion about 90 to 100 degrees. So that took almost 6 to 9 months doing a serial cast correction, 3-stage surgery, like 1/3 correction before surgery, 1/3 correction during the surgery, 1/3 after the surgery.
How much maximum femoral cut we can take?
Yeah, so you can take the cut until the collateral ligaments. Your collateral ligaments should not be compromised. On an average, it is recommended that you take suppose 9 millimeter of distal femoral cut. Then you can take another 3 to 4 millimeter, 2 millimeter or 2 millimeter, maximum 4 millimeter you can take. Beyond that, usually collateral ligaments will come there, and that may compromise the stability.
Sir, for posterior release on the femoral side, by curved periosteum and tapping gradually,
yeah,
we could be able to release it.
Yeah.
Your recommendation is the curved diathermy.
Yeah, curved because periosteum very tough structure.
Yeah.
So you can do whatever, basically to protect the soft tissue structures behind. So I do a curved diaphragm. Once you release the periosteum from the cortex, then you push it with the gauze piece gradually behind with the periosteal elevator. That becomes easier with a curved periosteum. Or if curved periosteum is not available, I do a curved osteotome. I take it and gradually you just push it, so that the gauze piece is protecting me there.
Thank you, Dr. Mohanty sir.
Thank you.
Now I would like to invite Dr. Sanjay Londhe for his next lecture on the pre-operative planning and registration with a fully active Curvis robot case-based discussion. Welcome, Dr. Sanjay.
not coming. So first of all, good morning. Thank you very much, Apex Super Speciality Hospital and Dr. Singh and Dr. Swaroop Patel for inviting me here. So what we will do, I will briefly discuss how we plan the robotic surgery. We are a group of six orthopedic surgeons who basically installed this machine in the city of Mumbai first about 14 months back. And we have almost completed more than about 300 cases now. So every surgeon has little sort of his or her own idiosyncrasy in planning. So I'll just show how I plan. And I think Dr. Swaroop Patel was suggesting me that I'll curtail some of my lecture and we will plan the surgery, whatever we are going to demonstrate. Hopefully it should go well. So it's a valgus knee. I already planned on the team viewer yesterday. So we'll share how we have planned as an actual case, which we are going to operate. So I think as you are aware, there are benefits of robotic assisted total knee arthroplasty. To be honest, when the patients ask me how much is the advantage, I feel it's about 15 to 20% incremental value is there, because you have the comfort of planning the surgery much in advance. So I think the soft tissue releases and the dissection which you need to do during the operation is much less. In fact, next week I am presenting at EFORT, European Federation Congress in Vienna, where we have analyzed the immediate postoperative outcomes of conventional versus robotic, my own cases only. And the VAS score and the morphine milliequivalent tramadol requirement or NSAID requirement of a robotic knee are much less as compared to the conventional knee. Though it is very early, long-term functional results are awaited. So I think these are the early trends. So preoperative planning, I think all of us are orthopedic surgeons. Basically, the patient gets a dedicated software 3D CT scan. All those files get transferred to the biomedical engineer of Merrill, and along with the biomedical engineer, they do segmentation of those files, and we sit not physically. They may just take us on the team viewer, and we plan the surgery. So this is what we will actually show on the computer. So I'll skip this. Essential steps to basically align the HK axis, hip, knee, ankle. You need to have a femoral head. You need to have the medial epicondyle, lateral epicondyle, medial posterior condyle, lateral posterior condyle on the CT, then medial distal condyle, lateral distal condyle, and then you get this perfect view, AP, lateral, axial, as well as three-dimensional view, which we will show. And you have, it's like a mechano, it's you can play with it. You can anteriorize the implant, posteriorize the implant, internally rotate the implant, externally rotate the implant, or you can upsize or downsize the implant also, making sure that there is no notching and you achieve a good balance. So this we will explain. So femoral implant planning my way, as in a lot of robotic active users, they have different formulas or different workflows, but I usually keep the distal resection of the femur at about 9 mm unless the patient has a preoperative flexion deformity, where I will keep it at about 11 mm to begin with if it is a bad flexion deformity, or 12 mm, either distal medial or distal lateral. Again, this is a myth. We have been doing conventional knee and always we have been cutting 9 mm from the lateral distal condyle. Now you will see, we are soon about to publish that majority of the times actually we are cutting more on the medial side than the lateral side to get the HK axis 0. I keep it at 0. I don't believe in kinematic alignment. I believe in 0-degree alignment. And probably because we are cutting more on the medial side to get the HK axis 0, so I think all the conventional knees probably we were overcorrecting them. I don't know. It's a food for thought. It's a food for thought. But there is a concept of constitutional varus in Indian population, and probably that is the reason why we are cutting to get the HK axis 0 in a robotic knee. Sometimes the medial dissection is more than the lateral dissection. Usually, then in a varus knee, usually I keep the posterolateral resection equal to the posterior condyle thickness of the intended implant. For example, if I am using a size A implant, then I will keep posterolateral resection at 7.2. And if I am using a size B implant, I will keep it at about 7.7 in a varus knee. This is done by anterior or posterior displacement of the femur implant and by giving flexion and extension to the implant. In a varus knee, I usually keep the posteromedial resection about 1.5 millimeter to 2 millimeter more than the posterolateral resection to get a rectangular gap. Because in a varus knee, the structures are tight more on the medial side. So I keep 1.5 to 2 millimeter more posteromedial resection than a posterolateral resection in a varus knee, whereas in a valgus knee it is exactly opposite. We will show in a valgus knee you keep the posteromedial resection equivalent to the size of the posterior thickness of the implant, and the posterolateral resection will be about 1.5 to 2 millimeter more to accommodate for that trapezoidal gap to become a rectangular gap. So valgus knee, the posterolateral resection is kept about 1 to 1.5 millimeter more than the posteromedial resection, usually done by externally rotating the implant in a varus knee and internally rotating the implant or keeping the implant in neutral in a valgus knee. Initial registration points which we will show during the operation. Basically, during the operation we mark about 40 points on the femur and 40 points on the tibia to make sure that the patient's anatomy is matching with the CT scan morphed model, and there is some concept of root mean square error. It should be roughly about less than 1. That means the patient's anatomy is matching with the CT scan. In a patient with a very bad osteophytic, with lot of osteophytes, which our patient has, I think today's patient which has been kept for the operation, we may accept the value up to 1.2 or 1.3 also, because osteophytes sometimes cause little aberration or little sort of artifacts. So these are the points, multiple points on the femur, medial, lateral, distal, anteromedial, posteromedial, anterolateral. Then establishing the tibial mechanical axis, again upper part of the tibia and the center of the ankle. Proximal center of the tibia is taken, tibial tuberosity, ankle center is taken. PCL fossa, medial condyle center and lateral condyle center is taken. Tibial implant planning, again I am open to suggestion and question, but usually in this particular system, the proximal part of the tibia, our observation is, as you will see, the burr comes down and cuts. So I usually don't keep the upper tibia in a varus knee proximal lateral resection at about 9 millimeter. Because you have to accommodate the 2 millimeter size of the burr, because the diameter of the burr is about 4 millimeters and some healthy cartilage. So if you plan 6.3, eventually you will end up cutting about 8.3 to 9. That is our observation. That if you plan for 9, probably you will be cutting about 11 to 12. Only this resection, otherwise all the resections are point to point in this particular system. But the upper tibia always, I think it cuts about 2 millimeter more, because the burr goes down and cuts the tibia. Hopefully we should be able to demonstrate that. Posterior slope, I usually keep it between 3 to 6 degrees, depending on whether the tip of the prosthesis is touching the posterior cortex of the tibia. I keep it at 0 HK angle. My philosophy is simple. If I keep it at 0 and if I deviate 3 degrees here and there, still I am in that safe zone. If I keep it at 3, then I may land up at 6 or 0 degrees, which I don't want. So anterior and posterior position of the tibial implant to ensure no damage to the soft tissues. And this particular robots prepares the keel as well as the keel wings, but usually I keep it to myself, the last option, the last part of the surgery. I cut the proximal tibia and keep the rotation of the tibia and preparation of the keel to myself during the operation. So selection of tibial base plate, again make sure that there is no, is there a pointer? Make sure that the base plate doesn't extend there, because these are all dangerous structures are there. Medial you are okay, this is medial, this is lateral. Lateral always take care of the patellar tendon. So ask your assistant to use a radius ulnar spike or something, because the burr medially it will cut like this, but for the lateral the burr will go like this. So always protect the tendon, because that's an important structure, and if there is any inadvertent damage to that, then I think the patient can and the surgeon can land in trouble. Tibial registration points, again medial, lateral, anterior, tuberosity, medial plateau and lateral plateau. So this is what we usually get. We get to see the implant from the lateral side, medial side, from the foot end, from the head end. Make sure that there is no notching. Tibia also we can see from all the sides. And this is 2 or 3 days before the operation. you have the comfort of sitting in your AC and planning the surgery, vis-a-vis certain other systems where means we have the luxury of even having access to the Velis system, where the hospital I work, they have both the systems. But there you have to plan during the operation, and sometimes like garbage in, garbage out. You know, if you are stressed and if you don't mark it well, then there might be some untoward alignment. So this is the report we generate. Again, I think this we have clear. This we have published in International Society for Technology in Arthroplasty. First 40 cases of ours. We were correct in about 80%, 100% of the cases for the femoral implant, and we were correct for almost 96% of cases in the tibial implant, the sizing. That is the paper in Indian Journal of Orthopaedics. So I will show during the operation, intraoperative workflow. I use a PS implant. I don't use CR implant. I use 100% PS. The knee is exposed in a routine manner. Mind you, in this particular workflow, as Dr. Mohanty has explained, our conventional knee is about, say, 60% measured resection, 20% gap balancing. In robotic, it is almost 80-85% of the measured resection and hardly 10 to 15% of gap balancing. So no osteophytes are removed. Minimal medial soft tissue envelope is reflected for the varus knee. Valgus knee, it is the other. Insertion of tibial and femoral tracker pins are done. Usually I prefer to penetrate only 3 cortices to prevent stress fracture. For the femoral pins, certain surgeons have start using within the incision. I still use the conventional way, away from the incision and into the femoral shaft. The aim is again to prevent the see, if this is the cortex, the tracker pin should be like this. You should never end up transcortical. If you go transcortical, the chances of stress fracture are high. So that is a very important point, and ask your assistant to drill it very slow. So I asked Dr. Swarup Patel, who is assisting me today, because this is the only step during the operation I am more intimidated actually in the robotic surgery, you know. So these are the tracker pins which we go, again registration. So this is what we get, the pre-cut gap check. Once we put everything, you move the knee in from full extension to flexion, 90-degree flexion. The pre-cut gap check balance is checked in full extension, mid flexion and 90-degree of flexion. The medial and lateral gap values are captured. As you can see there, the medial gap is about 7 millimeter, lateral is 10. So we don't have to touch anything on the lateral side after the robot cuts the bone. And you know that there are certain osteophytes. Once you remove those osteophytes, majority of the times that 7 millimeter gap will become 9 to 10 millimeter gap. It gives a fair idea about the post-cut balance. There is a very good paper from the I think Michael Mont from USA regarding the robotic surgery. His recommendation is for a varus knee, if you get a value of about 9 millimeters on the medial side, lateral side can be about 10 or 11. About 2 millimeter lax it should be in a varus knee, because that's a natural laxity. And in flexion, up to 2 to 3 millimeter of laxity is also acceptable. And vice versa in the valgus knee. So it need not be 10-10. In fact, if you have 10-11 or 9-10 or 9-11, it is better, because constitutionally in a varus knee or in a normal knee, laterally, posterolaterally the knee is little lax. That's why the lateral meniscus is also more mobile. You know, when a lot of us do arthroscopy and we know that the lateral meniscus is more mobile. So robot positioning and everything that can be femur resection, these are the normal flow, distal cut, anterior chamfer, anterior cut, posterior chamfer, posterior cut, lug holes. The only system of the robotic system which allows placing of the lug holes, I don't think any other system allows that. I am a PS surgeon, so I do a box cut also. If you are a CR surgeon, I think once you make the lug holes, your surgery is over for the femur side, and trochlear cut. So this is how the robot cuts, which we will see. Tibia resection, again tibial cuts are done in the following order: medial condyle, lateral condyle. When the upper lateral condyle the robot is cutting, make sure that the patellar tendon is adequately protected. Put a radius ulna spike and use your suction as a retractor, you know, when the robot is cutting the upper tibial cut. Then keel and keel wings I usually don't prepare with the robot. I use a manual sort of implant, a manual instrument for that. I think I can skip that. So post cut balance, again, as I have told, once everything is done, I then go and remove the osteophytes, put a trial implant, and again move the knee in full flexion, 45-degree flexion, in full extension, 45-degree flexion to 90-degree flexion, and see the gap balance. Now, as you can see, in extension, the medial side in this patient, 9 value is there, but in extension it is 10 and 11. Captured value is 10 and 11. I am happy with it. About 1 or 2 millimeter laxity in a varus knee is quite acceptable, and valgus knee, it is a vice versa. The trial implantations are carried out, the knee balance in flexion and extension, varus valgus alignment and flexion deformity, hyperextension of the knee checked. As you can see, the limb varus is about 0 degrees, the knee is flexed in 90 degree of flexion, and you see the balance on both the sides. Again, very simple, if it is tight on the medial side, then appropriate soft tissue releases are done in a sequential manner in the medial side in varus knee to achieve a rectangular gap or equal values. If it is tight on the lateral side, then appropriate soft tissue releases are done on the lateral side in a valgus knee to achieve rectangular gap. Then normal, you implant the prosthesis and close. So these are certain cases, actually very, very early cases. This lady was from Chhapra, from Bihar. For some reason, she chose to come to Mumbai and get it done. So this was the deformity. This was her pre-op planning. So as you can see, I have kept posterolateral, the implant is C. The thickness of the implant is 8.2 millimeters, the posterior thickness of the implant. That's why I have kept posterolateral as 8, posteromedial as 9.1 to achieve, to compensate for the tightness in varus or on the medial side. Again, external rotation as regards the transepicondylar axis and PCA, posterior condylar axis, is about 1.5 to 1.6. Again, upper tibia, because she has a lot of lateral opening, I want to cut less. You know, even in conventional knee, we will not cut 9. We will cut about 5 or 6. That's why you can see I have kept proximal lateral only 3.5. So because I have kept 3.5, I will end up cutting about 5.5 or 6 millimeter from the upper lateral tibial side, and I should be fine. I think if I am not mistaken, we gotten away with 9 millimeter insert in her. So, or maybe 11 millimeters. So this is the gap which we got, medial and lateral, same lady, extension 12-12, flexion 12-12. That is a post gap balance. This is intraoperative picture, and this is the immediate post-operative picture. So certain cases, I think CT scan is also important in picking up certain cysts which usually are not visible on the X-ray. 83-year-old lady, wife of a very senior physiotherapist where I practice. X-rays are okay, but if you see the CT scan, there is a huge cyst in the condyle. So here we slightly altered our flow of the operation. Robot mills the bone. So here I cut the distal femur, but proximal anterior chamfer I didn't do it with robot. I did it with a manual thing, so that I got a bone graft there. And we grafted this particular cyst or the bone defect with that particular anterior chamfer of bone. So this is again advantage. Sometimes you see the cysts on the tibial side which are innocuous, and during the operation you might get surprise. So you can warn the implant company in advance and keep the appropriate inventory, rods and everything ready, rather than having a last minute surprise during the operation. So this was the cyst. This is during the operation. This is what we have grafted, pretty straightforward routine step, and this is our post-operative X-ray. Again, this is a very interesting case. Patient coming from Jalgaon, which is at the before Bhusawal, on the border of Maharashtra and Madhya Pradesh. 20 or 30 years back, he had a fracture which was managed conservatively with traction, and he had a malunited fracture of the upper 3/4 and lower 1/4 of the femur. This was his plain X-ray. This was the scanogram. I think absolute ideal indication for computer navigation or robotic, because you cannot put any intramedullary rod. This was his clinical photograph, and this is with the robot. Now, as you can see, if you actually go with the upper femur, the implant is in hyperextension. But if you calculate the hip, the ankle on the CT scan in the sagittal and the coronal plane, they are in line. So this is, sorry, I don't have the clinical photograph, but he did extremely well, and he was non-Bombay patient. So 14th day he took a train ticket and went back to his house, you know, and later on got a lot of patients from that part of the area. Again, valgus knee with multiple loose bodies, very minimal sort of resection you need to do, and you can get a good result like this. Stress fracture. I went to assist one of the young surgeons in city of Mumbai, where they had a robot on a loaner basis. One can see a stress fracture lower down in the upper tibia on the right side. So this is what we achieved. And not that the robotic knee, means see, we all have been doing conventional knees. Almost 90 to 95% of our patients are satisfied, you know. Some 5 to 10% of patients are somehow not completely happy, and that's the worldwide statistics. So what better robotic has, as I have honestly said, I think it has about 20% incremental value in good alignment and less soft tissue handling. So faster rehabilitation, less post-operative pain, and your alignment is guaranteed. So one part of the variable you are eliminating, and the patients are recovering faster. So these are certain mother-in-law of a doctor. So she has only posted on my WhatsApp, after undergoing TKR bilateral in February 2022, where we started a robotic surgery. Mother-in-law went to see the cave paintings at Hampi, and she is climbing the hill. Another happy patient, they are posting, she is from Indore, but I think her son-in-law, her sort of brother-in-law stays in Mumbai. So she came to Mumbai to get it operated, and she has written, my wife has posted all the details. She ran a 5-kilometer marathon and sort of came first. Not all the patients do well, you know, that well. They also need to be motivated. It's not that the surgery is the panacea of everything. You know, the patient has to put in a lot of effort. They need to be positive. The physiotherapist should also be in sync. And this is amazing, you know, means again, this is one patient I had operated, Gujarati lady. She says she danced at her annual program, and she has posted that the lady in the yellow, you know, at her annual day 2022-23, and sort of amazing things patients can do, provided they are properly counseled, provided we do our job well, they do their job well with a physiotherapy, they have a positive attitude, and physiotherapist also sort of motivates them, you know. So I think we have a lot of robots now at our disposal, but I think the image-based robots are better because we can plan better. As I have told you, I have operated with the other system, imageless system also, but there is some intraoperative stress in that particular system because you need, it's like garbage in, garbage out. If you don't map it well during the operation, you will not get the boundaries, or you will not get the landmarks correct. And I think with this I'll stop, and we can show it on the laptop what we have planned for the today's surgery.
Thank you, Dr. Sanjay, for a wonderful illustrations. And I would like to invite, and you have got a second topic.
Yeah.
Yeah.
Today's patient is they will show the X-ray. What we have planned, we will discuss.
Okay, fine. Get it.
If it can be connected. Yes.
Whenever you need graft, you skip one step.
Correct. You do a distal
where you can get
cut posterior chamfer, posterior condyle. Anterior chamfer will be cut because anterior chamfer is a very good graft. And whenever there is a cyst, you use that graft. No, because see, lug holes.
Sometimes said that you are using yourself, cutting the lug
holes are made You can flex extend the implant, you can anteriorize the implant, posteriorize the implant, you can externally rotate the implant, internally rotate the implant. Even sometimes not this system but Wellis system, if you are not getting correct, I have kept sometimes the femur at 3 degrees to get the HK 0 degree. Yeah.
You can take all the cuts, and it has the provision that you can just skip the enter chamfer, so you can leave that step. It can take all other cuts and make the lug holes. Then you can put your 4-in-1 jig through that and take the enter cut on your own.
Correct. So essentially your planning remains the same. I got your question. When you are doing it manually, you feel that whatever you have planned might change. But as sir had said, you have put the lug holes, you put the 4-in-1 zig, you put the screws through that in that lug holes. So the anterior chamfer will cut as you have planned. Hopefully today we should be fine. I don't know about Dr. Srivastav, but our abortion rate is about 2 to 3%. Means out of to about 2%. Out of 100, sometimes 2%, and that too because of some software glitch. You know, we had to convert it to the convention. But almost 98% of the times we could go with the workflow and we executed that, and it is much better than the internationally reported conversion from robotic to conventional on table, a rate of about 10%. See, one patient I will tell you, you have been using it. Everything was done, registration was done, everything was done. I attached the robot to the patient, and then you finally mark the points, medial and lateral. You know, the final points before you start. We did the tibia and femur. We marked the points of medial epicondyle and lateral epicondyle. There it was showing some vague value. It was not less than 1 millimeter or 1.5 millimeter. It was showing some 5 millimeter or 7 millimeter. So still I told them that you start with the distal cut, but you can get a rough idea how much it is cutting, and I was not very happy that it was not cutting what I had planned. So I stopped it and I did the femur myself. That was one case, and another case, I think again the RMSE value we were not very happy, so we stopped. So I think this is a patient Loknath. I think you should have shown the X-ray. You know, anyway, X-ray is not there now, but okay. We'll present it later. So one second, this moves. Femoral head center. So you mark all these points. I usually try to see the condylar center from the foot end. So I am okay. Medial epicondyle, you see from the medial side, M. I think usually the M comes, you know, this is head, foot, anterior, posterior, M, and yeah, that is M probably, okay. Then lateral condyle, it's not going in. Lateral condyle, no. Yesterday we planned along with the on the CT. Yesterday the CT scan has been done of the patient. Segmentation of the files have been done. Company's person yesterday was in Varanasi, I was in Mumbai. He took me on Team Viewer, and this is how we have planned. You will see on the, this point is wrong. Can you go back? See, this is a very tough case Dr. Singh has kept actually for demonstration. See the osteophytes. Can you go back one slide? It's a good question.
Sir, the condylar axis or the medial epicondyle? So we are trying to locate the medial epicondyle.
See, this point should be on the native femur. It should not be on the osteophyte. If it is the osteophyte, then you are not registering correctly in the preoperative plan.
No.
Yeah, correct. See, medial epicondyle. So that's good. Lateral epicondyle. Yeah, click. So again, that is the lateral condyle, then medial posterior condyle. That's okay. Medial posterior condyle. Medial posterior condyle. Are you happy? Then lateral posterior condyle. So this is your transit condylar axis. This is your posterior condylar axis. Lateral posterior condyle. Medial distal condyle, which is the most prominent part. Again, see, this can be written here. No, it should not be on the osteophyte. Then lateral distal condyle. This is okay. Lateral distal condyle. Fine. The point is here. Point is here. AP lateral. The most prominent point. Most prominent point. Then this is the femur implant. Okay, so 1 second. So I think this is wrong. Our implant A, B, C, D, E, F. I think F, the implant is there. No? I think this. Yeah, A, B, C, D, E, F. F implant is there. So this is not the final what we have approved. We are going with the F implant. So this is how the implant will look. So as you can see, I think these are the different values. Means for the purpose of demonstration, I am saying. See, this is 10, 12.8. So I want it to be down. I want it to be about 9 millimeters.
You can see in the corona and the sagittal.
9 millimeter, correct? Can you see that? Okay. Then because it's a valgus knee and F implant, I think it is 9.2 company person. What is the thickness of the implant? Merrill. So posteromedial should be 9.2. F is 9.4. So we'll keep 9.4 as posteromedial thing. So go for the external rotation. F implant. From the head end, this is from the foot end, anterior, posterior, medial. Make sure that there is no notching. Can you see that? You can rotate it also. There is no notching when you see from the medial side. When you see from the lateral side also, there is no notching. If you see from the head end, no notching at all. But I am not happy with this, so we will see whether we can do something about it. Posteromedial, distal lateral. Increase the flexion, maybe. Yeah. Yeah, I am just distalizing the implant now. See, the distal lateral was 9.5, so I made it distal lateral 9.1. Now I try to change the rotation.
So the image with the implant, you can see the values changing there and the implant rotating when sir is rotating. So that gives an idea of how much of internal or external rotation we are doing. Both sir,
Both sides.
you can see in the axial image, the green line is the epicondylar axis and the orange one is the
This is for
condylar
just
axis.
planning. So see, posterolateral I have kept it at 10 and posteromedial about 11. So again I will go to the flexion extension and maybe take the implant little back. I am taking the implant posteriorly. So 9.4, value is 9.4, correct, the thickness of the implant, and 11. I will need to see whether it is notching. If it is notching, I will flex the implant. So again, see, this is how the looks okay.
Looks okay.
Looks okay. Here the implant is little on the medial side. Okay, so in the we'll try to keep the implant, shift the implant little laterally. Can you see that? Implant is getting shifted laterally. Are you happy?
Yeah, little more, sir, I guess.
Yeah. So here we can see the implant, how it is going to fit. Lot of osteophytes. You can see that. These are the lugs. So this is how the implant is going to sit. Happy? No overhang. Can you see that?
Yes, sir.
So I think you have a lot of levers, you know, to change your to get the this is varus valgus. It looks okay. These are femur registration points, medial side. Click here. See, again, very good question you had asked. This point is incorrect. Can you see that? It's on the osteophyte. So I need to go little up. Now it is correct. It's on the bone. Lateral. Okay. Proximal. See from the foot end and mark proximally. Anteromedial. Anteromedial. Anterolateral. Anterolateral. Posteromedial. Posteromedial. Posterolateral. Posterolateral. Following na? Anybody, any questions, please let me know. So again we are going to the tibia, proximal axis. Try to see it from the head end. It's in the center, bang in the center of the tibia. Ankle center, see from the foot end, bang in the center of the ankle. Tibial tuberosity. Looks good. Yes. Yeah. Team viewer, you have the option of changing along with the company person. Yes, 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 yes. Yeah. No, I usually plan myself. I don't rely on the company people. So PCL foci is mainly on the lateral side. Medial condyle center looks good. Lateral condyle center somewhere here looks good. And this is the tibial implant. So 3 is too small, you know, because if you see from the head end, it's a too small implant. So with up size, yeah, size was A, B, C, D, E, F. I think A, B, C, D, E, F. E we are putting or F we are putting? F. So we are, that's why I am going with 5. Again, this is too much proximal lateral. I will decrease the proximal resection of the tibia. I will keep it about 6.2. So I will end up cutting about 8.2. This is how we are going to cut. Yeah. This is how we are going to cut. This is also okay. Here you have the option of anteriorizing the tibia or posteriorizing the tibia. from the head end. Looks good because the burr will come from here and will cut here. So there is a adequate bony margins all along. To prevent soft tissue structures, this system leaves inherently a piece of bone as a protection to protect the soft tissues, medial collateral, lateral collateral, patellar tendon, and obviously the dangerous structures at the back. Correct. Yeah, see, you see it here, na? See this. This implant is over. I think it has gone. नहीं ठीक है नहीं ये बराबर है ये I think let it come here. Hi, can you see that? See my tibia is fitting very well on this. It is not undersized, it is not oversized. And see, if you are worried, plan it according to 4. I would err on the smaller side of tibia, cut according to the smaller side, protect the tissues, and you know in your mind that you are going to put 5. But don't plan according to 6 and let the burr go somewhere else and cause some catastrophe. You know, it will not. But you exactly. Yeah, see here also it is seen very nicely. Dr. Patel is demonstrating. Keel also you can see where we are going to do. And again, you can anteriorize, posterize the implant. See, everything is in your hand actually.
Green is the robotic line. This is as far as the robot will go.
Will cut. The green line.
The green line. This is the path which is going to follow. So it is always inside the bone. So this is, I think, the perfect size and the perfect placement.
So I think hopefully we should put the 5 implant. I think we should be all right because see, if you see from the head end here, looks good. Can you see that? But somehow if you feel you are going to cut more or going to end up near the soft tissues, plan according to 4. There is no harm in planning according to 4 because the cut is going to remain the same. See, cut will be determined by these 2 factors. Understood, no? So internal, external rotation. If you are going to prepare the keel, you can internally or externally rotate the implant. I am internally rotating the implant. Here I am externally rotating the implant. You can see the value internal there. But this is relevant when you are going to use the robot even for the keel. So varus valgus, you are happy with this. I think again something disconnected from their end actually. So I think the only last slide is remaining. Now the last slide will show the complete preoperative plan. What we have battery is gone. Battery is gone. Correct. That's why in that case I will cut the upper tibia less. Because I know once I remove the osteophyte, the medial side is going to get open. The medial side is going to get open. So preoperative gap check when I do whether before removing any osteophytes, if I get a value of even 3 or 4 on the medial side and 9 on the lateral side, I am happy. Because I know once I remove those osteophytes, that 3 value is going to become 7 or 8. Exactly. That's why I have to be very, very conservative in the upper. See, if you cut less, you can always cut more. But if you cut more, then you have a very bad scenario of putting 17 millimeters in there, on table. And beyond 17 there is nothing. Correct. See, role of surgeon will always remain. We will always, it's like a pilot and autopilot. If the Varanasi looks good, the runway looks good, the pilot will land with the autopilot. But if there is a storm, if there is
Thank you, Dr. Sanjay. Thank you, Dr. Sanjay.
Next.
सर वो स्कैनोग्राफ पे वैसा नहीं आ रहा, लेकिन सिटी में आप देखेंगे इट इज अ वेलगस. अब
स्वरूप
हाँ वो एक्सरे में थोड़ा सा न्यूट्रल टू वेलगस जा रहा है।
ठीक है स्वरूप.
Yes, sir. I thank Dr. Uttam Garg and KD sir for chairing the session. Now we'll go for case presentation. So we have another interesting, very interesting case. So to chair the session, I request Dr. Anupam Srivastav sir and senior most orthopedic surgeon Dr. KP Agrawal sir. Please chair the session.
Good morning everyone. We start with Dr. Amit Jaiswal and he will talk on Dr. Amit.
He is a present VOC president, VOA president here in Varanasi.
First of all, I would like to thank Dr. Swaroop and Santosh sir and Team Apex for giving me the opportunity to present this case.
I like to call Dr. Abhinav Agrawal since this laptop is and pen drive is not working with this system. He will be presenting a knee case for discussion.
So very good morning to everyone. So as it is quite evident, this is a knee meeting, so I'll be presenting a knee case. And for this case, I'd like to go for discussion more than what are actual things. So in this modern era of technology, most of us, or rather many of us, are using WhatsApp as a primary source of our conversation, also for dialogue, also for messaging, also and for practice purposes also. So we get, as many of us are traveling surgeons also, and what is the latest term, I don't know. So most of us, we are now getting X-rays and reports via WhatsApp. So this is just, let's discuss this case over WhatsApp. That I received this case on WhatsApp through a hospital. So this was a WhatsApp consult through a hospital. So a typical standard history, a bilateral 57 years male, he presented to a hospital with bilateral knee pain, and he had a history of some trauma to the left knee 12 years ago. And as said, this was followed with X-rays that were presented to us. So this is the X-ray of bilateral knee that was given. So the left side had some trauma 12 years ago, which was treated conservatively somewhere else. So opinion of the house. Most of the traveling surgeons, visiting surgeons, people who move around various hospitals to operate, busy surgeons. Vineet is here? No. Okay. So what will be your plan looking at these X-rays? And how will we plan? Yes, Dr. Vipin. That's correct.
Incongruent. So TKR with it's a valgoid knee, so lateral parapatellar approach and TKR I think would give the best outcome.
A standard TKR
with lateral parapatellar approach.
With lateral parapatellar approach. Why would you choose a lateral parapatellar approach?
Because it's a valgoid knee. Anything it's my what I learned that if it is valgoid knee more than 10 degree, it's better to go lateral parapatellar approach.
Okay.
Because we keep on releasing the medial structures, and that gives not
so I'll make
so
things
satisfactory.
I'll
feeling.
make things a little more complicated for you. Okay. So you're just getting, sir. Exactly.
Yes,
sir.
yes, exactly.
So that is why I said,
is the
in
important
this
thing that
current
the
era of WhatsApp consult and everything going through
clinical
WhatsApp,
and the clinical
people are doing it. Exactly.
Exactly.
So that is actually the crux of this presentation.
Yes.
But
clinical is very important to
sorry,
examination.
Valgus knee tolerates better for the pain. That is correct, sir. So, but we are like the younger generation also. Myself, I consider myself young only. Okay, me included. We are getting more and more of such cases on the WhatsApp. Even the patients are consulting on the WhatsApp. Sir, ये X-ray है, कितना खर्चा लगेगा? First thing is that only, and क्या करना होगा? There are so many things, so many factors. Sir, please. सबसे पहले पैसा आता है, sir.
Whenever you receive an X-ray, first you need to see what is the complaint of the patient. It is not only the X-ray. You have to treat the patient, not the X-ray.
Very
you have
true.
to treat the patient, not the MRI. You have to treat the patient, not that CT scan.
Very true.
So one has to treat the patient. Even if you do a WhatsApp consultation, I also do online consultations. But at the end of the paper, I read that patient needs to be examined clinically in order to give the final opinion.
Very true.
That you have to write and with a registration number that you have not given the final comment unless you see the patient. This X-ray will not so many things about soft tissues, what is the deformity, what is the complaint of the patient, what is the vascular status, what is the muscular status, what is the quadriceps power. Many things you cannot know unless you see the patient.
Very
That's
true.
the first, I think, message you want to give.
Yes, very true. Exactly.
Yeah, that is true. That is true.
That is what I was trying to make things complicated for Dr. Vipin. This is actually a second consultation. So now what will he do? He has got a mindset, he has been advised something at some place. You don't know what it is. But yes, he has been advised some surgery and he just wants to consult. You being a super specialist, he wants to consult with you.
I missed that point that clinical examination is important, and before ending the statement on WhatsApp communication, we should really end up this like clinical examination is important prior to that. Then after that also the plan remains same. I think that way.
So as I said, WhatsApp consultation, what will be the plan? Okay, anyone would like to go for a high tibial osteotomy in this case? No? Sorry? This is all you get. Plain and simple. This is all you get.
We can see here that the lateral condyle of femur is also becoming hypoplastic. So erosion is evident in both the...
This one? This part?
Yes, yes. The lateral condyle.
Yeah.
When you will open this, you will find that it will be hypoplastic.
What about the right-sided knee?
Right side, it's not that may require any surgery unless and until clinical examination.
The patient is coming to us with bilateral knee pain, severe pain.
Okay.
And with this X-ray, some hospital. Okay.
If the degenerative arthritic changes are more evident on one side, then it's better to go slow.
Okay. So you'd go for a left-sided TKR to a lateral parapatellar approach, considering it as a valgoid knee.
Yes.
To the standard implants.
Yes.
Okay.
And then after that, once he has done 2, 3, 4 months, then how is he is feeling in right side? Then accordingly.
Right. Dr. Sekhar sir, your comments, your 2 words. Right.
Given conservative management, and that has failed. Okay. Now, I don't think that this knee is valgoid. There is a focal defect on the lateral condyle, on the lateral tibial condyle, but the alignment is not valgus. Maybe it will be confirmed on HK view or on CT scan, but it doesn't look like a valgus knee. Now, if this focal defect is causing symptoms, this cannot be reconstructed by biological means. It cannot be lifted, and at the age of 58, then the treatment will be knee replacement only.
So you would go for a arthroplasty care in this one? No.
Yes, if the patient is symptomatic, he has been given conservative management, and he's having complaints, then I'll go for this replacement.
Your first preference would be a standard TKR or a robotic TKR in such case?
See, there is nothing like robotic, non-robotic. Robotic is a tool to do TKR in a better way.
Navigate it.
Yes.
Let's
Whatever, it's a technique. Like you have jigs to do TKR, robotic is also a tool to do it to a TKR.
Very true.
It doesn't make a bad surgeon a good surgeon. The principles remains the same. So you can, for this you can do either way, either conventional or robotic.
That is a golden word, I would say. Robot is only there to help you. It won't make you a good surgeon. For a bad surgeon, a good surgeon. I think that's a golden point.
Approach will be standard.
Standard?
Standard medial parapatellar approach.
Standard medial parapatellar?
Closer will be more difficult as compared to medial parapatellar, and we are usually more used to close medial parapatellar as compared to lateral parapatellar. So in a simple case, you should avoid lateral parapatellar unless it is a very valgus knee, 40, 45.
So why will closure be difficult in such cases?
No, not in this case, but you should avoid.
In a lateral parapatellar approach.
Yeah, that's what I'm saying.
The closure will be difficult. You are expecting okay. Sorry? Unilateral knee?
Unicondylar.
Lateral?
No, right side, sir wants to do a...
You want to do a unicondylar knee for the right side? Left one unicondylar. Unicondylar lateral, do we have it? I don't know.
Yes, but I
have not seen.
Nobody does it. I don't think we have.
It's very rare. Unicondylar lateral, I suppose it's a rare thing. Yes, okay. But again, coming back to our situation, it's a WhatsApp consult. Come on. And okay, WhatsApp consultation done. Everything is asked. So the patient has been counseled for a bilateral TKR by some other person, other hospital. He has come to this hospital. Again, the same thing. And yes, so basically it was sent to the X-ray was sent. Okay, we have got a bilateral TKR case. This is the X-ray. Come and do it. Okay. So what will be the plan? Standard, as I discussed, standard medial parapatellar, as most of us would choose. And any added precautions? Anything anyone would like to add? Any form of special implant that you would like to keep in handy or anything like that? No? Standard
general condition of the patient should be assessed properly.
I'm sorry?
General condition of...
Okay, sir. But
time, right. That is the important thing.
So, okay. So the OT is ready, the theatre is ready, our theatre is also ready, and the theatre there was also ready. इसको पहले निपटा देते हैं सर. इसको भी निपटा देते हैं सर अभी. So this is the case when I finally saw the patient just before the OT. This is the case.
How much correctable it was on table?
I'm sorry?
How much correctable it was? How much valgus was correctable? Whether it was correctable? Since there was a bony defect only, na?
This is gait. So as correctly pointed out, this was a valgoid knee which had a severe defect on the lateral tibial condyle. And any changes in the plan now? The OT is ready, the theatre is ready, the implants, standard implants are ready.
Is it correctable valgus?
Sorry, sir? I'm walking without pain. Yes, sir.
Dr. Abhinav, was it correctable on table or not?
Is it correctable?
It was partially correctable. It was partially correctable, not entirely correctable, I'd say. The valgus was there. There was some MCL laxity as well.
So we would prefer
what plans now?
Medial parapatellar, standard knee.
Standard medial parapatellar?
With conventional knee.
With a conventional. And MCL laxity, anything you'd like to do about it? Dr. Surup?
Will be managed on table.
Dr. Vijay? Okay. Dr. Goyal, sir?
On table, it will be assessed and
on table. Okay. So this was, I was in a fix. I had to do the case. And, okay. So I just, Prabhu ka naam lekar ke ghuse andar. And yes, so standard parapatellar theatre, bilateral TKR was done. So MCL laxity was there. So it was balanced. We used a thicker insert. And we used a post-operative knee brace. So the knee was okay. It was opening up medially a bit on the on table, but upon closure, it was a decently balanced knee. This is post-operative X-ray. Again, a WhatsApp X-ray that I got immediately post-operative. This is his 6 weeks post-op. Standard implants, medial parapatellar approach, and this is his 6 weeks post-operative. I'm sorry, this is again a WhatsApp video. I'll get a fresh video with him in his shots, and yes, we can reassess. And but this is what was done, and the message and the entire crux of this presentation was, please don't give a WhatsApp consult, definitive WhatsApp consults over this, and always get a weight bearing X-ray. These were not weight bearing X-rays. The initial X-rays that I got, these were not weight bearing X-rays. Had they been weight bearing IP views, it would have been clear the amount of valgus that was there, and that's what tricked us. So I suppose the OT is ready, sir. Thank you.
हेलो
नहीं सर अब बनेगा ना सर हाँ बनेगा सर ये कल का वीडियो है सर आया हुआ जो
थैंक यू अभिनव 2 minutes more
सर मैं तो सीधे थिएटर में पहुंचा ना जी सर मेरे पास आता तो मैं तो वेट बेयरिंग फॉर एक्सरे फर्स्ट में करा था आई डिडंट गेट योर क्वेश्चन Agreed, sir. It was take. हाँ sir, it's totally my fault. I agree, sir.
Point should be noted here. There are silent thing that has not been discussed here. The axis of the patient from one is that you said it that weight bearing X-ray has to be done properly, and the hip knee angle that has been calculated pre-operatively, and the other thing that is very important to assess the patient clinically, his general condition, his blood investigation. Sometime we know there is a osteoporosis. I just landed with something that I hammered the tibial implant and that is broken. Very easily, just routinely, just we are doing it, just we hammer the tibial plate and it is plated in the midline. So need to be checked out. Osteoporosis also, that
of course
should be
proper
done.
workup is of paramount importance. Nothing can be emphasized more about it. Definitely.
What
So
is
the crux was the proper workup is always necessary
That is
before
very
going up to
important.
the OT. That is the entire crux of the presentation.
You have
Thank
rightly said WhatsApp discussion should be abandoned or it should continue.
Absolutely. Thing is, nowadays even the patients, they want a WhatsApp consult. They want everything done on WhatsApp. They don't want
Exactly.
online consult.
We should avoid to for the general public, and we should discuss with ourselves. It should be avoided in the general people. That's good. That is the. Thank you, Abhinav, for nice presentation.
इस पहले वाला जो एक्सरे साइड में लगाया तो लगा दो. Dr. Sanjay sir, can you hear us?
नहीं मत करो 10 मिनट के बाद. हेलो.
हाँ जी सर.
Yeah, we are just getting the things ready. We'll be live within about 7 minutes. Okay? 5 to 7 minutes.
कर दे तब तक. हाँ तब तक ठीक है. So we'll have one more case presentation.
Yeah, sure.
So he's saying 7 minutes he requires.
Next case is by Dr. Amit Jaiswal. Please continue.
The CT scan is mandatory.
So respected seniors and dear friends, I am going to present the case of osteoarthritis with varus knee. My case was in post-lunch session. Right, come. So, yeah. So, she's a 77-year-old female with pain in her both knees, and she had a severe varus in her both knees. So this was the preoperative gait. She had I'm going to discuss her left knee. That was a complex primary. That was a severe varus, 35-degree anatomical varus, not a mechanical varus, and FFD around 10 degree. So FFD, that is looking here flexion, that is correctable up to 10 degree. So challenges in these cases are three. First is restoration of mechanical axis because there is a complex primary severe varus. Second concern was soft tissue balancing, and third is use of minimum constraint implant. So these are the three challenges in this case. So I would like to discuss this case. First, choice of implant. Now the case is open to house. Which implant should we prefer during the surgery? Should we go with the conventional or any TC3 or anything extra? Yes, Dr. Anupam.
Dr. Amit, this is incomplete X-ray. We should have the full bilateral weight-bearing X-ray, number one. Number two, there should be one hip, knee to ankle axis has to be calculated properly. Then we can comment anything. By these X-ray, how you can comment? Only the clinical examination per-op or the pre-op you can assess and you can go for that.
X-ray shows there is a severe varus, and that is anatomical 35 degrees.
This is left knee?
Yeah, left knee.
And the right knee?
And in a scanogram you also get the same shot of picture, severe varus, simple.
No, right knee, just to calculate that is both knee.
I had operated this case 7 to 8 days back, and I had operated left knee only. So I am going to present this case. What you are expecting in scanogram?
Just wanted to see the opposite knee varus, how it is, how the walking gait will be the patient.
That was also severe varus.
I agree with you that because many of our patients you will find, in addition to knee varus, there will be bowing of the femur and bowing of the tibia, and metaphyseal varus deformity will be there. So extra-articular deformity. That is why Dr. Anupam is asking that. Ideally, one should do hip, knee, ankle, full scanogram, as well as showing the little bit of distal femur would be also helpful to know about metaphyseal deformities.
Sir, in this X-ray, there is no extra-articular deformity in the tibia as well as in the femur, as enough tibia is visible. And on scanogram, I think we will expect that much.
Okay, we take it that there is no metaphyseal deformity.
No matter, sir.
Yeah, we can go ahead. Yeah.
So, what are the challenges should we face? And I would like to discuss the preoperative planning. What should be the choice of implant? Should we go with the conventional knee, or should we have anything extra on table? Mohanty sir.
Yeah, I would keep constant implants, but most likely I can get away with a conventional implant only. And here, when there is a mediolateral subluxation of the knee, in those kind of cases, it requires sometimes release of the popliteus at the posterolateral corner. There is a beautiful article that importance of posterolateral corner in a severe varus knees. One should read that article. So many cases in this kind of mediolateral subluxation, you have to release popliteus at the posterolateral corner. Take a 18 gauge needle, do a pie crusting, or else just take the cautery and cauterize. And finally, after you see that, what happens? You correct the alignment, everything, take the cuts, release everything. What will happen? You extend the knee when you put the trial components, and when you flex the knee, suddenly your polyethylene pops out, or there will be flexion tightness. So if you just release the popliteus little bit, then it becomes balanced and everything falls back into the place. And it may require undersizing of the tibia, reduction osteotomy of the tibia, so that will give good balance. And these kind of cases, to begin with, also you have to take a very less of tibial cut, less of femoral cut, because after taking all those osteophytes, huge osteophytes were seen, suddenly the knee becomes very lax in this kind of cases.
So should we should go with the conventional implant and soft tissue release first, but I think we should have as a TC3
always you keep a standby
in such a severe complex primary varus. And in tibial cut, as sir has already told, that we should go with the less cut and lateralize the implant, downsize the tibia, and along with the medial release, extensive medial release. And on femoral cut, anything extra should we be cautious during the surgery on femoral cut? Yeah, to balance the posterolateral corner, yeah, definitely. And I think femoral cut should also be less, but how much less, sir? This is questionable, as in pre-operative clinical examination and X-ray, it is already opening on the lateral side. So how much less? If we are talking about less, so routinely we are cutting 8 or 9 mm tibial cut. So in this case, should we go with the -2, -4, -3, or -1? In standard conventional systems, we have option of -2 and -4.
You can take 7 mm and -2 cut. That would be ideal, because if you are cutting too much of femur, then too less of femur, there is a possibility of joint line,
so it is
alteration of the joint line.
So it's always a challenge and intraoperative examination, repeated examination that we have to follow during the surgery. Cut the less, balance, cut, and again balance. And on femoral side, can we use a less valgus axis, sir, 1 or 2 degree? Because
normally I go
because
by
medially is a very, very tight structure, so we have to put the implant. If we cut the valgus at 1 degree or 2 degree less, we will have a more space on medial side.
Rather, you should.
Now there is a concept of kinematic alignment is also coming. So can we mix in such a complex case?
You know, traditionally we take 5-degree valgus cut for the femur, and in case of valgus knees we take less of valgus cut, or 3-degree of valgus cut in case of valgus knees. But varus knees we take 5-degree of cut, or you can take 6 degrees of valgus cut.
If we cut a 5-degree valgus, definitely we'll have a less opening on a medial side, and that is already compromised, already challenging. So now there is a concept of coming of kinematic alignment, where you can accept up to combined varus or valgus up to 5 degree.
Dr.
4
Simon
to 5 degree.
wanted to ask something.
That is a combined valgus or combined varus. Valgus varus on both tibial as well as on femoral side. Because it's not a simple case. If we land up with a misbalance or will not be able to balance on table, then we have to go with the
registration
TC3.
करने के बाद
Then
उनको
we'll
discuss
have to
कर
go
रहे
with the TC3, and as we all know that the life of the TC3 will always be less as compared to conventional. Dr. Shyam.
Dr. Amit, with this amount of varus and FFD, and when we are thinking of changing the valgus at the femur side, it becomes important to see for the neck shaft angle as well.
Yeah.
That will probably give some guide whether you are going to change the valgus or not.
So this is the now everything is discussed, I think. So one more important thing, that most appropriate implant will always minimize the need of revision surgery. As we have already discussed, then in tibial cut we should cut the tibial less. We should do the extensive medial release, remove the osteophyte, downsize the tibia and lateralize it. And if required, if you will not be able to balance, we may require medial epicondylar osteotomy. And on tibial side, cut the femur less and valgus 1 or 2 degree less, and go with the mid-path regime between the kinematic alignment and mechanical alignment. I did this case with the Velis robotic system, which is basically real-time navigation and robotic arm. Sir, you want to speak, sir? Sir, you are audible, sir.
So at the age of 77, when the patient has come to you with so much of deformity and osteoporosis, then I would err more towards a constrained implant if needed, rather than trying to preserve the collaterals and stretch them completely, because the chances of it failure are quite high if it's too tight. So even the constrained implants nowadays, they last quite long, and we know that this patient is not going to have too much of functional requirement. So it's just my thought process that if needed, I won't mind putting a constrained implant in this case.
Sir, as Mohanty sir told that if you are able to balance it on table,
definitely
go with the conventional.
And most probably you'll be able to manage
for
it.
For osteoporosis, we can put this stem on both the side. If you are worried that on table there is a severe osteoporosis, there is a likely chance of fracture in later on or early failure.
So in this case, probably with build up on the medial side and a stemmed implant, you'll be able to get through it.
Sir want to say something?
No, just to add him, certain companies, manufacturers, they have constant inserts,
yes,
which can be used along with the primary implant, like Smith and Nephew. They are PS, PS plus, PS plus plus. Same, implants can take. So those kind of things can be on table. You can change the constraints, only the polyethylene constraint. So that will provide some kind of mediolateral stability in those kind of.
But that should be available on table.
Yeah, just for the knowledge sake, just.
So coming to the next slide, that was the initial slide is not changing.
On table, it was clinically, Dr. Amit?
Yeah.
Virus and valgus stent how it was on table?
FFD it was correctable up to 10 degree.
And
virus? 10 degree virus was correctable, 10 to 15 degree.
Look like it is ankylosed type of
What I was
thing.
showing 36 or 37 was anatomical, not mechanical, because there is already a 5 to 7 degree valgus between anatomical to mechanical, so we should add it to 7 degree. So total mechanical valgus was around 40 to 42 degrees.
Look like the tibia medially has gone much, so be careful in cutting on the medial side of the tibia.
I think Dr. Anupam, you agree, and Dr. Amit, these X-rays look very horrible, but on table you get a lot of nice
because that is not only a pure virus.
Yeah.
There is a laxity and subluxation of the joint.
And on table
this joint is
it looks,
subluxed basically.
Please show your final Excel because the OT is running late.
But for a complex primary, you should always a backup implant.
Yeah, that's next. स्विच करना है उसको. What you did?
I did take care, sir.
Just up, you can describe your procedure by the time audio visual.
Yeah. Please summarize your
thing. It is a well assisted surgery. So if it is not permit, I think you can wait for after surgery we'll discuss.
Did you put any constant implant or it was traditional implants? Means PS. PS. Reduction osteotomy.
Hello.
Reduction osteotomy, that was agreed.
Hello, Dr. Sanjay.
Yeah. That was needed
Hello.
here.
Yeah.
You need to do the
it is audible.
reduction osteotomy.
Yes,
then
you are
advance the
audible.
medial
We
and
can
lateral.
start, sir. Yeah, you can start. So we have initially, as I have told during my lecture, I have opened the knee. I usually open the knee. I have removed all the meniscus, removed the anterior and posterior cruciate ligament. Your residents are fantastic. They have put the pins, tibial and femoral pins. We have put the arrays. We have completed the femoral and tibial registration. And Dr. Singh has kept a very easy case actually. Lot of osteophytes are there. But fortunately, our RMSE was quite good. Less than 1. Femoral side, it was 1.2. So we have accepted that because lot of osteophytes are there. So I think we are in the process of checking the pre-cut gap balance. So is that correct?
Sanjay,
little detail of the
Sanjay,
steps
can I
you have
ask?
taken. Sorry? Little detail of the steps you have taken for femur, tibial marking and everything. Yeah, so putting the pins. Yeah, see these are, you can see that. See, these are the tibial pins, about 8 fingers below it from the medial side. I have told your resident, Dr. Chandan, that Akash, Manoj. So as he has touched the opposite cortex, he has to stop. I usually try to put it in 3 cortices. Same for the femur, about 6 to 8 finger breadths above. The tibial pins go from the medial side, the femoral pins go from the lateral side or in the anterior. There are certain surgeons who put the pins through the incision as well, but I try to put it above, away from the incision to prevent the sort of obstruction of the robotic arm. And then we marked the femur about 40 points, we marked the tibia about 40 points, and we confirmed that the RMSE was less than 1. So I think the patient's anatomy is matching with the CT scan anatomy. So I am ready to now have a rough idea about the pre-cut gap balance. Is that clear? Yeah. So we'll move the knee through the range of motion. Gap check.
It looks like a varus knee medial wear of.
Exactly. On the X-ray, so see, If you see at a 7 o'clock position, you see the limb is in 1 degree extension, 1 degree flexion. Lateral it is 5 millimeter and medial it is 2 millimeter. Can you see that? And the residual varus of the leg is 4 degrees at 6 o'clock position.
Yeah.
Then I am bending the knee. I am bending the knee up to about 90 degrees, 7 o'clock position. Lateral is 7, medial is 0. Yeah. So, though on the X-ray it appears to be a lateral compartment osteoarthritis, clinically there is a medial compartment osteoarthritis. One can actually zoom inside the wound and show. So, once I remove the medial osteophytes, I am hopeful of getting that 0 value to about 6 or 7. So, this is in mid-flexion, about 45 degrees. 45 degrees also, the lateral and medial remains the same. When I go up to 90 degrees, 7 o'clock position on your screen, lateral is 7, medial is 0. And when I go into the extension, this will give an idea whether the patient has a flexion deformity or hyperextension. At 7 o'clock position, you see it is about 1 degree. It is about 1 degree, medial opening about 2, lateral 5. So I think the knee is little tight. So I may resect, more of upper tibia. I have conservatively resected it, but I may go for, instead of 5.4, I might go for 6.4 or 7.4. Is that correct?
Okay.
So now, I think I will put couple of retraction pins, 2 millimeter K wire. Resident, come here in front.
So kinematic alignment.
No, I would aim to have a 0 degree. But if I aim at 0 degree and if I end up at 3, I am happy. But I don't want to start with 3 degree because if I end up with 6 or 7 degree, it is not acceptable.
Okay.
So I am just putting retraction pins.
That's the benefit.
One from here.
The mechanical if it is 3, then it's
Yeah, put it. Gentle. Yeah. Fantastic.
So putting
Wait.
pin for the retraction of the soft tissue in tibia.
Just to retract the soft tissues on the medial side, we are putting 3 pins. Put it from here. Wait. Wait. Yeah. Relax. And one from here. Aram se. Don't touch this. Take around. One more pin.
Sir, am I audible, sir?
Yes.
Sir, now we are putting pins, sir.
Yes.
To retract the soft tissue or any other purpose?
To retract the soft tissues.
Okay, sir. So it is your routine practice?
Yes.
Okay.
Now there are clamps to attach the robot to the patient, but I still use the pin, the Shyam pins to fix the robot to the patient.
Sir, can you guide us the pin positioning?
The one pin
femoral?
is through the medial femoral condyle.
No, sir. Array pin, sir.
Array
pin on
pins,
femoral and tibial.
Yeah, see this is tibia, about 8 finger breadths. I am a fat person, so my fingers are also fat. So 8 fingers down, anteromedial to posterolateral, touching the third cortex. Femur, about 6 to 8 fingers up. Especially in thin ladies, you can go up to 4 or 5 fingers also. Either they should be in the center or from the lateral to medial side. As I have discussed, they should not be transcortical. You need to have a vertical sort of 3 cortices purchase. Transcortical pins have a high chance of a stress fracture. Fortunately, till to date, as I speak, we never had one. But there is an incidence of about 1 to 1.5% stress fracture.
So these pins are in femur or unicortical, sir?
Not unicortical, just touching and engaging the third cortex, but not penetrating the opposite cortex.
If we put these pins in metaphyseal area, sir, so chances of stress rises will be less, I think.
That's correct. Some people, they put the femoral pins in the metaphyseal area, but sometimes they do come in the way of your robotic arm.
Yeah.
So light please. I am attaching the robot to the patient. 1 second. 15 number blade and forceps, come here. 1 minute, I'll just put the robotic pins and I'll explain. Marker please. Thank you. Come here, don't stretch your back. Knife, bigger knife, forceps. Forceps please.
Sir, what is location and exact site of the science pin, that robotic pin you put in the
lateral
femur?
femoral condyle.
Where it is
lateral epicondyle.
Distance from the medial and the lateral condyle, it is?
Yeah, lateral epicondyle.
Lateral epicondyle.
Lateral
And the tibial side?
Tibial
robotic?
side just below the patellar tendon.
Just below that.
Sir, robotic pins.
No, so just I am talking about the robotic that you.
That's correct. Yeah, I am putting the robotic pin.
Okay.
Sir, what is the purpose of this
To
pin?
stabilize the robot to the patient.
Okay, so we are going to stabilize the robot with the.
To attach the robot to the patient.
Okay.
That's fine. Aram se. Now be careful. Here there is a patellar tendon. You don't want to go through the retractor, please. You don't want to go through the patellar tendon. So what I will do, certain people go through the skin by a stab incision, but I will develop a plane between this skin flap. This is the tibial tuberosity. This is the patellar tendon. So I will go below the patellar tendon. Can you see that?
Yes, sir.
This is the tibial tuberosity, patellar tendon. I don't want to go through the patellar tendon. So I will develop this plane. Happy? So that I am safe. Yeah? I will go somewhere here. Can you see that?
Yes, sir.
Just below the patellar tendon, I am not lacerating the patellar tendon. Marking it. Your residents are keeping me correct and on my toes. So parallel to this.
And how many millimeters below the joint line, sir?
About 6 to 8 millimeters.
Yeah.
Yeah. So just confirm they are good, nice and stable. So let the robotic arm come now.
So sir, your approved CT planning, you have approved the physical planning of the console?
Yes.
And
What
you have
I will-
selected what robot is going to do?
Yes, now I will allow the robot. Fantastic. So I think let the camera go on the screen.
That is
So there is a top view and a side view. Top view, the top view green and the blue marks are seen. I will kindly ask the anesthetist to take the patient towards the ceiling. Can the table go up, please? So as the patient is going up, you can see those balls appearing on the side view. The blue and the green one, they should be on the fantastic. So I think we are happy. Can you focus on the screen? Everything should be either blue or green. Nothing should be red.
So patient is coming towards robot, sir, na?
Yeah, robot is coming from the lateral side of the patient.
Yeah.
So now they will attach the pins. Aram se, don't drop it. Okay, tighten it. Wait. Yeah. So I attach the robot to the patient. Everything looks good. So I'll have a final confirmation. So I am just validating the robot.
Sir, we are unable to see the robotic eye. Where is the infrared camera?
Hello? Sir, would you remove the osteophytes before
No.
attaching the robot? Or?
No. I will ask the robot just before removing starting the robots. Now at this stage I can remove the osteophytes, but I usually don't do that.
I think your robotic
later
arm
on
is moving, eh?
Yeah. So later on, if after the osteophytes are removed, probably that will add to the added ligament laxity.
Correct. Just hang on a minute for a couple of minutes. So again, final confirmation. I was mentioning in my lecture at this stage, once robot failed us actually, and I had to convert it into a conventional. Yes. Happy, Anmol? So we are ready for the femoral resection now. 1 second. Company person?
Sir, so we have fixed the femur and tibia with the stamen pins so that it...
See, usually I ask the company person to use suction as a retractor. Now there is no need for a femoral arrays, so we are covering the femoral arrays. Company person or me, I will use this suction as a retractor to protect the medial collateral ligament, to protect the patellar tendon also. Okay? What's your good name? Vinay, na? So we are starting with the resection now, the distal cut. Start.
Sir, so we have fixed the femur and tibia with the stamen pins so that it should not move during
Correct.
the surgery.
Correct. Irrigation. Please start the irrigation. 250 cc syringes. Irrigation is not there. Wait. Irrigation not coming. Saline, keep it ready, sister. Green needle. Irrigation happening? ए, तुम्हें हाथ लो थम्बा मेरे को एक गाउन और देना क्या एक गाउन और देना मेरे को आई थिंक यू टच्ड मी हाँ दैट्स फाइन नया बर है ना
Bone appears to be quite soft, sir. Dr. Sanjay. New bar is here.
Nibbler sister.
New bar is here. Distal cut is almost over.
Just wait. Now I will remove little bit of osteophyte with the nibblers as I go on.
So you have stopped the robot at this moment.
Yeah, we are stopping the robot, little bit of removing the osteophytes. So we have cut the distal cut. Now we'll go with the anterior cut.
Otherwise it can count all the cuts together.
Yes, yeah, anterior cut please. Or anterior chamfer, I'm sorry. See, as you can see, this robot will go down and cut. So that's why it is essential that these pins should be put distally. Otherwise they will come in the way. Can you see that?
Yeah.
Especially in thin females, this can be a problem. Can you see that?
Anterior cuts. Sample. Anterior sample.
इधर ध्यान दो. Very good. So I will just remove clear off little bit of osteophytes here, and then we'll go for the anterior cut. Lot of osteophytes are there. Anterior cut, please. Come. Vinod, na? Vinod Kumar. Vinay.
Sir, you are taking out osteophytes just for the demonstration, or in the regular practice you keep on taking out?
If there are a lot of osteophytes, it will increase my speed. Rather than robot cutting it, I might as well remove it. Just wait.
So without notching it is cutting, eh?
Yes. Hopefully I should not have notched. I will confirm in a minute.
So in between.
Yeah, we are good. Wait, Anmol. Yeah, we are not notched. Take my word for it. I think you can ask your residents.
That's okay, it's okay.
So no notching. We are good. Gentle. Superb. I'm just clearing little bit of tissue without damaging the MCL. So now we will go for the posterior chamfer. While taking the posterolateral chamfer, I think Mr. Vinay, he will be retracting the patellar tendon here. Posterior chamfer, please. Karo. Protect. So he is using this retractor as a MCL protection. Can you see that?
Yes, yes. Yeah.
Saline. Lateral side. Now wait, Anmol. See, before you cut the posterior condyles, I usually try to remove little bit of tibial spine. Nibbler, please. Because the tibial spine can sometimes come in the way of the robot. So if you do tibia first, this step is redundant. I'm just removing the tibial spine so that it doesn't come into the way when it is resecting the posterior condyles.
any distractor?
I have not used the distractor in this case actually. I could have used.
Okay.
Yeah. Start. Pani is ready. Water. Yeah, see, it is coming in the way.
It's fine.
Here the option is, if it keeps on coming in the way, Nikalo, I can do the tibia first and then go for the femur.
So in between we can change.
Yeah. Up. I'll just see. If it is coming again and again, I might as well do the tibia first.
Sir, so a pilot should always control autopilot.
Yes, 100%, as I was telling you.
So much of the bone dust while cutting this by robot, any harm or any bone in the soft tissue left after
I always use
lavage type.
Lavage, yes. Posterior, we'll try once, posterior, otherwise we'll go for the tibia. Cut, posterior condyles. No, I think we'll go with the tibia.
Still it is coming in the way.
Anmol,
Still coming.
we'll go with the
posterior
tibia.
condyle.
Yeah, marker.
If anything comes in contact, they will stop.
So all the time it will hamper the cut posterior condyle.
I could have used a
Tibial
distractor
spine.
actually, but at this point I don't want to use it now because since
So
we already
the
started.
tibial cut has to be the first, I think.
Yeah, some people can start tibial cut first.
Dr. Amit, tibial cut is the first or the femoral cut is first?
Yes.
While not robotic.
Anything you can do. You can cut the femur, you can cut the tibia first. No issue. It's the surgeon's choice.
Yes.
Okay, meaning there is just either way.
One second. One second.
Okay, right.
In robotic system.
Sure.
So in the conventional procedure and the robotic procedure, how much the time of the procedure that you'll compare, sir?
First 10 cases, just to be
Time
on
is rather important, I think.
yeah, first 10 cases we used to take about 20 minutes more.
Okay.
But later on, it is almost neutral.
Medial posterior condyle it is cutting. Tibial is cutting. Okay.
Radius ulnar spike, small spike. Just wait. Nibbler, please. I am a very slow surgeon, but I want to have accurate values and good alignment and thing for my patient.
That always slow and steady wins the race.
So as I have told you, patellar tendon is here. So I will try to use a spike to prevent the injury to the patellar tendon. Nibbler, please. Vinay, hold this. Thank you. Lots and lots of osteophytes are there. Hold this.
So have you dislocated the tibia anteriorly?
No. I have not.
Dislocation is not required in this case.
How you are very sure that you are cutting the tibia and the structures nearby are safe?
Yeah, because haptic boundary is there, robot will not go beyond the haptic boundary. Chal, cut lateral side.
During planning, segmentation has been done up to the bone only, not of the cartilage or any soft tissue.
Section do hath mein.
Yeah, only bone will touch, no cartilage. Both sides. 40.
This is cutting femur or tibia?
Tibia on lateral side.
Can the camera focus inside?
Can camera focus inside? I think by that time it will finish. Even this debris is coming, you cannot see. this debris is in software you have given the information of tibial bone, and that is all it is operating.
Sir, we are protecting MCL and LCL and patellar tendon during the surgery, but we are not protecting the posterior structures because we don't have access to that area and we are not subluxating the tibia. So is this burring is completely controlled, or is there any chances of posterior penetration of capsule as well?
Confirm.
Dr. Sanjay. Hello.
Yeah, 1 second, one second.
Okay.
I'll take a question. Suction check. See, the lateral tibial plateau is very sclerotic. That's why the burr had stopped. So that's a good feature. Any resistance it encounters or any soft tissue it will encounter, it will stop, which is actually a good thing.
Sir, my question is, we are protecting MCL and LCL and patellar tendon while burring, but we are not actively protecting posterior structures.
Correct. That's why while planning, I always keep a margin at the back.
So we have to leave the margin posteriorly as well?
Yes, I told you, instead of 5, I could have planned 4.
Okay.
But I don't want to go posteriorly because our friends are there. Yeah, start. Start, please.
It shows the cut area within the boundary only. But then when you are planning also, you can bring the implant further forward so that there is additional step.
Bone is very sclerotic.
Once the cut has been done, you will see that once the tibia subluxated, there will be a ledge of bone posteriorly and laterally. That has to be removed. Yes, nibbled or saw.
Fantastic. So we are done with the tibia. We'll go back to femur. Yeah, 1 second. 1 second. Keep it. Anmol, just wait for a minute.
There is a question.
Huh?
Is there any residual bone left on the posterior side?
Yes, I will show you once I dislocate the tibia.
So will you clear it by the
Saw.
nibbler
Nibbler or saw.
Yeah.
I will. I will, sir.
Okay. It is the regular practice.
Yeah, that's my regular practice. We have to register again, or we are okay, Anmol, posterior? Yeah, otherwise we'll register again.
Sir, so there is no intraoperative check or balancing now?
No,
in this system.
no. We can actually, no, once I cut everything, I'll put the trial implants and again check.
Yeah. Suppose the case of if a severe FFD, sir, and we have to do recut at the femur +2.
We can.
So after checking, we have to again reattach the robot to the femur, and then we have to cut, no, sir? Am I audible, sir?
No, I think robot is making a lot of noise. We can take the question after one or 2 minutes.
So that thing has to be taken into consideration in the pre-operative planning.
Yeah.
If you have a flexion deformity, then during the gap balancing, what we'll do, we'll keep the extension gap more than the flexion gap.
Lugs.
So suppose there's a flexion deformity of 10 degree, then I won't balance it at 8 and 8. My extension gap will be 10 and my flexion gap will be 8. So that sir, so sir, बात वही है ना, ultimately it's the surgeon who will decide. You have to take into consideration that there are osteophytes. Once you remove that osteophytes, automatically it will decompress a bit.
Box.
And accordingly you see that if the deformity, but in general we have seen that if there is a deformity of say 10 to 15 degree, and if we keep the extension gap 2 millimeter more than the flexion gap, and we remove the osteophytes, it comes straight.
We'll see. Nibbler.
One question, how this robot will help in the soft tissue balancing? No, it's not going to help the soft tissue. And the TKR itself, it is a soft tissue balancing surgery. How you define this?
Sir, so with robotic thing coming, there is a slight change in philosophy also, that now
we have been taught
some degree of
TKR
balance.
it is a soft tissue balancing
हाँ
surgery.
सर, वो था सर, अभी भी है कि TKR is a soft tissue surgery where implants are there. लेकिन सर nowadays you can do also a bit of balancing by changing a bit in the bony cuts. So the thing that the mechanical alignment 0 to 0 होना है, थोड़ा सा that has been challenged. It has been shown that if there is a malalignment of up to 3 degree, then that doesn't changes the longevity of the implant. So you can do a bit of correction in the bony cuts. You can keep them in a bit of virus so that the soft tissue releases are a bit less. It's a major
That
resection.
is a
thing.
major resection.
Yes.
Means it is just a change of the version with the time.
So
आराम से
mid path.
So ये निकालो, ये निकालने को दो. Come here, remove this. Carved osteotome, sister.
Now the biggest advantage of robot is that it prevents soft tissue injuries. we'll get to know what is the long-term outcome, but the biggest advantage now, it prevents soft tissue injuries, which is inadvertently, suppose you could have gone and injured the posterior soft tissue structure, inadvertently medial collateral ligament injury. That is not happening. That is the biggest advantage. And it follows the principle of measured resection, that you take the bone cuts rather than releasing the soft tissues. Over the period of whatever the surgeons have felt or the scientists have felt, more of soft tissue release leads to more of instability, and that leads to also more of post-operative pain and other complications. So rather than addressing soft tissues, you are correcting everything by doing a bone cuts.
Robotic means it is a bony version of the TK.
Yeah, that's I told you, gap balancing and measured resection. So it is a measured resection technique.
Measured resection. So the concept is just shifting from the soft tissue balancing.
You can tell it's a kinematic alignment.
This is a take
whatever
that is important.
Yeah.
That
sure. Can the camera come in? So we have
okay.
Nibbler. So see, we have calculated all the resections. These are the osteophytes which we are taking for the. See, there are always a rim of tissue. Can you see that on the medial side?
Yeah, we are seeing. Yeah.
Very nicely, there is a rim of tissue at the back of the femur also. Can you see that?
That you have to nibble out, yeah.
That's correct. I will take a curved osteotome and nibble it out. As I have told you, if I am not happy with the trial balance, I may take 2 mm more tibia. That can be done manually. So again, a concept of pilot
in case
and
of
autopilot.
FFT, there is a more than 20 degree of the FFT in the cases where we are doing posterior capsule release by periosteum or something like that. How this can be defined by the robot?
Because when I did a pre-operative pre-cut gap check, it would have shown me 20 degree flexion deformity. So I would have increased the distal femoral cut. Nibbler, please. Wait. Yeah. One second. Cautery. Curved osteotome. See, lateral joint line is opening quite well. Though it was a valgus knee to begin with, actually the structures on the medial side are tight. Osteotome. Hammer. Nibbler. So we appear to be okay on the femoral side, no notching. We are just clearing the posterior tissues. That's a popliteus. Curate, please. And artery, please. Yeah,
in case of bony ankylosis type of knee, how it is going to help?
Sorry? Artery?
Okay.
Nibbler?
That is easier by this robot. Okay.
See, there is a loose body here at the back, and a meniscus is also there.
So the varus valgus knee is a difficult.
See, Can you see the loose body?
Yes, yes, Dr. Sanjay.
Artery. Can I have another artery? Yeah. Take this. There's a medial meniscus also.
Posterior condyle preparation, we are unable to see by the camera.
Sorry. See, this is that's a meniscus, intact meniscus. So what I will do at this stage, now I will disengage all these things, remove the distractor, remove the pins, relax, remove this, remove the, ये निकाल दो, या ये निकाल दीजिए, के वायर निकाल दीजिए, and we will see the post cut balance and then appropriately release the tissues. Remove this. Sister Nibular. Some people don't do this step, but I think it is important to get a post-cut gap balance as well. Another pair of gloves, please. Gloves.
So you are going to check it?
Yes. Trial femur, artery. Yeah, just remove. No, don't remove the DMIO, just remove the foot attachment. Fantastic. Trial implant, left side F. Is that correct? Anmol? Fitting well. Can you appreciate that?
Yes, yes.
Absolutely fine?
Yes.
Okay. Posterior spike. Now I will subluxate the tibia or dislocate the tibia and see whether there is any bony rim.
On the tibial side?
On the tibial side, correct. Anesthetist table down, please. No. Table down. Maximum down. Very good. Patient has a very good height. Yeah. Can you appreciate that? See, there is a rim here. Lateral spike, please.
Yeah, but we are not able to see the top
view. Just see the top view.
Yes, yes.
See, there is a rim of bone left here. Can you see that?
Yes.
Can you see the rim?
Yeah, big. With the osteophyte also.
That's correct. So I will clear all that.
Yes, and medial tibial plateau is...
Yeah, medial tibial plateau also little bit of osteophyting is there.
And the condyle is still not bony.
Yeah, another radius ulnar spike. Thank you. We'll require a little bit of saw or a nibbler. So yeah, can you see that? On the lateral side as well, see there is a rim of bone.
Yes.
Can you appreciate that?
Yes, sir.
Yes, sir.
We appreciate your decision.
No, correct me if I am wrong. We are in a democracy, sir.
You have taken good steps, sir, to dislocate and clear out.
So little bit of saw, sister. I will not touch much medial laterally because I am happy on the lateral side. If at all we are touch tight, so I don't know.
On the medial side.
Medial side, that's correct.
Someone is asking, Dr. Sanjay is asking, can we increase the with tibial cut 1 mm more?
Yes, I may have to do that. That's a fantastic observation. I might have to do 2 mm more on the tibia, but we'll see. I'll go in a very stepwise manner. So that osteophyte gone.
Sir, my one question is here that while you are doing the tibial cut, so उसी समय उसको dislocate जो है करना क्या time consume हुआ? पहले करके उसको then you should have cut it.
Sorry?
No.
Sorry, I didn't get that.
Just you did the cut on the tibial side before dislocating the tibia. If it would have been done
While doing the dislocation.
Yeah.
Yeah, but I think if I dislocate, there will be too much of a movement. And this robot is very, very sensitive to the movement. Any excess movement, it will stop.
So, do you require dislocation in every case?
No.
Yeah, that is.
So there is a little bit of
So it
meniscus
is
there.
very difficult by robot also.
1 second.
Then you need to help the robot, nibbler and periosteum bone cutter. You
Just
need
remove
to
the femur.
continue.
Dr. Sanjay has taken a extra precaution for in planning itself to leave some bone.
Femur, extractor please. No. Always. See, there are lugs. Somebody is now giving me a hammer. That's a wrong way. Put the femur and bring, because if the lugs move, condyle will fracture. Yeah, डालो उधर. Remove it. So I just want to see the medial meniscus. I think there is a meniscus there, and there is a see. Can the camera come in? There is an osteophyte on the medial side. Can you see that white line?
Right, sir.
So I will get see all the motis. The pearls are coming out. So yeah, remove it. I think as an orthopedic surgeon, we can afford these pearls, not the real pearls for our wives. Curved osteotome. Lift it up.
ये femur है.
Yeah, very nicely it is coming. Can you see that?
Yes.
And the medial meniscus is also there. Cockers. Can you see the meniscus?
Yes, sir.
Cockers, please. So I think once I remove all this, I am reasonably sure the medial side will open up. Another soft loose body. Nibbler. Right angle. Sorry. Still some meniscus. I usually like to preserve a little bit of meniscus attached to the medial collateral ligament so that I am sure that I am not damaging the medial collateral ligament. So let's try. Nibbler.
Yes. Doctor, Vijay is asking too much release, it will disturb the balance.
No, I am just releasing the meniscus I am removing. Nothing else I have done.
Sir, since we are removing the meniscus along with the all osteophytes, so
I might put a 11 implant, but I doubt. I think even 9 will be tight. That's my gut feeling. Let's see.
Sir, my question is, sir, since we are releasing the soft tissues,
5-9.
we have. Sir, am I audible?
One second. One second in a minute. Yeah. Relax.
Still FFD is left.
Little bit. Yeah, I may increase the soap.
Sir, we are not able to see the screen, sir.
1 second.
focus on the screen. Yeah.
See, as you can see, I can show the screen is 10 plus 13, 10, 12 or 10, 13. 1 minute. So, Anmol, can you show 0 degree?
Yeah. Yeah, it's a complete extension is visible and
visible.
5 to 6 degree varus, 4.
Yeah, about 4 degree.
Yeah, yeah.
2 degree, 0 degree, about 4 degree. And when I flex,
It's 90.
1 second. 1 second, I think. So we are little tight, 8 and about 12. So I will little release on the medial side. See, this is the leg which is straight. Can you see from the top? Can you see from the top? See, lateral 12, I am happy with it. Medial, I would like 10. And extend flexion deformity of about 1 to 2 degrees. So I might now I use a saw and take little medial side more. Are you with me?
Sir, is there any flexion stiffness over there? What is the range of motion?
Yeah, see, this is the range of motion.
Flexion, sir.
Yeah, see this.
Yeah,
See this.
120.
Completely.
30.
He is bending. Can you see that?
Yes, sir.
Happy?
Sir.
So I will little release on the medial side. I may take little more on the medial condyle.
Yes, done.
Happy?
Happy, sir.
Happy, sir.
So I think Dr. Vijay is correct, but I think the lateral is already showing 12 to 13, so I don't want to touch the complete tibia. I might release medial side, or there is a bump I will show you. So with the saw we'll have to get that bump out.
Bump on the tibial condyle.
Dislocate. Posterior spike. Correct, na? This will bump, will remove. Dr. Singh, Vijay Singh and SK Singh, sir. See, can you appreciate this bump?
Yeah, tibial bump is there.
That bump is there. Yeah. So probably once I use a saw and get rid of that, only on the medial side, I will have 10, 12, 10, 12 on both the sides.
Yes, sir.
Lateral spike. And I think we should be okay. Here again I have one more option. Since it was showing 1 or 2 degrees of flexion deformity, I might give little slope.
Posterior slope.
Posterior slope.
Yes.
All the faculties agree with that?
Yes, sir.
Yes.
Any disagreement? Any disagreement, sir? I may give little posterior slope, sir.
Present planning was 3 degrees.
I'm slightly increasing the slope. So here the role of pilot comes in.
Yes.
Eyeballing posterior slope increasing.
No, only removing 1 millimeter, and we will check again. See, a good part about that, we can check again. Chalo, trial, nibbler.
Will you drill that dense part on the medial side?
Yeah, I think the saw is skiving off.
Yeah.
Implant. That's fine. We'll release in a minute. One second. So, lift it up. Lift up. Lift up. Now see, take a camera from the lateral side.
Yeah, 2-3 degree
Happy, sir?
hyperextension, yeah.
That's nice.
Happy, sir?
Yes.
Alignment.
Happy TKR.
Okay. So I think we'll convert in a normal way. so we can get locked off from view. And this is the range of motion. Patellar tracking, that's a manual patellar release with my hand, and that is the range of motion. That is the range of motion here.
You help the robot, I think, sir.
Sorry? Okay.
Very interesting.
Happy?
That is concluded.
You will
He
buy
helped
that?
the robot.
Yes, sir.
Sir, you will buy that?
Yes, surgeon assisted robotic surgeon.
Chalo. Thank you, sir.
Nice, sir.
Okay, sir. Thank you very much. Nicely concluded.
Thank you, sir.
Sir, happy? Ye nikalo.
I thank Dr. K.P. Agrawal,
Happy?
sir, and Dr. Anupam Bose for chairing the session.
ये निकालो.
So
चल
now
टिबिया prepare करने को दो.
we
Abhi
have
Swaraj, once the
another
cement
live
sets
surgery
in,
in the
we'll
same
release the
patient,
tool.
the right
एक second.
knee.
ये देखो. Happy?
So that is
not much opening. Not much opening
इसको हटा
here.
दो.
Not much opening here. We have increased the little slope. तो ये थोड़ा हाँ posterior slope ये क्या है ना है ना.
और इधर का ऑडियो भी ऑफ कर दो.
Perfect. चल.
हाँ उसको हटा दो. So this case, Dr. Sekhar Srivastav sir is going to operate, and before operating, as you all see, the good planning is what the robot is going to execute. So sir is going to take us through how he has planned his case. So this is the case. I request Dr. Sekhar Agrawal sir to come on the dais and present his planning to all of us. Thank you, sir.
Thank you. Respected Goel sir, Dr. Singh, Dr. Swaroop, and Dr. Mohanty, the Varanasi Orthopaedic Association and UP Orthopaedic Association. I am really glad and honored to be invited for this meeting, which is perhaps the first robotic meeting in the state of UP. This is the same patient and will be operating the right side. So I don't think there is any confusion that this patient is having varus knee. It has been proven in the last case. We'll just go through the planning and we'll take it as if I have received it just now. So that's how we start. You get the planning stage like this. This is the femoral head. You can see it in all the three planes. You can move it. If it is not in the center, you can move it accordingly so that it matches the circle and you get the center of the femur. You come to the condylar center. Now you can move the axial view to get to the center, and you can then compare it in all the three planes as well as the 3D images. Then comes the medial epicondyle. So there is this osteophytes. Now if you want to find the medial epicondyle here, you will be slightly confused where is it. So you just scroll it. You want the surgical, you want to have the surgical transepicondylar axis. So it is not over the most prominent part, but at the sulcus just beneath the medial epicondyle. So we mark it here. Not much confusion on the lateral side. It is the most prominent part. So we mark it on the axial cuts. Then you come to the posterior condyle. I will first mark it on the 3D images and then see that it is just at the edge. And then similarly on the lateral side. Now once you have marked the epicondyles and the posterior condyles, it will automatically give you transepicondylar axis in relation to the posterior condylar axis. Okay, so it is coming 2.8, which is usually equal to the 3 degree which we take in a normal varus knee. So it's similar to that. the medial distal condyle, again first mark on the 3D images. Maybe I can slightly alter it a bit. I want to take the most prominent part because it is in relation to this point the burr will be cutting. Again we have to take the most prominent part on the lateral femoral condyle. So once we have marked the axis and the bony landmarks, the software will automatically generate the implant. Okay. Now we have to see whether it is okay according to our planning or not. So this is showing that there is a distal medial resection depth of 9 mm. Can you see that image, last one? So the distal medial image is showing we are cutting around 9 mm. On the distal lateral we are cutting 12.2. Now we know that the thickness of the implant is usually 9 mm. So we want to bring it down. So I start bringing it down. I am distalizing my component. Approximately I keep it say 8.6. Okay. Now all this is preliminary planning. We are going to change everything during the surgery. Okay, to maintain the gap, to do the gap balancing. So we keep it at.
Why you plan 8.6?
So 9 कर देते हैं.
Yeah.
ठीक है. So let's keep it 9. No issues. And so when we are cutting 9 mm on the lateral side, on the medial side it is coming 5.8 to maintain the functional cut. Sorry, the mechanical alignment, to maintain the mechanical alignment. Now let's see the posteromedial and posterolateral. It's a varus knee, so I want to align my component properly to the posterolateral segment. Okay. Now size, it is showing size F. Size F may the thickness of the component is I think around 9.4, which we discussed in the previous case. Here we are cutting 9. So I think we can slightly anteriorize our component. So now the posterolateral is 9.4. Is it fine?
Yeah.
Sir, in a varus knee, there is a opening. Sometimes there is opening on the lateral side. So in a lateral femoral condyle, if we cut less than 9 mm, 8.5 is also okay.
So
as you are planning.
In a normal knee also there is slight opening on the lateral side. Okay. So we are okay. We are okay with that.
8.5 was also okay.
But we'll again see there is no flexion in the implant. The trans-epicondylar axis is 0 and in relation to posterior axis it is 2.8. Okay.
So what is this? No flexion?
That is implant is neither in flexion or extension. Okay.
As we increase the flexion, there will be
There
less
will be
flexion
decrease
gap,
in the
between
flexion gap.
Yeah.
So suppose I am increasing the flexion here.
Yeah.
Can you see that the implant is moving?
Yes, sir.
Now I have given a flexion of 2 degree here.
So that is the beauty of robotic surgery.
Yes.
That we can increase the flexion. If we feel the more flexion gap, we can increase it.
Yes.
But in a conventional method,
So
we cannot,
suppose
in a conventional method we cannot flex
Yes.
the component.
And you can do that without notching. If I simply bring it back to reduce the flexion gap, then it will lead to notching here. Okay. But what I can do, I can keep it in the same position and I can give flexion that will reduce the flexion gap but will not cause notching. So let's again bring it to 0 because our posterolateral gap has increased. We want it 9.4, so flexion gap is again 0. Distal lateral we are cutting 9, medial we are getting 5.8. Is it clear till now?
Yeah.
Now when we talk of robotic, we talk of personal fit, personalized fit. That means we want the implant to put in such a way that it matches the natural anatomy. Okay. So what we'll do, we'll again scroll it on the axial images. Now this is showing the implant. Okay. we all know that to have a good flexion, your posterior offset should match the natural knee. Okay, so I will just keep looking that this posterior offset is maintained. Okay, now so as we come down, see here is a part of osteophyte which is going to be removed. So on the lateral side it is almost matching that. On the mediolateral aspect, if we see
a little bit opening will be on lateral side. Considering
lateral side it is
opening.
overhanging.
Overhanging, okay.
In the notch.
Okay, so what we can do?
Lateralize.
No. We can rotate it a bit. Okay?
Yes, a little bit more. Yeah, it's okay.
So now it is matching on the lateral aspect as well as on the medial aspect. Okay?
Fine.
We are fine till then?
Yeah, fine.
Okay. Now, if we see on the mediolateral aspect, then there is a bit of overhang. But then that's the problem with everything, that you can have a personalized cut, but you don't have a personalized implant for every patient. Okay?
Lots of R&Ds is still going on the Western world for personalized implant.
Yeah. Now, as we will also be taking the box cut and lug holes through the robotic system, so I just want to see that my lug holes are in the center of the condyles. So this seems fine to me. As far as varus valgus is concerned, we are keeping it at 0 degree. So that completes the femoral part. Any questions, Dr. Shivam?
0 degree means 0 degree mechanical only.
0 degree mechanical.
Yeah.
But femoral anterior part is little overhanging.
Over anterior part overhanging means that you have to then again see. Just a minute. This one?
Yeah, in this axial section.
So what we can do, I feel that we can go one size smaller now. Let's take E.
Sir, 1 or 2 millimeter overhang is always safer.
Anyway,
you are always safer.
When we are doing robotic, we are talking about 1 millimeter. So let's take size E. Okay. And now so as I have taken size E, suddenly you will see that the posterolateral gap has increased. Okay. Now we have to correct that. There is overhanging as mentioned by Dr. Singh. So let's bring the implant back. Sorry. Okay. So what we can do, we can remove the implant and see how are the cuts. So it's fine till now. There is no notching. I can go a millimeter back again. Let's put back the implant. We can't go more posterior. So at this point, our posterolateral gap is 12.2 and we need around 9.4 to 9.6. Okay. So I'll give flexion to the implant. So now it has become 10.7. But now as I have given flexion, the anterior part has again become more anterior. So I can go back more. So we are 10.3 now. Let me again check. So there's notching. So we have to come. So if we take size E, then it is perhaps in the anteroposterior thing, it is slightly small. Okay. Here also you can see that we are not able to match the posterior offset. Okay. We can't go more posterior because that will cause notching, and here the posterior offset is not being maintained. So
if we increase the size, there will be overhang on medial lateral side.
Yes, there will be a slightly increase on the medial lateral here. Okay. So what we'll do, we stick to size F. On table we have an option to undersize a bit, okay, but we cannot upsize it. We can undersize it, we can't upsize it. So to be on the safer side, we will keep it size F.
Can we increase more flexion to decrease the flexion gap?
More flexion on the femoral
flexion
side?
Of the, yeah.
I think we keep it a limit of up to 2 degree.
Okay.
So that there is a margin of say 1 degree more, but more than 3 degrees is not desirable. Okay. So we come back to size F. Again distal lateral has increased, so we bring it down. We keep it 9 millimeter. Posterolateral we will have to again extend it so that it becomes 0. And maybe enterize it a bit. So now are we okay? Distal lateral we are cutting 9 millimeter. With the size F implant we will be cutting 9.4 millimeter of bone, which will be replaced by the implant. And let's just scroll it on the axial images. So on the, at least on the anteroposterior aspect, we are well aligned. Maybe there is a bit of overhang on the mediolateral aspect, but then that's the problem with the implant. We can't do it anything. So now we go to tibia. Now we have to put these points which will match with the, which will map on the body. Just make sure that you are not marking these points on the osteophytes. Tibia again, you mark the center, you mark the center of the ankle. Now if you want to take the keel as well as keel wings, then these 2 points have to be marked very accurately, tibial tuberosity and PCL fossa center. If you are just taking the flat surface and you are going to prepare the keel yourself, then you can put just anywhere on the tibial tuberosity, doesn't matter.
How to select the tibial posterior center, sir?
So tibial tuberosity.
No, tibial posterior center.
Tibial posterior center. नहीं सर, tibial posterior center तो इसमें नहीं है. PCL fossa center.
Yeah.
PCL fossa center you have to, so this is the PCL fossa.
Yeah.
You have to take it on the lateral aspect of the PCL fossa, not in the center, slightly lateral to the center.
Yeah.
Then medial condylar center. So then it gives the tibial component. Now here you can see that it is cutting 10.7 millimeter from the lateral tibial condyle. Now what Dr. Sanjay mentioned, that if you take size, if you keep it 10 on the tibial side, we have seen that it usually cuts 2 to 3 millimeter more. So what we again do, we will move the tibial component up. that it is around 6. So that will cut 9 millimeter from the lateral tibial condyle. So if we are maintaining the mechanical alignment on the tibia also, then we'll be cutting just 1.4 millimeter from the medial side because there is a defect there. We are doing PS knee, so we'll keep a posterior slope of around 5 degree. Okay. Now we are going to prepare keel ourselves. So this rotation internal external doesn't matter, but this is important because I want to keep the implant within the bony limits. I don't want my bird to go beyond the bony limits. So I am rotating it, and maybe I'll also decrease the size of the tibia. So that my implant is within the bone.
Up to what degree sir internal rotation acceptable?
Doesn't matter. हम तो सर केवल सरफेस कट ले रहे हैं ना बस, बाकी तो हम अपना ही करेंगे. So it doesn't matter. So now my implant is within the bony cut. We can also see what will be the what will be the track of the burr. Okay. So this light blue thing is telling that how much our burr is going to cut in the bone. So we know that some bone will be left posteriorly and laterally, which we'll have to remove. Varus valgus, we are not giving any varus or valgus. We are going for mechanical alignment. But if we see the X-ray, this patient is having a lot of varus deformity. On table, if there is any problem in balancing, then maybe we can give it 1 or 2 degree of varus. Again, we have to match these corresponding points on the body. That's the summary of our final planning. So we are aiming for a mechanical alignment. These are the cuts on the femoral side. These are the cuts on the tibial side, and how much is the resection depth and the sizes, everything will come there. So this is a static plan. Now when we do our surgery, we'll do the gap balancing, then there may be some changes in the plan, and then accordingly we'll go ahead.
Sir, in planning, we have left the residual bone on the lateral tibial condyle.
Sir.
We cannot plan such that we should take out by the robot itself.
Sir, I think the most important concern in fully active robot is damage to soft tissue structures, and that's why this is designed in such a way that always when you take the cuts, the burr is coming from the anteromedial aspect. So there will always be bone on the posterior and the lateral aspect to be on the safer side.
Thank you, sir. Thank you.
Sir.
When it is resting on the cancellous bone. When you reduce the size of the implant.
No, sir. We have reduced the size just for the purpose of taking the cuts so that our burr doesn't go beyond the margin. But when we take the implant, we remove that part of the bone and we'll take the appropriate size implant only.
That
So
time
I
you
have
may increase
yes,
the size
yes.
of
So
the
I have
implant,
taken
yeah.
perhaps size 4 here, but on table I will size it again and I'll see that it sits on the cortical bone. Yes, sir.
So it may be size 5.
It probably will be size 5, sir.
Okay.
Fine. So
चेंज करो पीपीटी अप करो लाइट तो भी चल रहा है आ जाओ हाँ आ रहा है दो बार हाँ आई होप कि दिस टाइम इट शुड नॉट स्टॉप आप थोड़ा तो चेंज करो बार बार टोन्स को हाँ जी पहले चल जाए तब तो बुलाओ So to chair the session, I call Dr. Sanjay Yadav. Please come on the stage and chair the session, sir.
Now, quick summary again back to the case. 77-year-old female, severe varus and FFD. And preoperative gait we have all seen. And it's a complex primary, severe varus 35 degree, FFD 10 degree. Surgical challenges, restoration of mechanical axis, soft tissue balancing and use of minimum constraint implant. This already we have discussed. So I did this case with the Velis robotic assisted device, and that is a real-time navigation with robotic arm. So this was my initial leg alignment before all releases, before removing the osteophyte. As I have already told that around 35 degree varus was there. So it's showing 26 degree varus at 90 degree flexion, and we can see there is a lateral opening of 10.5 on 0 degree as well as at 90 degree, but medially it was quite tight. It was 3 millimeter in flexion and minus 2.5 in flexion. So there was a medial tightness, as it was expected that it was a complex primary varus. So this was the initial leg alignment. During the surgery, when I removed all osteophyte and did some medial release, because medial release was expected as it was a complex case, I could achieve 10.5 laterally and 11.5 laterally, and medially 3 mm release I could find. So medially, posteromedial it was 6, and medially still it is 0. And to put the implant, we require at least 8 or 9 mm on medial side. So then I removed all the osteophyte. I downsized the tibia and lateralized the tibial component, and this was my pre-operative planning, intraoperative planning that I can play with on table. That is the beauty of real-time navigation. During the surgery, as before, I have already asked her how much minimum cut, -2 or -4. So there was an answer from the floor that it should be -2, means 7 mm. But in intraoperative planning, I could go with the 6 mm on medial side, and 6 mm on lateral side and 0 mm on medial side. That was my intraoperative planning. 4 degree posterior slope and 0 degree varus. On femoral side, I could achieve proper balance by 2 degree varus. That is the beauty of kinematic alignment. Because if we have to put the implant inside, we need to have some varus along with all releases. So I have to accept 2 degree varus and 5 degree flexion deformity, flexion component to fill the flexion gap, and 0.5 degree anterior cut. So on femoral side, 7.5 and 7 mm on distal, and 5 and 10.5 on posterior. So this was the intraoperative planning. In intraoperative planning, I have to accept 2 degree varus on tibia and femur, and downsize the tibia, lateralize the tibia and femur in 5 degree external rotation. So this was final leg alignment after the surgery. It was 1 to 1.5 on lateral side and 0 to 0.5 on medial side. This was my final alignment. And this was the post-operative X-ray. Any comment? Anupam sir? This was the post-operative X-ray. Sir, I am doing all valgus, varus, FFD for past 12 years. For such a complex primary of varus of 35-40 degree is not an easy case to do with simple basic primary knee. We have to keep all our implants as a backup, and on table you have, in a conventional method, on table we have to take a repeated judgment during opening, balancing and cuts. So that is the beauty of real-time navigation, that on table we can change the plan, we can rotate the femoral component, we can flex the femoral component. So this was my post-op X-ray, and this was second post-operative day. Patient was made to stand. I did this case just 7-8 days back. So one last slide, the advantages of robotic assisted device. It is a compact on-table mounted device. It is a saw blade system. It is a real time based, and workflow is very simple, and it is always under the control of surgeon, always. And one literature that image-free robotic assisted total knee orthoplasty always improves the implant alignment accuracy on cadaver. Still the long-term and mid-term results are still pending, but at present we have to rely on these graphs as well as the literatures. Thank you, sir. Any question?
Dr. Sanjay Yadav, do you want to ask any question?
Very nicely done case, very complicated case made easy by the support of technology.
Thank you, sir.
Thank you, sir.
So, as requested by Dr. Swaroop, may I call upon Dr. D Tripathi, sir, for his case presentation. PCL in total knee arthroplasty, whether to retain it or substitute.
Thank you, Mr. Chairman. I bring the greetings from city of Allahabad to you all. Prayagraj. I'm thankful to Professor S. Goel, Dr. Mohanty, and organizers Dr. S.K. Singh, Dr. Swaroop for giving me this opportunity. Friends, the CR knee is becoming popular day by day, and in every meeting there is a debate between the PS and CR knees. So there are a lot of advantages of the CR knee, and whether we all should shift towards the CR or not, That is what I am going to see in this few minutes. So, to PCL in the total knee arthroplasty, whether to retain or to substitute, the PCL function of PCL is it is posterior stent for the tibial translation, and it is secondary stent to the tibial external rotation, varus and valgus angulation, and mediolateral displacement. The controversy of PS and CR knees has been as old as the advent of total knee arthroplasty, and it is still going on. In the early days, there was two processes. The one was the duopatellar. It was PCL retaining. It has flat topography. It has 100 degree of flexion. On the other side, it is a total condylar which has PCL sacrificing, and it has dissagitated topography and giving a less degree of flexion. So the controversy remains towards the range of motion, phenomena of rollback, stability of the knee, correction of deformity, gait analysis, stresses of the bone processes interface, and polywear along with the proprioception. There are three types of surgeons. If you see the worldwide, many of the exclusively CR surgeons, many of them are exclusively PS surgeons, and few of them are selective in the cruciate retaining. The advantage of CR knees are the processes can be less constrained, less force is imparted at the interface, it achieves greater range of mobility, preserves the joint line at the near normal, retains collateral ligament kinetics, and preservation of intercondylar bone stock is there. And the most important is there is a good proprioception in the knee. The problem with the CR knee are it has late anterior posterior instability because of the laxity of PCL later on, needs more frequent lateral release for the patellar tracking, and it has late posterior wear. On the other side, the PS knee, the forces that are normally supported by this ligament must be taken care of by the secondary soft tissue stabilizing structures and implant itself. The PS knee can be done almost each and every case, even in the revision arthroplasty, while the CR knees in the only early osteoarthritis, if a patient is very less deformity. The advantages of the PS knee are it is more forgiving, it is easier to correct severe deformities, modern designs, they have the control rollback and the better range of motion. So that is the PS knee has given more equally good result with the CR knee. Coming to the proprioception of the knee and PCL, I think this is the only point that PCL retaining processes CR knees conferred a statistically significant greater improvement in the proprioception than the PS knee. That is the sole advantage of CR knees. The range of motion, there is no advantage in the range of motion in the PCL retaining or sacrificing. PS or CR have the same range of motion. Video देखा? Can you run the video? वीडियो नहीं I think you can see the PSD, the good stability with the full range of motion. Excellent. Even you cannot get with the CR knees. The stability of the these knees, the PCL retention, the CR knees contact points close to the center of the tibial plastic surface, while the PS knees contact point move to the anterior to the plastic. So there is no difference in the stability of the knee. Here you can see the PS knee very stable, the stability in the rising from the chair and sitting, good stability in the PS knee. Deformity correction PCL in the varus or valgus knee more than 20 degree, you have to sacrifice the PCL. In the severe flexion deformity again up to more than 40 degrees, you need to sacrifice the PCL. So in these cases, very few surgeons they still can do the CR knee, but it is quite difficult to retain the PCL in these patients. Gait and PCL. There is no study has demonstrated any advantage with respect to gait with the retention of PCL, the CR knees. Here you can see the very natural gait of the PS knee, rising of the stairs, getting down of the stairs, very natural gait. So it's not that PS knees have not very natural gait. The stresses and wear. The Swedish registry said that the well-performed total knee arthroplasty with either PCL retention or sacrifice have equivalent survival rate in the future. What does the literature say? There is strong evidence support that no difference in the functional outcome of complications between PS and CR arthroplasty design. NICE guidelines, they also say that there is these differences are clinically not relevant. The Southeast Asian countries, they also say that does not affect post-operative range of motion or functional outcome. Swedish knee registry, there is no statistically significant relevant difference in the complications are detected. What does the Cochrane review say? It says that functional and clinical basis on which to choose whether or not to retain or the PCL during total knee arthroplasty surgery remained unclear. So CR knee, I think it looks that we retain the processes and we get the good progression, but by and large I think we can go ahead with our PS knees as well. So we need not to turn into the CR knee, all the total knee arthroplasty. So to conclude, PCL sacrifice and substituting, excellent track record. The PS knee has excellent track record, excellent long-term results, excellent equal knee movement and stability, and excellent gait performance. So take home is that substitute the PCL as a natural step, because we all get very difficult primary cases. It's not that we get the very earliest stage of osteoarthritis for the surgery. So I think it is we must remove the PCL for the ease of surgery in each and every case. Thank you. Thanks a lot for your patient hearing.
Very nice. There's one thing I would like to add on, the PCL in a young age, if you are intending for the knee replacement surgery, so it should be saved in the younger age.
If not in the younger, even in the elderly patient, if the deformity is very less, like there is no varus 5 degree, 3 degree, 2 degree varus deformity, you can, if you can save, then you must save it. But what we get that very difficult cases, when patient comes to us, it is all deformed with the flexion and various deformities. If possible, you can you must.
Why you are doing in younger age?
Suppose there is a younger age, the patient is having some trauma, having some secondary degenerative changes in the plateau fracture.
Younger age, we do younger age in rheumatoid like cases where ligament is already damaged. So there is no point. Why you are doing younger age? Younger age reconstructive procedure should be done. That is the dictum. You should not do in younger age. But there are indications like rheumatoid where ligament is already damaged. So what is the point in saving it? That is my take. And how young? You mean young by which young you are talking about?
Not in even in elderly patient, if you are doing CRNA, you could retain the PCL. It gives stability and it gives, I think, better proprioception. But in the
you said just now there is no difference.
It's no, only proprioception. Only in the proprioception. Otherwise, there is no difference. Proprioception is better. That is they found it out.
So
feel better.
There is studies also which claims that getting up from sitting posture is better in CR designs.
I've shown you the clinical results getting from the chair, and it, even in the PSC it's quite good. And patient is even doing the squatting and cross-leg sitting, but it's not allowed. But patient are doing with the PSC because now they have the good cam and the good cam mechanism is there. Yeah.
So relying on two ligaments like as such, there are many studies which suggest PCL thickness is equivalent or is more than the MCL. We are dissecting the PCL in most of our surgeries to rely on MCL and LCL, which are much weaker ligament as compared to PCL, and we are relying on CAM.
Hello, Sanjay sir.
Even in Western worlds and Western European countries, all
Sanjay
are
sir.
switching gradually to PCL retaining designs rather than PS
Hello.
designs. The registry data we have shown is of 5 years earlier. Current data, they are more inclined towards CR design.
You can release the PCL a little bit. It's not completely excised. You can release and.
These days, sir, we have ultra congruent polys or deep dish polish, which we can use it with retaining the PCL as well. That will give additional support rather than relying on the cam.
Yeah. Thank you, sir.
There are two different philosophies. Both the knees are doing well as of now. Both PCL retaining and sacrificing, both are doing well. PCL retaining knees are little bit. PCL retaining knees are little bit more, technically demanding. To balance the PCL against the deformities, little bit more demanding. And as sir told Tripathi sir that posterior cruciate substituting design is more forgiving. Okay, it is easier to more forgiving. Most of the surgeons in India that are trained by Dr. Ranawat, and Dr. Ranawat does all posterior cruciate substituting. Now question is that bone preserving and bone sacrificing. Whenever you are revising a cruciate retaining knee and posterior cruciate substituting knee, usually you go for a more constant knee, either TC3 or LCCK or whatever. Revising a posterior cruciate retaining knee to a posterior cruciate substituting design is extremely rare, because you have to take out the implant, you have to take out all the cement, everything, there will be bone loss and you require a constant implant. So TC3, so that psychological barrier that revising a posterior cruciate retaining knee and doing a substituting design only, it doesn't stand good. Even that too in unicondylar knee. People tell unicondylar more bone preserving. Very, very rarely unicondylar knee, when you revise it to again a TC3 or a LCCK knee rather than revising it to a posterior cruciate substituting design. So these are the surgeries, their entities are themselves only. It's not that it is isolated that this is one and next step is posterior cruciate retaining, unicondylar knee, next is posterior cruciate retaining, next is posterior cruciate substituting. It is not like that what is projected in the lectures, or people project it like that. They are in the surgery entity, they have got their own indications. as Dr. Tripathi rightly pointed out, what are the indications of cruciate retaining knee? Very less deformity, you know, maybe a deformity which is very less. There is not much of flexion deformity. Suppose 30-40 degree of flexion deformity, you have to go for a posterior cruciate substituting design. Severe varus deformity, which you showed that case, their posterior cruciate retaining will be difficult. You have to sacrifice the cruciate. So in this kind of deformity, which most of our patients, almost in India, patients come at that stage only. Their posterior cruciate substitution is more important. And only in J&J design, that PFC, the box cut is much more, where we are worried about, where the sizes, size 1, size 2, where you are using the femur. There this is difficult, that it takes a lot of box cut, and that may lead to intraoperative medial or lateral condylar fracture, especially medial condylar fracture, if you are not little careful. Those cases it takes a lot of intercondylar box cut. So in those cases other knees are available, like their active knees are available, you can use active knees. In those cases persona knees, all these are, they take out less of box cut, so their posterior cruciate substitute designs are available. And as you told that after sacrificing posterior cruciate, you can, if you feel like, you can use ultra congruent insert, which will act like a posterior cruciate rollback mechanism. It will help. Ultra congruent or deep disc inserts, which can be used instead of flat on curved designs.
Vision of the UKR. We are unable to do the posterior substituting knee. We are always going to TC.
Not always.
No.
Most of the time.
Most of the time.
Most of the time.
What is the reason, sir?
That is because you have to build up that bone defect there. Okay. See, whenever you are going to, there is a tibial cut you have taken, there is a femoral and tibial bone loss. Yeah. When you take it out along with the cement, there is definitely the bone loss is there. So whenever there is so much of bone loss, then in order to take the cuts and balance that, you require a constant implant on the table. Most of the time. Very, very rarely people, so I have seen only until one case where the unicondylar knee, which has been revised to a posterior cruciate substituting design. If it is early failure, then fine. That is not much of osteolysis, not much of bone loss, then early failure, then there you have revised. But early failure, then it doesn't mean anything, no. Suppose the patient is failing with aseptic loosening beyond 5 years, 10 years, whatever. That time there will be a lot of osteolysis and all these things, then the knee will, there will be a lot of bone loss. Medial side, but then you have to balance on the lateral side, you have to take that much amount of, you have to use augments. If you are not using, then you have to use augment. Whenever you are using augments, you have to use S-time extender, naturally you come to a constant in design.
So according to you, there is a very limited indication for UKR.
No, not limited indication. Properly indicated cases, it is doing well. Properly indicated cases. Those indications are very less in our country.
Thank you, sir. Thank you so much.
Thank you, sir. And I think we are ready in the OT. OT, can you hear us? Dr. Sekhar Srivastav, sir?
Yes, sir.
Sir, can you hear us?
Yes, sir.
Dr. Sekhar, sir, is there?
No, sir. सर तैयारी हो रही है सर, बस 5 मिनट में.
You can see the robot arm that is orienting itself in 3D space. Sekhar sir, can you hear us?
Yes, I can hear you.
Okay,
can
sir.
you hear me?
Yeah, sir, we can.
Okay.
No, it is not compulsory. You can ask, sir. Sir, there is a question to you.
Yes.
Tourniquet is mandatory in all the cases, or you can do without tourniquet also?
We can do without. In
We
fact,
can do
what
without.
we will do, अभी छोड़ दो. We'll start without tourniquet, and we'll inflate the tourniquet once we have taken the cuts. Okay. Okay. So there is no flexion deformity. There is varus which is correctable.
Dr. Vipin, you'll moderate this session.
सिस्टम लगाए थे? अपने तरीके से करेंगे.
Hello. Meanwhile, while we are taking off with the session, Dr. Amit and Dr. Swarup, you opted for a particular system, and Dr. Swarup, you opted for a particular system. What made you arrive at those decisions? What bigger advantage does your system have? You had both the options.
साउंड दे दो. मुझे भी सुनाई दे. जा रहा है ठीक.
Now, is there?
बस ठीक. इसको थोड़ा सा ये करो यार ये.
We have surgeons using two systems, and you have used both of them. So what do you feel is good about which system and where has it an undisputed advantage?
Pins पर ही डाल देते हैं. It will save us some time.
Honest answer, see, both the systems have very good advantages and disadvantages. Image-based system, as I have shown, cysts or
Marking pen.
osteophytes and preoperative planning, not much of stress during the operation. Whereas Velis, their pins are very thin. The pins
Pen नहीं चल रहा है.
in the metaphysis in the femur, and the tibia also, one pin through the incision, another pin
ले रहा है?
below that. Pins are very, very small and low profile. Their arrays are fantastic. Their arrays are
ये यूज करते हैं. पिछले केस में यूज किए थे इसको और ड्रिप यूज किए थे. ऐसे छोड़ दे, कोई बात नहीं. ये यूज करते हैं. हाँ. मार्किंग पेन दे रहे हो? नहीं नहीं तो ये दे. चल ये दे दो. चल ये वो दे जो यूज किए थे. अंदर से डाल दे. मार्कर मुश्किल है. ऊपर ले ला.
Certain of my colleagues, a couple of early cases, there was notching on the patient itself, and you see on the confirm it on the screen. So if you suppose, see this is the
so on table we are getting a punishment for our mistakes.
So it's garbage in, garbage out during the operation. Here at least we have the we can show it to some other colleague 2 days before in the image based system. So there couple of times there was a notching, and during that stressful moment you have to adjust rotations and everything. So that is because and the haptic boundary is not there. There you have to hold a saw. Actually very smartly Johnson people have given saw in your hand because we are used to holding a saw in our hand. You have to just press the button. The saw will cut whatever saw it wants to cut. But there is no stop. In Miko, there is a haptic boundary. In US, there is a haptic boundary. That is, you have to be so you can go along with the saw.
Sir, but you have to stop always. Once you press the button, then only saw will move. If you release the press button, the saw. Second thing, what you are saying, intraoperative stress, that I don't find on table.
Right.
For initially, for few cases, definitely, for first 5 to 10 cases, there was definitely a little bit stress. But once you get used to the technology, that stress reduces to lesser extent. One more good advantage that on table you can navigate and you can change the plan. If you feel that I had made this plan, and once I remove the meniscus and osteophyte, and my medial opening is 1 or 2 mm gaining, so we can change the plan. We can change the component, femoral component. So that is also. And third, sir, that pin positioning, even putting the pins in the diaphysis, there is a chances that it will cause a stress fracture. And if you're putting the pin in a metaphysis, it will chance of less. So there is a less post-operative stress as well. So both the technologies are good. Some certain positive points are over there and certain. And one more thing, sir, in this system we are leaving posterior condyle of the tibia unburred or uncut. But on Velis system we can put the retractors, we can subluxate the tibia anteriorly, and we cut the whole tibia in a single go. So both the systems are good, but certain advantages are here and certain over there.
What he says is absolutely right. In the Velis system, once you move they have that robot check or gap check, you move from extension to 90 degree, and you get a parallel lines or curve. Now we were getting values of 10, 12, which is acceptable for 9, 11, 9 is the and in flexion it was 15, 16. So we were not sure why it is 15, 16 or 17, 18 in flexion. Actually,
size of the femur you have to add on.
Instead of 6, it was sizing 5. So once we figured out that it is not big to the actual again, our own surgeon conventional, we matched the content and we saw it is actual 6, and we corrected on the computer.
उसका तो हिलाते नहीं है. हिलाने में जो ढीला पड़ जाता है.
That was the initial training part. That computer always says
less than one size femur, you have to just press a button 6 in place of 5, and so both are different types of plane, and you have to tune yourself on such type of planes.
But the size of the pins are very small, so I think tourists can also take a view from that. Pins are very, very low.
Okay. Can we start? I don't find any problem in the purchase of the pins, sir, because all the time we are putting a bicortical. Since I am putting the intraoperative inside the incision, so we have to purchase both cortex. Close to the joint. Yeah.
Dr. Sekhar.
Yes. So now debate is over. Now we are not going to debate versus vallis versus pubis. We will debate robotic versus non-robotic in next session. Deep knife.
I think every big hospital probably will have two systems down the line. I can foresee that, because one group of surgeons. But every big hospital, we were the first, then Bijlani came, then Uttam Garg came, then lot of other hospitals purchased, and every hospital will have two systems.
One more difference is there that suppose in this system, if you are planning for a bone grafting, then you have to do some certain manual cut to have a bone. But in vallis, you can cut, you will have lots of bone on table. But in burr system, it will burn completely. Yes.
Hello?
Yes, can you hear me?
Yes, a little louder.
यहाँ से mic का volume बढ़ा दो. Okay. Can you hear me now?
Yes, sir.
Okay. So we are going with standard medial parapatellar approach. We have put the pins beforehand. Now we have the option of putting the pins from inside the wound also, and in fact in our hospital we put it here on the medial side, but they are telling me that it's a slightly different kind of robo and it is coming from a different direction, so I'm not taking any chance. The tibial pin is of course outside the wound. We'll prepare the patella beforehand. Nibbler. Saw. इससे बड़ा निबलर चाहिए. So निबलर. तो क्या नाम है? हाँ, चंदन. आप डॉक्टर मनोज सिंह. आप लोगों ने उस साइड कराया था ना, सेम वैसे ही करना. So we are not going to replace the patella. Okay, nibbler. Start करना इसको. Do the initial release. Not extensive. Oman. Where's the camera? आप इधर से दिखाओगे ज़्यादा अच्छा दिखा पाओगे. Are you getting a good view?
Yes.
I'm just getting the camera angle changed so that we can get a better view.
Sir, from medial side, I think we can get a better view. This is vision is getting obscured from this side.
Yeah. He's just setting up the camera. एक ही कैमरा है ना? Okay. First it on.
Now it's better.
So the deep MCL is being released, and then we'll. Okay. Pin. Array. बहुत पतली पिन नहीं है ये. क्यों? हटा निकाल लो वो. One more pin. So these are the retractors for the medial soft tissue sleeve. Open it. सामने सट जाइए. ठीक है, ये तो ठीक है. So we are just aligning the array so that they are visible to our tracker.
Dr. Srivastav,
yes,
you can explain about the patient and your approach and pinning everything.
So it was a standard medial parapatellar approach. Okay.
Yeah.
Can you see the knee joint?
Yes, yes.
So we haven't removed any osteophyte.
Yes.
We have prepared the patella.
Yeah.
We have just released the deep part of the MCL. We have put these pins as retractors, and these are the pins for the array. Now, can you show on the screen? That screen. Can you see the screen?
Yes. X-ray is visible.
Yes. So there are two dots, blue and green. The blue one is for the femur.
Okay.
The green one is for the tibia. I am moving the knee throughout the range to see that these dots are visible during the range of motion, both in flexion as well as extension. Okay?
Okay.
Now we'll start registering the points. There are 40 points in the femur and 40 in the tibia. Start. We are starting with the femur. Yes, go. 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 Yes.
So this sequence is mandatory here.
Yes. Okay. So you can see our RMSE is 4.5. दिखाना back एक बार. Yes. चलो कोई बात नहीं. It's okay. It's okay. Back नहीं करना.
It should be less than 10. Anything less than 10 root mean square error, you are okay. And then you
1, 2,
the RMSE should be less than 1.
3,
but there are a lot of osteophytes.
4,
so you can accept up to 1.2 to 1.3 root mean square error.
Go. Go. Yes. 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 Okay. Okay. Yes. 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 Collect. Yes. Go. Yes. Yes. Again, yes. Go. 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 Collect. 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 Go. Go. One, two, three, 4, 5, 6, 7, 8, 9, 10. So you can see that the final RMSE is 1.01. So I'm going to accept that. Okay. 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 So the femur mapping is over. Let's come to tibia. Collect. 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 We'll do it again. It is coming more than 10.
Yeah. But Dr. Srivastav, there are a lot of osteophytes, so
Yeah.
I think maybe up to even final RMSE up to 1.2 is acceptable actually.
Yeah. Yes, collect. 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 So it is still coming in orange. We'll continue with that.
Yeah, I think you are fine,
Yeah.
sir. 10.07.
Yeah. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. One, 2, 3.
Suppose if your point
4,
is not correct, na, it will show
5,
it will show red. It will show red.
6.
Yeah, and it is showing now where the points he has to mark.
1, 2, 3, 4, 5, 6. 1.
See, now recollect the point. Can you see that? Red aa gaya, so you have to recollect.
1, 2, 3. Go. 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 Go.
40 points, correct.
Yes.
Here,
Go.
here there are points. Other system you
Go.
have to paint. Just
Yes.
graph it.
Yes. Yes. So the final RMSE is 0.85.
Yeah, it's very good. 0.85. Yes.
Okay.
See Here the distance should be less than 1.
Yes.
Root means square error.
Yes.
That means your patient's anatomy is matching with the CT scan morphed model.
Okay, so now we'll be doing the gap check. But what I'll do, I'll just remove these osteophytes now before we do the gap check. You have to be very careful that you don't remove osteotomy. If you remove these osteophytes beforehand, then it will be a problem. Straight osteotomy. चौड़ा नहीं है नहीं दूसरा दो यार चौड़े वाला दो चलो वही दे दो कर्व दे दो especially the medial ones. Nibbler. Okay, सामने से हट जाओ. So at 90 degree the lateral gap is 11, capture. Capture. Okay. So I am just looking at the lateral figures right now. Okay.
Yeah.
On the lateral side you can see that it is almost balanced. The extension gap is 10, flexion gap is 11, but that gap seems to be too high. So what I'll do, I'll put my tibial implant a bit higher. Come to the tibial implant. एक मिनट स्क्रीन पे दिखा रहे हो ना? हाँ. Tibial shift. Proximal 1 mm up. एक और कर दो. Okay.
So you want a 9 mm laterally in both
Yes.
flexion extension?
Yes.
Okay.
So let's see again. Extension, capture. So it is 9 in extension. At 90 degree, capture is 9 in flexion. But see, if you see the max figure, it is showing 11 and 13. That means the ligament has the capacity to stretch up to 11 and 13. Tibial component up. Tibial shift. एक up कर दो और. So I'll settle for a gap of 8. Finish.
At this point, will you give a valgus stress and see whether the medial side is opening up?
Okay. Extension. एक
Yeah,
minute.
osteophyte मिटने का तो आ जाएगा. Reduction osteotomy.
No, it's not showing.
He's just adjusting just now. He's doing before the
Uh,
robotic cut. I usually do after the robotic cut.
Dr. Sanjay.
Yes.
So we'll stick with this plan right now.
Yeah, I think you want to put a 9mm poly. That's why probably
Yes.
your upsize means your proximalize the tibia,
I think
and you are settling for 8.
I may be putting size 11 also.
11, yes.
But let's see. We'll keep it at 8 now.
Correct.
Okay. Okay. Bas theek hai.
And I think there is a suggestion from the audience that once you remove the medial osteophyte, probably you will put a smaller tibial base plate.
Maybe we will have to do reduction
Reduction
osteotomy also.
osteotomy, correct.
Yes. Now, I have the advantage of seeing this patient's surgery before, as Dr. Sanjay was doing. So I will take this precaution beforehand. I will remove this tibial spine, yeah. So
nowadays you use distractor or you don't use?
No, I don't use. I don't use it. Do you use?
No. Unless the patient is very overweight and I cannot access the posterior part.
Okay. Okay. रोबो लेते आओ.
So you also don't use the clamps, now you use the pins to attach the robot to the patient.
Yeah. I find it more sturdy.
Yeah, that's correct.
Knife. So you feel the head of the fibula, the tibial tuberosity, and you go in between.
So Dr. Srivastav is using a separate stab incision. I usually develop a plane below the
artery.
tibial tendon, patellar tendon, sorry.
चलो लाओ देते हैं रोबो. Osteotome. So we are all set for Mr. Robo now.
See, that's why I don't do
वहाँ
this.
स्क्रीन दिखाते रहो.
I develop a plane through the incision and just below the patellar tendon I go through the incision. Yeah, little blind.
इसको ना इधर से ले लो नहीं तो नहीं इसको घुमा दे पूरा.
So see, there are RZ,
और अब इधर घुमा.
RX and RY. RZ is the robotic approach. RX, if you are getting a red thing, you adjust the flexion extension. RY, if you are getting a red thing, you adjust the rotation, and it will come.
सामने
Correct. And tibia. See, they need not be parallel because those clamps, they have very good play, 360 degree. But if you put parallel, it is easy for the robot to come and get attached to there. They need not be parallel. Little bit here and there, it's okay. Absolutely no problem. See, external fixator हम कैसे भी डाल देते हैं, तो adjust होता ही है. So those two balls, the green and the blue should be on either side of the midline.
Okay.
That means the positioning of the robot is correct and it's ready to go.
So you have to see that there are no red dots, no red markings.
Yes, Dr. Srivastav, I was just explaining that. See, the
Yeah.
RZ is sometimes coming red. That means the
Yeah.
robotic approach, the operator has to change.
Yeah. वो कर दिया मैंने, छोड़ दो कोई बात, leave it. So check again that everything is fine.
Sorry. See this RZ.
Yeah.
This RZ, this view top. This view is these two
Okay.
points should be in the center. That means top view and side view. Yeah, correct. The patient is there. Patient should be in a mid block. Mid block, correct. That's correct. So I think Dr. CJ Thakkar used to famously say, a fool with a tool is still a fool. So you need to be always alert. Sorry.
Okay. Okay. So we are all set.
Yes. So you are using a PS implant or CR implant?
PS implant. I use PS implant only. Yeah. So this time we are going to show you the screen, which will show that the burr remains within the boundary and doesn't go beyond it.
See, this is the boundary. This is the boundary in which the burr will move.
हाँ इसको ज़रा नीचे कर दो हाँ Don't tell me उसको साफ करना है
So, see, these are the values. Distal medial 5.8, distal lateral 9, posterior medial 9.7, posterior lateral 9.4. It's cutting. Usually for varus knee, I keep this about 1.5
Start.
to 2 millimeter more. But again, individual, more. Yeah. Correct. Rotations. Correct. And outside.
ऐसे करना कि वो दिखता रहे ना बीच में यहाँ पे मत आओ
So as you can see, in our subject,
पानी वहाँ पर नहीं जा देख के पीछे रख फीमर की तरफ रख एक यहाँ भी रखना पड़ेगा
sudden opening of
हो जाएगा So you can see that the burr is moving within this boundary only.
Yes, very nicely.
So the burr is coming from the medial aspect. So on the medial aspect there won't be bony ledge, but on the lateral aspect you will always have this bony ledge.
Correct. Medial side he has already retracted with the pins, so he is okay. Laterally he is keeping the bony, that's why he has planned like that.
So that's the distal cut. आप continue करो, continue. Don't stop. Next we'll take anterior chamfer cut.
Yes. Yes. a saw, hospital doesn't charge for a saw. If you use a saw even for a minute, they will charge 3,000 rupees.
Now we go for anterior cut. कोई बात नहीं.
People who are doing subvastus approach, especially when you are cutting the anterior cut, be careful. I don't do subvastus. Some of my colleagues they do. There is a possibility of a damage to the muscle. So you need to retract it for this step. People who are doing a subvastus. No, you can. One of my colleague he does subvastus and keeps the patella on the lateral side. That's okay. Yeah, not necessary. One of my colleague is a subvastus CR, patella in the lateral side, no drain, and subcuticular stitches. No tourniquet he uses.
Go. The posterior chamfer and then the posterior cuts.
Yes. If you are a PS surgeon, you are getting that notch cut. उसका बोध है. फिर उससे ज़्यादा मिलता है तो शैम्पर आप खुद दो. तो इम्प्लांट डाल के. ये 2 मिनट का स्पीड है.
आप बोन पे फोकस कर दोगे? यहाँ बोन पे दिखाओ. थोड़ा सा साइड हो जाओ. Okay. So we haven't put any retractors on the medial side.
Yes.
एक artery.
So you also put these 3 pins on the medial
Dr.
side.
Sanjay.
Yes.
Pause. Can you hear me?
Yes, yes, we can.
Okay. So we have cut this much of the posterior condyle. And
Correct.
this is the osteophyte. Now that has to be removed manually.
Correct.
Okay. Now even if you are doing conventional, then also your saw comes like that.
Yes.
And that part has to be removed. Resume.
Sorry. No, but he was correct, but he was tight, na inflection on medial side. So this will have, he's cutting 9.7.
पीछे ले ले. बोन निकालना पड़ेगा. Recovery.
He may have to go for 11. That's what he said.
Okay, start. So as it tunnels through the bone,
Yes.
so we don't require, presently I can see from this position that we don't require any retractors on the lateral side also.
See, that's what he removed the tibial spine first only. He has already removed.
So that completes the posterior thing.
Yes.
Now when it's taking the lug holes, then I'm quite careful that it's in the center of the condyle. There have been couple of occasions where we thought that the lug holes are very lateral. So at that time we stopped it, but now it seems central.
At this step, that medial retraction pin, if your assistant puts it little anteriorly, the burr may hit that
And
pin.
now it will take the box cut. दिख रहा है? ये बीच में तो नहीं आ रहा है? थोड़ा साइड बीच में जाकर.
I think we are able to see properly, sir.
छोड़ दे, वो हटा दे.
This graph we will always get.
आ रहा है बॉक्स कट? दिख रहा है यहाँ पे?
Yes, we are able to see, sir.
Yeah. Nibbler. Sometimes this bone comes in between. Okay, resume. And then the trochlear cut. So that completes the femoral cuts. Probe. Tibia. तो इसमें लेना नहीं था फिर से, तो लेना तो होगा ही. ओके. ओके. एक मिनट निबलर दिखाना दो. Start.
There is a bone. Like a protection. Femoral posterior bundle already cut.
ये अगर हम अभी करना चाहें, हम और कटलेस बढ़ा सकते हैं टीबिया में. So, Dr. Sanjay. Dr. Sanjay?
Yes.
Pause.
Yes, Dr. Srivastav.
So at this point, what I feel that maybe our tibial cut is a bit less.
Okay, so you want to increase the tibial cut?
And you know what's the problem?
Hmm.
Like in our system, if we take the tibial cut as 5,
Okay.
it was perhaps cutting 7 or 8.
Correct.
But I think this system is quite accurate.
All right, okay.
So if we are taking 5, it is cutting 5 only.
So you can increase the cut.
So I will take perhaps 2 millimeter down.
Okay.
Okay. So we again go back to
Yes.
tibia.
Nothing. See, I
Shift.
was encountering a problem to cut
No,
the
shift.
posterior condyle. So I went to tibia. I completed the tibia and came back to femur.
बस ठीक है एक ही रखते
You
हैं
can do tibia first.
है ना ज़्यादा नहीं करते हैं फिर
Absolutely no
हाँ,
problem.
ठीक है गो
ठीक सर. It was okay.
confirm okay probe
2 मिनट ज़्यादा कर. He's feeling that space is less.
okay इसको पीछे रहना पड़ेगा आम आ रहा है
खाली इम्प्लांट के टाइम चढ़ा देता था तो टेंशन ही नहीं किसको बट वी हैव सबमिटेड दैट पेपर आल्सो
ठीक हो
आफ्टर 10 to 12 cases your OT staff everything your assistants time saved
okay okay चलो
So I think you have increased it to 6.6 on the lateral side.
Yeah.
So most probably it will cut about 9 or if it is accurate about 7.
About
and
7
then,
or 8.
And
Yeah.
7 to 8 and then reduction osteotomy and
Yes.
removal of that osteophyte.
Yes, that
so
will do that.
you might be good for 9 or 11.
Yeah. That's the plan.
You can cut tibia first, no problem. In fact, one of my colleagues, he is a CR surgeon, subvascus, no drain, he cuts the tibia first. No problem. Tibia first. You can do with tibia first. No, you can do tibia first. Absolutely no problem.
ठीक है गैप है ना कंपनी है हो जाना चाहिए so again as you can see when it was cutting on the medial aspect it was going from medial to lateral.
Correct.
But when it is coming on the lateral aspect it is going from anterior to posterior.
Correct.
So you don't require any additional retraction. Sometimes the patella come in between, so you have to put a human retractor.
Yeah, I am little paranoid. I always keep a radius ulna spike on the lateral side, just to be on safer side. happy with that 1 degree of friction. So I slightly increase the slope with the saw. Correct. Slightly more slope. Little less. Little relax. Correct. वो ज़्यादा कट नहीं करते हैं
So that completes the tibial cut.
Yes.
We'll take out the robo. We'll keep the array.
Yeah, you also do a post gap check and everything because some of the surgeons they don't do actually.
Yeah. लेग होल्डर हटा देंगे लेकिन एरे लगे रहेंगे.
Yes. Yeah, because see, he's still keeping the arrays because then he has a, if he is not still happy, he may release more tissues or remove the bone from the posterior side and then balance it again.
ये पे निकालने को दे दो. टेबल का हाइट नीचे कर दीजिए. रिवर्स कैसे करना है?
Initially, I was very hesitant for osteoporotic bones, but I think touch wood till to date we never had any iatrogenic fracture because I think the burr cuts very precisely. Initially, we were very hesitant about the osteoporotic bones using this burr, you know.
अभी आपको जगह देते हैं. एक नीचे शीट चेंज कर दो.
The haptic boundary is there. Burr will not go on me. It won't go on me. So now, Dr. Srivastav, you will remove all the osteophytes and put a trial implants and again check the gap.
Yes, we'll do that. ये पिंस भी निकाल दो. एक होमन. अरे विनय तो यहाँ पे आ जाओ. So now you have to do the standard thing now.
Yes.
Central osteotome hammer.
Yes. You already planned T and transepicondylar and posterior condylar axis. Posterior osteophyte निकाल रहे हैं. उन्होंने दिखाया ना काटने के टाइम.
ओके, कोई बात. सेंट्रल वो दे देना. निकालते में निकालते हैं.
Into TC3. कभी ऐसा नहीं है, TC3 का जरूरत नहीं है, खाली
Okay, now enabler.
Normally we can with the augmented stem, correct? I think चल रहा है, दिख रहा है बराबर. Can you, Dr. Srivastav, can the camera come from the top?
Okay.
Fantastic. So you have removed the posterolateral osteophyte and the lateral osteophyte from the lateral femoral condyle.
Yes. Now, can you see this?
Yes, very well.
So what happens? The burr goes inside that. It
Correct.
tunnels through the bone.
Correct.
Okay.
And protective tissue is still there, bone
Yes.
is there. So
Yes. And this is the bone which is behind.
Correct.
That you have to remove. Now saw. एक यहाँ पे भी होमन दे दो.
Correct.
Now this patient is having gross varus deformity, so we may have to release a bit of soft tissue.
Yeah.
I will remove this. So, undersizing of the tibia ensures that we don't go into the soft tissue.
Correct.
And as was discussed by Professor Goel and Dr. Mohanty, that we'll remove this bone. The sizing will be according to the native bone. The actual size of the implant.
Correct.
We'll size it again and put it on the cortical bone. But during planning, we have undersized the tibia so that we don't go into the soft tissues.
Correct.
Okay. Okay.
Yeah, but not necessarily, but you don't want to go
Now.
posteriorly on this.
Tibia.
So very nicely popliteal tendon is also seen and
Yeah.
it is nicely protected.
So this whole thing is osteophyte.
Yeah, anteromedial osteophyte as well as the posterior osteophyte you have removed, posteromedial.
Yeah.
I think the gap looks good, sir. Actually,
Yeah.
you may get away without releasing any tissue.
Let's see. Nine.
So this
4.
is size 4 you are going to put?
This is size, this was size 5, but I'm going to try size 4.
Size 4, correct.
Yes.
So that you can remove the medial bump that.
Yes, yes.
And I think F implant marries with 4, na?
Yeah. Okay, pin. So size 4 seems fine.
Yes. And you can do the reduction osteotomy and then remove
Yeah.
that medial side.
Yeah, double.
That's why you can, but usually majority of the surgeons they don't use the burr for the kill. Last में ये अपने हाथ में रखते हैं.
हाँ? एक वो देना. Forceps. वो दो. Hammer. Drill. Saw.
Yes. You can go ahead. He is not checking, but you can.
So sometimes there is a very hard sclerotic bone on the medial side, and
Yes.
if you just use a broach, sometimes it may fracture the medial condyle.
Yes, very important point,
So-
Dr. Srivastav. I have burnt my fingers. I have fractured 2 tibia myself. So this is a standard procedure of using a saw and sort of
Yeah.
making sure that it goes completely.
Yeah.
Kill.
Sanjay.
Yes.
This is applicable even for non-robotic.
I know. I have created complication myself, you know.
नहीं एक चौड़ा ऑस्टियोटोम बस दे दो.
So 4.4 and 6.5 millimeter half threaded cannulated cancerous screw is a mandatory thing during knee replacement.
लाओ 100. एक और यहाँ भी लगा लो जस्ट एज ए रिट्रैक्टर. Osteotome. Okay, pin remover. निकालो. नहीं ये रहेगा. ये निकालो. फीमर लिफ्ट करो जरा. हाँ लिफ्ट. उठा. So we have to remove the osteophyte, nibbler. So that's the medial meniscus. Can you see that?
Translation and rotation.
Let me feel inside. That seems nice.
Yes.
On the left.
I think your fingers are going easily on both the sides, so I think you should be fine.
Osteotome. Curate. Again, this is a standard procedure. Whether you are doing robotic or non-robotic, the posterior osteophytes have to be removed. Seems fine. Seems fine. Injection लगाना है क्या? नहीं.
No, they don't give periarticular.
Okay,
actually, I also asked it.
Okay. ठीक है.
Posterior capsule.
Okay, इसको दिखा. So the gap seems to be okay to me. We'll put the implant and see.
Yes.
Femoral implant trial.
Bupivacaine, cefuroxime, then your clonidine. I put steroid also in non-diabetics.
यार इसको छोड़ो, निकाल के दे मेरे हाथ में दे. इसको निकालने के लिए दिया का, डालने के लिए नहीं.
Yeah, looks fine. It has
Yes.
gone well. No notching.
I have always noticed that if you are doing robotic surgery, the implant sits very well.
Perfect. Yes.
Perfectly.
No struggle.
Yeah.
Yes. इधर जरूरत ही नहीं है.
9.
I think you will be fine, sir.
Okay. Left. हट जाओ. सामने से हट जाओ.
I think the screen needs to be shown.
Tibia.
We are not getting the.
उसको ठीक करो.
Okay, now it's clear.
So clinically, to me, it seems fine.
Yeah.
But we need to validate it. उसको घुमाना पड़ेगा. OTS.
I think the tibia implant is not seen. You may have to just adjust the camera.
Yes,
sir.
yes.
Yeah. Yeah, perfect.
Okay.
13, 12, I think you are all right. Perfect. Nine and 12, 10, 12. Yeah.
Okay.
Lateral should be little lax, which you are. Very nice. And limb alignment 0 to 1 degree of valgus.
Okay.
Yeah, perfect.
I think I'm going to try 11.
11 should be
Yes.
fine because it's showing 11,
Yeah.
11 actually.
इसको पकड़ो. I'll do a bit of release and I'm going to put 11. ला दिखाना. तब से ऐसे ही चले जाएगा.
सर 11 डाल के lateral side से दिखा देना ऑडियंस के लिए.
Okay. छोड़ दो. निकालो. Lateral side किधर से?
From the align means there is no flexion deformity.
अच्छा अच्छा.
Actual patient.
यहाँ जरा साइड से दिखाओ. ये पैर.
Okay. So
So
you are happy with 11 or you are happy with 9?
No, 11.
Okay.
11 is fine.
Tracking is good.
Tracking is good.
Yes. No
So-
touch technique to the patella. Yes.
So
Fantastic.
this will be our final implant.
And polo test is negative. No
Yeah.
pull off, no lift off.
No, no.
Very nice, sir. So hardly you have touched any tissue in severe varus also.
Yeah. We'll remove a bit of synovium here. Implant निकालो.
So Dr. Srivastav, thank you very much. We are taking the other leg.
Thank you, sir.
Fantastic demonstration, sir.
Wonderful, sir. Thank you so much. Dr. Sarup.
प्लांटेशन करने जा रहे हैं. We will have inauguration. तो प्लेट लेके आ जाओ फटाफट कराओ ना यार. किसके इनॉग्रेशन के बाद करना चाहते हैं? ठीक है वो भी कर सकते सर. इनॉग्रेट करके फिर कर लेते हैं. 10 मिनट लगेगा. majority लोग आएंगे. हाँ सर नहीं आ पाएंगे.
थिएटर में मेरा पेन ड्राइव का बॉक्स रह गया उधर काला.
मैं अभी मंगा देता हूँ.
सर का
I hope the lunch was good. So now the feedback is very important, sir. Now we will proceed with the inaugural ceremony. So I would request our VOA President, Dr. Amit Jaiswal, sir, to please come in front. I request our President-elect, UPOA, Dr. D Tripathi, sir. I request Dr. Sanjay Londhe, our guest. I request Professor Dr. S.S. Mohanty, sir. Dr. Sekhar Srivastav is still in OT. So we request our VOA Varanasi Orthopaedic Association Secretary, Dr. Shivam Sinha. I request our pattern, Professor S.C. Goel, sir. I request Dr. S.K. Singh, sir. I request Dr. Amit Jha. I request all the dignitaries to light the lamp. I request our VOA President-elect Dr. Karmaraj Singh also to come on the stage, sir. हाँ आएगा नहीं अरे कोई बात नहीं आप लोग फोटोग्राफ कर लीजिए कोई दिक्कत नहीं सर जस्ट फोटो खींचने का जमाना है I request our President-elect UPOA Dr. D Tripathi sir to bless the occasion and say a few words of encouragement to us.
Thank you so much, Dr. S.K. Singh and Dr. Sarup for giving me another opportunity to be here in the city of Kashi, the oldest and the smartest city on the planet. It is really a very vibrant city as regards the political and scientific activities are concerned. It is a Vidyapeeth with the convention of excellent academics, teachings and learning. And due to this enlightened atmosphere, the young orthopedic surgeons here are doing far more distinguished work than anywhere else, which makes we all proud. Today, we all are gathered here to celebrate another advancement of medical science. When I was a student of class 10 and preparing for the essay on the science, I found a quote, "Science can be a good servant of mankind, but may prove a bad master if not embraced properly." Robotic surgery and the artificial intelligence is latest feather in the cap of medical fraternity. Friends, let me tell you that surgeon's intelligence is far more superior than the artificial intelligence, as you all are genius and original. However, robots can be one of the best and finest assistant in the surgeon's armamentarium, but to keep it as proud and valuable assistant, you need to be very skilled and experienced surgeon like surgeons of the Apex and Oriana are. With these words, on behalf of UPOA, I congratulate you all for having a state-of-art facilities of the joint replacement and wish you a great success of this endeavor. Thank you so much for everything. Long live UPOA, long live VOA and long live IOA. Thank you, thanks a lot.
So I would like to call to moderate the session Dr. Amit Jaiswal boss and Dr. Shivam Sinha boss to chair the session. We have two interesting case presentation, and to present the first case we have very our own dynamic Dr. Unmesh Chakravarti boss. So I request Dr. Unmesh to come on the dais, please. सर कौन से नाम से? हाँ वो कर चुके हैं। इसकी बात क्या है? हाँ हाँ
Good afternoon, everyone. Thank you so much. It's been a wonderful day, seeing a lot of interesting robotic surgery. So initially I thought about presenting a complex primary, but then I just found this in my folders. So can I have the presentation on? So it's a case, 11-year-old TKR done, and he's a 78-year-old person with bilateral knee replacement done. Left is doing well. He has pain in the right knee, and otherwise he's a fit person, mild hypertension controlled, mild diabetes controlled, no major comorbidities, and he is now unable to walk. So let's start interacting. How we proceed from here? Let's start with Vijay. Vijay, how would you like to approach the case?
So it looks that the both tibial base plate as well as femur is loosened. I will like to rule out infection in this case first, and preferably will get a CT as well, because on the medial side, the medial femur condyle also there seems to be lysis or fracture. Get a CT. And
okay, so two concerns: infection number one, and number two, bone stock. So two important concerns. Sir, no history of trauma. Gradual progressive onset of pain and instability in the last 6 to 8 months.
He was okay for 10 years.
Yeah, he was doing very well for 10 years. Yeah. More than 10 years. I think he was operated at Gangaram by Dr. Nagi. So,
any
doing well.
Significant clinical examination?
78, yeah. Pardon me?
Clinical examination.
Clinically, knee is soft, supple, no induration, no firmness, fair range of movement. Instability is there, varus thrust is there, and unable to weight bear. Looks more like instability and pain combined. Yeah.
Stability is your anteroposterior or mediolateral?
Both. Rotational, partially rotational also. Yes, sir. Yeah.
Fracture in the medial condyle of the femur.
Yeah.
And seeing the misplaced tibial component.
Yeah.
But there is no loosening all around. So even 78-year patient with osteoporotic bone, even trivial trauma sometimes
yes,
leads to
can
this.
come. Yeah,
So
yeah.
is there any trivial trauma also?
No,
No.
no. He just says that progressively the pain has been increasing. So I think it's a combination, can go hand in hand because the component is loosening, there is mobility, microfractures, osteoporosis loosening. Mohanty sir, with your vast experience, what would you like to add?
No, nothing to add. As Vijay rightly told, first you have to rule out infection. Looks like a aseptic loosening of both the components, and since the medial condyle is fractured, so after you take out the implant, everything, the medial collateral ligament most likely will be deficient in this case, and when medial collateral ligament is deficient, then you have to straightforward go for a hinge knee. In this, of course, you have to keep a constant knee like TC3 or LCCK on the table, but final assessment of the bone stock will be done after taking out the implants. Though CT may guide you, but the final assessment is always on the table, that after taking out the implant, how much bone stock is remaining. So it look at a hinge knee along with sleeves you have to keep for the on the femoral side as well as on the tibial side.
So I think the third point which has come up is that we need to be prepared with sleeves and hinges, probably rotating hinges, and be prepared for reconstruction of the medial sleeve if MCL is incompetent. Any more investigation, imaging anybody would like? Anupam boss is there? Sir, Goel sir would say anything at this point would like to add? Okay. Anybody would like to add anything from here? Any more imaging? Aspirate, yeah. So infection was ruled out, blood, CRP, SED rates, they were all normal. Aspirate was normal. Anything else to pick up any investigation to pick up infection, because sometimes CRP can be spurious, aspirates can be not very clear. So what
Posterior soft tissue shadow is abnormal. Posterior soft tissue shadow is abnormal. So we must go for the MRI also.
Okay, so what would that tell us about?
Disproportionate soft tissue shadow we are seeing in the posterior side. See the lateral X-ray. That shows that something maybe on malignancy or some infection with collection. Yeah, like that. Yeah.
Bone scan. Yeah, Vinay.
Earlier.
So you mean cell counts of the aspirate, sugar levels of the aspirate, protein levels of the aspirate. Yeah, so those are the basic tests in the aspirate.
And synovial fluid CRP.
Synovial fluid CRP.
Morning we discussed
so
about the case.
Are you doing other synovial tests, like we have the Zimmer kit for picking up infection, like
Synovasure? No, Synovasure is very expensive. So we do leukocyte esterase, take that stick,
use
and
the
synovial fluid CRP.
So I think leukocyte esterase is a cheap test. The cards is available because all the urologists are using the esterase card for UTIs. So we can use the aspirate and do a leukocyte esterase, though it is not very specific, but it is sensitive. It is quite sensitive. So rest assured, infection was ruled out. So some more X-rays were done. Okay. So that's the So that's the status of the patella. So we did not talk about the patella here. So happy with the patella, we retain it, we change it, tracking well, and we can see the component. So the patella would be retained.
If it is on the table, you find well fixed, and that particular company implants are there, then you can keep it. Now, if you are using different company, of course, you have to change the patella.
But if the patella is stable in this case and well fixed, do we change it?
I don't change it.
If it is stable, well fixed, but after doing a revision, it is mal-tracking.
Then you don't change the patella. You have to do
correct
the
other
things.
All right.
Correct the patella.
Okay. All right. So further X-rays just to see the entire femur. That's the canal shaft, no deformity. The tibia, the shaft, no major deformity. And the component, if you see in the lateral view of it, it's almost like the posterior component of tibia is gone. So extreme flexion. So probably that is why the AP views were looking bad, because the entire posterior tibia is gone. So anybody would like to add anything? Dr. Sanjay, you would like to add something? Okay.
So we are trying to confirm between loosening is definitely there.
Yes. Infection has been ruled out.
Whether it is septic or aseptic.
Yeah.
More
Okay.
likely we are facing the aseptic loosening, probably because of after 10 years it's probably the polyuria.
Correct.
Age of supers.
So I think previously immediate intra-op infection, the cutoff was 6 months. Now it has been extended to 2 years, if I'm not wrong. So any infection within 6 months was previously called intra-op initial infection. Now it has been stretched to 2 years. Any infection till 2 years, but this is 10 years down the line, so that's fine. So what about confirmation of infection intra-op? Frozen sections. Anybody does frozen sections?
Yeah, frozen section can be done. I do frozen sections.
You do, yeah.
Yeah.
Okay. So
but you should have a good pathologist who is ready with the stuff, so that within 15-20 minutes they keep the
so
result.
for 5 quadrant?
We sent from the most inflamed part of the synovium is sent.
Intramedullary?
Most inflamed is the granulation tissue, that is the thing.
Do you send intramedullary also? Intramedullary from femur tibia?
Unless I suspect it, I don't send it.
Alright. So
Because pre-operatively, suppose everything is negative, aspiration including everything negative. Intraoperatively, only if you suspect that there is some localized granulations or anything suspicious, then that part of tissue has to be sent.
Alright. So we thought on those lines and proceeded to proceed the same way. So that was the status. The tibial component is very loose. So again, we took the femoral component out. That was the femoral component like, and it's a PS kind of a femur, and that's the amount of bone which came out, and the tibial component also came out. So from here the plan was doing a rotating hinge, and one more thing, you see the femur. Yes sir.
Intraoperative backside,
yeah.
So the femoral component with sufficient bone stuck adhered to the implant.
Yeah.
So is it a failure at the implant cement junction, cement bone junction, or bone to bone junction?
After
No, he taken out by hand.
No, it did not come out by hand. We had to use, tibia was loose, it came out by hand.
Okay.
It had debonded at the implant and cement interface. You can see that the implant, the femoral component was well stuck. So we had to use sequential osteotomes, thin osteotomes, and gradually take it off. Yeah. So the plan was doing because the MCL, the condyle was pretty much intact. There was a sleeve of the middle femoral bone with the MCL. So we planned to fix that up with anchors and screws, and to stabilize we used a RHK. It's a rotating platform with a hinge knee with sleeves to compensate for the bone loss on the tibial side, and a small sleeve for the femoral side to add on to the stability. So getting a zone 1, zone 2 and zone 3 fixation, because zone 1 was not very stable. So that's what it was done. So you can see screw with washer with the condyle and anchors to pull the MCL back, and primarily the RHK to take care of the stability. The joint line has gone up, the patella is low. So ideally the femoral component should have come further down to get the joint line normalized. So that's what it was like, and these are long term. I think it's a 1 year post-op X-ray. Thank you, sir.
Very nice, very nice. So, Dr. Karmaraj, we request you to present your interesting knee arthroplasty. Dr. Karmaraj. You ready with your case?
screen kar do. Very good afternoon. We've been bombarded with cases and a lot of teaching academics. So I've taken up a few small cases, not small, they're big in themselves, for a rapid fire, so we can quickly enumerate. There are a lot of things have been talked about: instability, robotics, approaches, and so far. This was a 60-year-old female who came with pain and swelling after 6 years following a TKR. Inflammatory markers were normal, joint aspirate was negative, the X-ray showed a subsidence, asymmetric there too, and extensive lysis around the tibial prosthesis and the femoral prosthesis. Now, as we look at this X-ray, the immediate concern is, having ruled out infection, what are the things that we have to look for? We want a balanced knee, we want a proper fitting prosthesis back, and how do we achieve all that? And what should be the level of constraint that we might need to use? These are the questions that pop up, and as we think, we have to again delve on the aspect of the zone fix, zone 3 to 1, which is a diaphysis, metaphysis, epiphysis. We have to see where we can secure the prosthesis and how we get it. So what we did with a full revision was considered to reconstruct the bone defects and achieve secure fixation. Zone 2 fixation, metaphyseal sleeve in zone 2, stem in zone 3 was utilized. The sleeves also provided a secure reconstruction. The joint line having been established, this gave us a balanced flexion and extension. And so this is what we achieved here. Now, same kind of scenario again is here, where an 85-year-old male came 10 years after TKR, and what we saw, there was gross laxity, subsidence and lysis. Again, the same parameters were addressed, inflammatory markers were ruled out, and again the same kind of question came up: what should we do here to regain proper implantation of the prosthesis and to gain a stable knee? Here, the options that we had was whether to revise it completely, or just whether sleeves should be used or porous cones should be used, or arthrodesis would be an option. But since the patient insisted for an active life and for an active, he had choices for an active lifestyle, he didn't want to go on arthrodesis. So in this case, reconstruction was used utilizing sleeves, and we got again the ligament balance. Cones and sleeves have their own indications where they would be used. Cones being better because they get integrated into the bone, so that way they are better. So this is what we did for this patient. In the last case is a periprosthetic fracture, which was a supracondylar type 2 displaced distal femur fracture, periprosthetic, as I said. And the options that we would have, either given the age of the patient, whether we do actually need to do something, or if we don't do anything, with the morbidity enhance, and would it be would union be possible? So all those things had to be considered. So the options were either we don't do anything, we just give up slab or a knee brace, or we do an open reduction internal fixation, or we do a complete reconstruction considering a distal femoral replacement too as well. Now there is an algorithm for this, which for supracondylar femur fractures, which talks about displaced and undisplaced fractures, and then according to the bone quality it is subdivided, for which the various indications are there. What was done here, given the age of the patient, the requirements and the non-united status, it was converted to a rotating hinge, sleeves were utilized, and immediate full weight bearing was allowed. So these were some of the cases that we took up. Basically what I have stressed on is the concept of subsidence and loosening of implants and what options we have in the market. We have the level of constraints that we all know. The simplest thing is the posterior stabilized. Then we have CCKs, we have TC3, and as was mentioned in the talk, very little constraint is provided by the curved inserts, tibial inserts, which has been mentioned. Now, if there are any questions or as you wish. Okay, take it. Thank you so much.
Thank you, Dr. Karmaraj. Now may I invite Dr. S.S. Mohanty sir to deliver his lecture on knee orthoplasty. Looks good, feels bad, his understanding.
Your vast experience, sir.
Actually, I have no, it is not a debate actually. Also, what robots cannot do. Oh, no, डायरेक्ट चला देता हूँ. कर दीजिए जो करना है.
मार्क कर दीजिए मतलब पॉइंटर.
हाँ ये चलेगा ना, ये ठीक है. Okay, thank you. So thank you very much. I had given this lecture somewhere else also, that what a robot cannot do. So there's an intense fight between the robots, different types of robots here, Bellis, Cubis, Mako, then so many robots are there. So among these fights that we must know that what robots cannot do. Friends, as you know, these are the 10 successful steps for doing a proper knee replacement surgery. You should have a first proper selection of the patient, correct indication. Your surgical approach has to be proper. You should take accurate bony cuts and alignments. Ligament balancing has to be adequate. You should use a proper design and matching size implants. The quality of implants can make a difference. You should have a good fixation with the bone, doing a proper cementing technique. Achieve a good patellar tracking, control your infection, and post-operative pain management. If you have addressed all these 10 issues, then your patient will be a successful patient after total knee replacement. Of course, other factors I have not taken into consideration, like the psychological factors of the patient, the level of dissatisfaction and level of mobility, all these things, afterwards physiotherapy, etc., how it helps to gain back the, the status, pre-operative status. So let's discuss one by one. Out of these, the robot addresses only this issue, accurate bony cuts and alignment, and other 9 points robot cannot address. So first thing is appropriate indications. You must select a patient who has got pain at rest, pain at night, pain which affects the activities of daily living. So unless pain is there, you should think twice, thrice before touching upon the patient doing a knee replacement surgery, only because there is a deformity present, only because there is a instability is present. Knee replacement surgery is not done only for those indications unless pain is present. And if you see on the X-ray, there should be bone and weight bearing AP view. If this kind of X-ray you see, those are the indications for the surgery, that is Kellegren-Lawrence, grade 3 and grade 4 arthritis. If you are doing a knee replacement surgery in the earlier part, Kellegren, KL grade 1 and grade 2, where just there is a diminution of joint space, then post-operatively, even if you don't land up in complications, patients will be dissatisfied because of several other reasons. Sometimes you may see the patient symptoms do not match with the X-ray findings. Patient may be extremely painful, X-ray doesn't look that bad, or opposite way. Patient may not be having any pain, but X-ray looks grotesque or X-ray looks very bad. So unless the patient symptoms matches with the X-ray findings, that is the proper time the indication is for surgery. Otherwise, just conserve the patient with some kind of treatment by time till the patient symptom matches the X-ray findings. The second important thing is the surgical approach. You know, this is conventional surgery and this is robotic surgery, what you see here. That 4 to 6 extra pins which they put in the supracondylar region and also in the upper part of the tibia, that may lead to stress fractures, and there is some, you know, systems which provide little thicker pins, that Dr. Sanjay was telling today, that thicker pins again may lead to more of stress fractures. So extra pins you are putting, though exposure remains same, it is not a minimally invasive surgery, exposure remains same, and in conventional surgery, robotic surgery, the surgical approach, it makes a difference, that how robots can cause extra damage to the tissues. And of course, this kind of generation of these particles, bony particles, one need to be very careful to wash out all these bone debris, lest it may produce, you know, problems later on. The ligament balancing, deformity cannot be corrected without releasing the contracted ligament and balancing the collaterals. Whatever said and done, even if you do only bony cuts, so somehow or other you have to do some ligament balancing at the end of it. So, which is a pure surgical skill, and not that robot is doing this balancing for you. So, as you know, naked eye assessment, less than 3 millimeter of instability we cannot see in the naked eye, but 3 millimeter or beyond anyway you can assess your naked eye, and you can release those ligaments appropriately to achieve a good balancing on the table, and you are satisfied after this. Now, implant design and size and quality of the implant. Do you know that to get the best results, implant should be size of the host knee, which is not possible at present. The human, you know, race is in so different, and we have only around 6 to 7 sizes of implant which are available. And different companies has got different patients specific implants, and it has to be US FDA approved, and more than 10 years at least track record has to be there, published track record, that in multiple centers it is showing consistent good results. Then only that implant one should select from the literature and use it. At present, the robotics have a closed system and can use only one design of the implant. So if you are buying a robot, you are married to that particular implant only, and you cannot use other implants. And you cannot buy multiple robots in your system, because it is very expensive and not very cost effective to have multiple robots, so that you can have the, you know, independence of, you know, your using multiple implants whenever you want in different manufacturers. So that is why, that is the biggest drawback of robots today, that you are using a robot, that means you will be using that particular, you know, implants. Moreover, some robots, they provide you know, assistive devices for the hip replacement surgery. Many robots, they have not yet devised their hip replacement software until now. Now, implant fixation, better implant fixation in a saw cut bone rather than a burr cut bone. In a saw cut bone provides a good cancellous bone exposure, it provides better cement intrusion, and but a burr cut generates heats and devitalizes tissues. So there is a little difference. That's why most of the companies, they have saw cut robots rather than burr cut robots. Only QBs has got a burr cut robots, and of course in Smith & Nephew they have got a burr cut robot. So that is little controversy about that. When it generates so much of heat and devitalizes tissue, there is a possibility of tissue necrosis. Now, patellar tracking and resurfacing, none of these robots have addressed this issue. Mal tracking, as you know, up to 20% of the complications of patellofemoral are due to mal tracking of the patella, and resurfacing shows a better patient satisfaction. Of course, there is a controversy about patellar resurfacing or not resurfacing, but though most of the surgeons were following not resurfacing the patella or selective resurfacing of patella, nowadays, as of now, the world is moving towards resurfacing of patella more and more, because the complications are much more, and that is why they are doing a more of resurfacing. So neither robot nor computer have developed this software for the, you know, patella mal tracking, or how to place the patella in appropriate you know, placement of the appropriate patellar component. So only your surgical skills can help you. Infection control, most common cause of revision TKR world over. 25% of our revisions are due to infection only after total knee replacement. And this depends on your infrastructure factors, OT laminar air flow, infection control, surgical factor like duration of surgery, how many, you know, personnel there inside the theater, and your meticulousness of surgery. And patient factors, of course, low hemoglobin, low albumin, diabetes, chronic urinary tract infection. There is no role of robot here that it can prevent infection in any way. Pain management is critical for early mobilization and short stay. What we are telling, early patient robot assisted surgery provides early mobilization because of less of soft tissue trauma, but it depends on the how you do a multimodal pain management. The combination of epidural adductor canal block, local periarticular infiltration, injectable paracetamol, transdermal patch or oral NSAIDs, and there is no role of robot here that your post-operative recovery will be faster with any pain management. That is similar for both kinds of surgery. So finally, accurate bony cuts and alignment. Remember, the center, hip, knee and ankle should be in one line, that is the neutral mechanical axis, and as we know from the literature, it has to be within 3 degrees here and there. So that's why people are talking about kinematic alignment and restricted kinematic alignment. The margin is almost 6 degrees, that means plus 3 degrees or minus 3 degrees. So sub-millimeter correction is not necessary, that you just show that is a neutral mechanical alignment. It may be little bit here and there, that doesn't matter, that the patient is happy and post-operatively functional outcome is okay, even if you do within these 3 degrees of outliers. So this is a 42 years old male, hemophilia again, young man walking with 2 auxiliary crutches, and X-ray looks so grotesque like this. It is just like a claw-like femur where the entirely upper part of tibia and lower end of the femur is destroyed. This is the lateral view, and this is after doing all 3 joint replacement, both knees and 1 hip replacement, and that is 7 years and 3 months follow-up of this patient, that his function is restored. There is no infection, it is a conventional surgery, no robot has been used. So if you are surgically, if you are good, you can balance your ligaments well on the table itself using a properly indicated implant size, that will give you a optimum result and patient's outcome will be better. So robotic surgery, if you see the long-term results, robotic surgery versus conventional surgery, the results are all same. It is more invasive, extra pin insertion needed, takes more surgical time, and of course the cost is a issue for many of us. So at present it is just a marketing gimmick. If you follow, my editorial in as a guest editor in the Indian Journal of Orthopaedics in 2021 November issue, Changing Paradigms of Arthroplasty Practice, I have given this conclusion that march of robots in total joint arthroplasty cannot be ignored. Robot has already entered our armamentarium, it is already occupying a space in our theatres. But robot assisted surgeries increase precision and component alignment without the surgeon losing control over the surgery. So surgeon has to control the robot in order to get that proper alignment and component positioning. Consistency of the surgical procedure improved and need for large instrument trays are eliminated. Those are the advantages of the robot in the surgery. But robots are expensive and have a large footprint in the operating room, it occupies that space. Eventual benefits in terms of patient outcome is yet to be known, though there are publications which are from centers who are practicing robot assisted surgery, they are showing better patient related satisfaction outcome, but it has to be multi-center trial and comparable with the conventional surgery. Next, that robot and artificial intelligence assisted devices will be part of our armamentarium. It will not go out of the armamentarium, it has to be there. Anything technology, new technology, it has to come and it has to occupy our practice. We need to change with time and use these technologies to the best of our ability to enhance our technique and outcomes. So first we must be very much well versed with the conventional surgery so that we can utilize the robot in our hand so that how to improve our technique better. But one must not forget that we should not go away from the basics and fundamental principles of arthroplasty. The conventional teaching which has been taught by our masters not only in our practice but also teaching, and we impart to our students. So we must know what is alignment, what is the Mikulic's line, how it is a varus knee, how valgus knee, what are the structures on the medial side, what are the structures on the lateral side, which needs to be released in what step in order to balance our knee. I thank you for a patient hearing, and again I request you for my endeavor in the Indian Orthopaedic Association elections. Thank you very much. Any questions? I can take it right now. Yeah. Now robot surgeons will kill me.
We have enough of debates there.
Yeah, yeah. 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 Yeah, you know, these are the concerns which are initial concerns after robot has come. Again, you know, future will tell, maybe 10 years, 15 years down the lane we'll get to know. Moreover, technology has got a, sir, 1 second. As we are discussing that navigation also was a technology which was followed, and gradually it went out when robots came. So they may be changing their software every 4-5 years. The companies, they always aim at you know, improving their research and improving their market also. So that is also will be detrimental for the surgeon unless something you have bought which at least lasts 10 to 15 years, so that you get the cost out of it. Then cost versus the, you know, research and the business, that has to be weighed against each other. Yes, sir.
Regarding intramedullary intervention.
Sorry?
Regarding intramedullary intervention
Sure.
by multiple pins and the intramedullary femoral rods. So what is the ratio means in which there is a less, in which there is a more?
You know, conventionally what you do, we will only on the femoral side you use the intramedullary jig. On the tibial side we use most of the time extramedullary jig. So the intramedullary jig, only one, you know, disadvantage what you can, there is a development of embolism, fat embolism, what we tell. There is a possibility of developing fat embolism. But here the pins, there is a chance of fracture. That is the, so there are two different things. Infection, again, as I told you, infection prevention is a different thing altogether. Pins, intramedullary putting, that doesn't make a difference in the infection.
Post cardiac bypass, on paper at least and theoretically, I think computer navigation or robotic surgery, it's like has an edge over a conventional surgery because you are not violating the intramedullary canal.
Especially in bilateral cases, probably that you are not intervening the intramedullary canal. But then you have to modify your, what I do give a thorough lavage into the intramedullary. I do a lot of bilateral cases conventionally. I give a thorough lavage to the intramedullary canal. I must have done almost more than 800 cases of bilateral TKRs, but not a single patient have developed you know, those kind of complications. Of course, patient selection is important. We do bilateral cases not in a not more than ASA grade 3 and all. So these are all ASA grade 1, grade 2 patients.
Okay. And navigation is not going back, so now it is a part of our robotic assisted device.
Yeah, in Vallis it is a navigation based system. Again, in robots there are different city based, some city based system. Then again, the advantage, disadvantage is there that you can map it out properly before surgery, so that you don't lose intraoperative time, but it is radiation to the patient, extra cost, etc. Whereas in Valley system, you do, it is no CT is required, intraoperatively you don't measure, it's a easier system, easily you can do, and you hold the, you get the surgeon's feeling of cutting to the bone with the saw, all these things, the advantage, disadvantage robots are also there. So there are so many variations there in the robots itself. Cost wise also, you know, QV system is very cost effective. It just costs around 2.5 crores or something like that, whereas other robots are cost around 7 to 8 crores depending upon the system.
Few complex cases are likely in extraarticular deformity.
Yeah, there is the role of navigation as well as robot is there. Only the complex cases like extraarticular deformity, malunion, all these cases, definitely there is a 100% role of the navigation and the robot. But those kind of cases are only maybe 5 to 10% of our practice. So that I will send it to you.
In the field of orthoplasty, sir, will we always focus on the longevity of the implant? All the researches that have been done in the past, every research is focused on increasing the life of implant, how long it will last. So down the line 20 years, I think we'll be able to see the difference between what we are using today.
Yeah, that time will tell in future.
Say that in a basic knee, conventional method is better or robotic knee is better.
Yeah, that time will tell about longevity of the implant. But why robots and you know, this navigation came into picture? Because 20 to 25% patients are dissatisfied after surgery. That is why, to improve the patient satisfaction level, that is what how these things came into picture. But whether the robot assisted or computer assisted surgery has improved patient related satisfaction compared to a conventionally operated surgery, that is not yet proved, or that is not very clear cut from the literature. Only people, it is biased studies, people who are doing using robot, they are telling that it has improved the patient related outcome. But otherwise it is almost same as you are feeling.
Unless the patient's native anatomy is replicated, there will be always some debate about it.
Might be. Kinematic alignment came, that patient's anatomy restored, so patient satisfaction is better, but you don't know. That is the thing. Thank you. Thank you very much. That you can read the editorial from the, yeah, it's there. अच्छा ओके नहीं उन्होंने हटा दिया सर.
So we are requesting everyone to please support Mohanty sir in his election, sir.
Dr. Mohanty is contesting for Vice President of IOA. Please vote for him.
I was the President of Bombay Orthopaedic Society, President of Indian Arthroplasty Association, and Education and Fellowship Chair for Indian Society of Hip and Knee Surgeons. At present, I am the member of the Knee Arthroplasty Committee of SICOT, and my principles in life is honesty, integrity, and ethics. And my aim is to two things. One important thing is that to establish IOA guidelines for each and every procedure, like we are following for diagnosing infection, AOS guidelines, grade 3 fracture, compound fracture, tibia, what are the guidelines, effort guidelines, European guidelines we are following. Let us have our own guidelines for each procedure, and which IOA will recommend, and it will get approved with the central government, so that every nook and corner of the country can follow it, and also it will save us from medical legal issues. That is my main motto, if I can do it. Thank you very much.
Thank you, sir. And after a very in-depth presentation and demonstration of case exhaustive, I congratulate Dr. Sekhar for his presentation there, and I urge him to come to the dais and give his presentation. Two back-to-back topics: knee arthroplasty experience as non-robotic to robotic, and challenging cases with robotic assistance.
So 1 minute.
आगे. Good afternoon, and I again thank the organizers for inviting me to this wonderful meeting. So this is the hospital where I work. It is a permanent hospital. It is the new block, and it was started by the plan and the execution. Everything was done by Dr. Sekhar Agrawal, but unfortunately he couldn't see the opening of the hospital. Now, so we know that it's a very burning topic nowadays, robotic, non-robotic, and we'll stick to some basic things. And my talk will focus on why and how. So we all have seen these kind of results. Almost everyone must be having this kind of examples in their armamentarium, where the conventional TKR gives wonderful result, not only in terms of activity of daily living, but also in recreational activity. A person around 82 years of age is got both his knee replaced and is practicing this Sikh martial art. But as Professor Mohanty mentioned, that there is still a dissatisfaction rate of 15%. It varies 10 to 20%, and there's always this quest to decrease this percentage. And that's why his topic was looks good but doesn't feel good. And we all have these kind of patients. So there are two basic goals: to have a proper alignment and a balance. Okay, and these are the surgeon's goal. But not every time, if you achieve this goal, it translates to function. Now, as a surgeon, we can just try to achieve perfection in these two things. To have a proper alignment, whatever alignment you believe in, mechanical alignment, restricted kinematic alignment, or functional alignment, and you should have a properly balanced knee. When we are doing a conventional TKR, there is absolutely no doubt, even for those who are not doing robotic TKR, that the planning cannot be matched the way it can be done in robotic TKR. Okay? If you feel that if you can give the patient his native anatomy, then we think that the patient will have a good function. And on a CT scan with all kind of views available, you have this power to at least plan it perfectly, like we saw today in both the cases. On an X-ray, this planning is a bit difficult. The planning is always two-dimensional. The templating is done to predict the size, but it is not accurate. Now, when we use this intramedullary femoral and extramedullary jigs, then sometimes there is movement of the jigs. The jigs may have limited options also. When we do conventional, you cannot move the jigs in millimeters, 0.2, 0.4, 0.6, 0.8. And the bone dissection using bone saw may or may not be accurate. Secondly, there is also no provision to assess the soft tissue balancing. So I would say that in the present time, the TKR is an art. Okay. Now that art may be perfected by surgeons like Dr. Mohanty, who is a gifted surgeon and who has the experience of thousands of knee replacement surgeons. But if we talk of knee replacement surgery now, it is one of the commonest orthopedic surgery performed throughout the world. Okay. It is going to become commonly done procedure everywhere. So there has to be a standardization. There has to be numbers which can dictate a surgeon that this knee is going to do perfect. Okay. So robotics brings that objectivity to this art. And then there is a question of philosophy. Now this patient came to me for surgery on his left side, and the right side was operated somewhere else, and this patient wanted a similar kind of result on the left side. So what do? Do you intentionally keep the knee in varus alignment, or do you give him proper mechanical alignment, which you are not sure whether he is going to like it or not? Okay, so that gave to this concept of functional alignment. Now if you consider doing this functional alignment thing, then it is very difficult to do it in a conventional way. Okay, you cannot eyeball 2 or 3 degrees. That can be done only with navigation or with robotics. And second change which has happened is which was being discussed in the morning also, that the earlier thing was that the TKR is a soft tissue surgery where bony cuts are to be done just to place the implants. Now there has been a slight change in the philosophy, and now the balance is being tried to achieve even through the bony cuts, so that the soft tissue releases are minimum and the patient's early functional recovery and pain is better. So robotics, it is basically a question of philosophy and what you think about TKR. Robotics is just going to help you in doing that. Okay, so it is a tool which helps the surgeon more precisely align and balance the implant with computer monitoring, helping the overall function of the knee joints. So that is the why of robotics. Now how it is being done, there are different systems which follow different patterns. So the system which we use, there the robotic software, it converts the advanced images to patient's personalized virtual 3D reconstruction, which we saw in the morning, and then you can do a planning on the software for appropriate component sizing, positioning and bone resection. And then, so that was even there in the navigation. With robotics, there is execution of this plan with high level of accuracy. So these are the various systems which are available. So you have an artificial AI based planning. That means when you take all these points, then the artificial intelligence based on the data of thousands of patients, it gives you the 3D model and the implant which is going to fit that patient. And then you have this execution of the plan by the robot. So the step 1 is patient selection. So the principles don't change. All the 10 principles which were discussed in the previous talk, they hold true even for robotics. If your patient selection is wrong, whatever you do, however perfect you align the patient is going to be unhappy. Second is you do the CT scan, then the 3D images are created and you do a pre-surgical planning, and then the surgical implantation and implant placement is done. I won't go into the details of the planning that we discussed in the morning. So at the end of planning, you get a picture like this, which shows the overall alignment of the limb, the size of the implant, the resection level both on the femur, both distal, anterior and posterior, as well as in the tibia. So basically planning in robotic surgery is performing a virtual surgery before the actual surgery. At least you are putting some thought into it. You are seeing the anatomy of the patient. You know where are the osteophytes available, what all you have to remove, and accordingly you have a great idea about the sizing of the implant, the position of the implant. So you are performing an actual surgery, virtual surgery before the actual surgery. And then if you believe in the machine, then it executes your plan to the perfection. So that's how you saw the live surgery. Now the big question which comes is whether all this planning and perfect execution leads to increase in patient satisfaction or not. But then we all know that it's a multifactorial thing. What we can do is we can try to give the patient a knee which best fits her knee joint, his or her knee joint, and is mimicking his natural anatomy as far as possible. Now, as far as safety features are concerned, one of the major concern against the active robots is damage to the soft tissues, inadvertently damage to either neurovascular structures or the ligaments. Now, that has been taken care in the system. If there is a bony movement of even 2 millimeter, the robo will stop automatically. It remains within the bony boundaries, and that boundary boundaries are recognized by the CT scan as well as set by the surgeon. As far as learning curve is concerned, well, the alignment can be achieved in initial 2 to 3 cases only. As far as timing is concerned, well, it does take some increased time, and literature have shown that it takes almost 40 to 50 cases to become time neutral. That means it becomes equal to the time which you take for conventional surgeries. So, robotics is a tool in surgeon's hand to perform knee replacement more accurately. Okay, but you have to decide what you want to do with it. It helps to execute the surgical plan more precisely with sub-millimeter accuracy, but the principles and technique you have to know. So, if you learn the technique only, you will be stuck with one technique, but if you learn the principles, you can devise your own technique. So, with robotics, you can play, you can first take tibia, you can take femur, you can give varus, valgus, whatever it is, but you have to know the principles, and then you can utilize it properly. Thank you.
Very easy. So there is a feeling that that is more accurate, rigidly fixed, and this may not be up to that. Though after cementation, we are giving. So anything to say?
Actually, I think there is no confusion in tibial implant. That is okay. In femur implant, what we have felt that the cuts are so precise that the implant fits properly without any struggle. Whereas if we do conventional, sometimes it doesn't match properly and you have to hammer it a bit. Whereas in case of robotic thing, it fits accurately, absolutely precisely, and you don't have to struggle at all. So I don't think that affects the fixation of the implant. In fact, that's better because...
And cement layer, cementation, anything to cementation?
Cementation, I think, is also quite good. It doesn't affect the cementation or anything.
Okay.
Yeah. So most of the cases can be managed by both conventional and robotic, but then there are few definite indications of robotics where it scores over the conventional thing. So we'll discuss a couple of these cases. So lady of around 57 years, difficulty in walking since couple of years, got deformity in both the knees, and these are her x-rays. So the left knee is in valgus and the right knee was also in valgus, but corrective osteotomy was done somewhere and the knee is now in varus. So if you see, there is whole shift of metaphysis medially. Okay, if you try to put your intramedullary rod, it will go somewhere here. It is displacement. So the surgeon tried to correct the valgus osteotomy on the right side, and in effect he displaced the whole of the metaphysis. So that's the lateral view of the same patient. There is, you can see that even there is slight flexion of the component. These are the clinical pictures of the patient. So these are few cases where the robotics really help you in planning and getting your component placed properly. So this is the planning for the left side where the patient was having valgus knee. So you can see that very small amount of bone is being cut on the lateral femoral condyle and similarly on the lateral tibia. That's the tibial cut after the cuts have been made, hardly touching the lateral tibial plateau. And that's the balance on the lateral left side. Similarly on the right side was more challenging because of the shift. So that's how we planned it. And that's what we could achieve. So it was perfect alignment without putting any intramedullary rod. So on the lateral side there was this screw and that's why we put this stem, and on the right side perhaps we wanted to give a same picture to the patient. It doesn't look nice that if you have a stem on one side and another side, it looks quite odd. Sir, ये भी जरूरी होता है तो नहीं, stem robot has got nothing to do with stem. What was the problem here was putting the femoral implant, because if you see the pre-op X-ray, there is, yes. You don't have to take much of trapezoidal cut. Here there is more of metaphyseal shift. So the problem here is putting your intramedullary jig to take the cut. Okay. Yes. No, we are not telling, we are, let's come out of that. We are not saying anything robot over navigation or robot over conventional. It is just the use of robot in this situation. You can even use robot. What's harm with that if you have it? Yeah. Yes, you can definitely. You can use navigation also. Definitely.
Just for the that screw, I would have put little obliquely.
Okay.
Along the trabeculae of the tibia.
Okay.
Whenever somebody for defect build up on the medial side, posteromedial side, laterally putting screws along the trabeculae. Because when you put vertical screws, there is a possibility of screw coming out through, coming out of the bone. So you can put little longer screws, building up the defect.
Yes. He is another person with osteoarthritis of bilateral knee. So again, if you say this patient had some subtrochanteric fracture on the right side, which was managed by DCS with a long plate, and on the left side he had a supracondylar fracture which was managed conservatively. So on the right side, definitely you can also do conventional. You can remove few screws and then put your rod. On the left side, the medullary cavity was obliterated. So these are the situations where robotics, or you can even say that the navigation scores over conventional. Again, a complex problem, a patient having severe valgus on the right side. Was planned and managed with. So here we had to use that with the primary implant, we used that spacer which had slightly constrained it, which can be a slightly bigger post in that. Another patient with valgus and hyperextension deformity. So the thing is that it helps in proper planning. You can plan properly, you can plan the implant size, the cut size, and that helps you in doing the surgery. Okay. Thank you.
Thank you, sir, for an elaborative description and gone through good cases and improving our understanding about the use of robotics, judicial use of robotics. Thank you, sir.
So technology will keep on improving. Okay, robotics and AI will definitely going to come in orthopedics and in every field. Now, whether it is the right time to jump into it or not, that's an individual perception. Okay. But then there is no doubt that it will keep on improving. Thank you, sir. Thank you. Thank you.
Thank you, chairpersons. So now, and thank you, sir, for a wonderful lecture. Now, to chair the session of debate, I request Professor S.C. Goel, sir, and Dr. Londhe, sir, to be on the dais. And we have a very interesting debate between two young dynamic surgeons, Dr. Vijay Singh and Dr. Neeraj, and both are going to so I hand over the mic to the chairpersons.
This is a very important topic. There are clear-cut demarcations, either you belong to group A or group B. There is nothing in between. And to be honest, I also always think of doing a HTO and I take my step backwards. And I also sometimes thinking of doing a unicompartmental, and at the end I think, no, forget it, I will just replace the knee, So I think that's a very good topic. Let's see, I think we get a clear-cut answer. So I invite Dr. Vijay Singh first. I believe he is a proponent of HTO. Is that correct? Unicompartmental. Fantastic.
STO. पहले यू क्या है? Good evening, everyone. To start with the debate, I will just like to see the show of hands. How many of are doing UCare? Only quite a few. I know my friend Neeraj will be talking a lot about HTO and try to convince you to do HTO, but probably after my talk, I'm convinced that even you guys will be eager to do UKRs. This is an age-long battle, high tibial osteotomy versus unicompartmental knee arthroplasty for medial compartment osteoarthritis of knee. There are plethora of studies available inside the literature favoring both HTO as well as UKR. Yes, the ideal indications of both UKR as well as HTO, they do share some common indications. While you see for case selection of UKR, the age should be more than 55, the activity level should be low, the weight should be, BMI should be less than 30, alignment should be within 0 to 5 degrees, and the instability should be less, while even the lesser arc of motion can be managed with UKR, vice versa with HTO. So how to decide? Are we overloaded with the options? In my practice, it's only UKR is only being done for patients who have alignment, tibial vara, where the joint lines are good, while the patients who have complete bone on bone or pictures like this, where the complete articular cartilage erosion is there, or all the patients who undergo UKR also go stress x-rays, varus valgus stress x-ray, if they show bone on bone appearance on medial side, probably they are the candidates for unicompartmental knee osteoarthritis, UKR in this case. In other indications being somewhat like this, where we have a lot osteochondral flap necrosis. This is one of my own patient who had a osteochondral flap avulsion or necrosis sonk lesion type lesion. We did a UKR in him. Now why UKR is a joint preserving? Because the ACL, PCL, the lateral meniscus is retained, all the ligamentous structures are retained in the patient, and there is a very bare minimal bony resection is there. It's less than 2 to 4 mm. And there is no overcorrection. We are not trying to shift the kinematics. It is just a load sharing device which has to be inserted inside the knee. You can see the tibial resection in this case is barely within 3 to 4 mm. And when we see in terms of femoral resection, it's hardly replacement, just in the true sense it is just a resurfacing of the cartilage. So when we talk about benefits of UKR, it has a shorter hospital stay, full range of motions, speedy recovery and ability to walk unaided, sit cross-legged on the floor, reciprocal stair climbing, brisk walking and jogging on is permittable. It's a joint preserving, it's minimally invasive operation. The documented 10-year success rate is more than 90%. The future surgery is facilitated and the functional results are optimum and recovery is speedy. It's also cosmetically, the current approaches are even cosmetically acceptable. This is one of my few bilateral UKRs being done. She's mobilizing on day 1 without braces, without crutches or something, and this is the first post-op day dressing. She can comfortably bend the knee up till 60, 70 degree, 80 degrees comfortably. This is her post-op x-rays. Yet another case with the fixed bearing UKR, and this is him on the first post-op day in the first post-op dressing. They are able to bend their knee comfortably up till 90 degrees without any pain. I am sure we cannot achieve with this level of comfort with any modality of total knee replacement. This is a functional range of motion at the end of 3 weeks. Once the patient sutures out another thing, they can bend it comfortably and can gain up to total knee of full range of motions. If done properly, if the implant is seated well, the patients do perform in partial knee replacements. They do have a very good active life. In terms of function, they have a rapid recovery after minimally invasive unicompartmental osteoarthritis. These days we have a microplasty sets or microplasty instruments available, which leads to twice as fast, the recovery rate is twice as fast as open UK and is thrice as fast as normal regular TKR. And the patients are usually home within first or second day, and there is no difference in accuracy. This is one of my own cases performed Oxford knee with minimally invasive microplasty instruments. The total incision length was less than 8 centimeter. These days, if I have to compare HTO versus UKR, I will be more likely to compare as Sanjay sir already told, I will be more convinced to compare it with TKRs. All my earlier patients who had underwent TKR, they came back to me for a TKR on the other side. But since they had only AMOA or intramedullary osteoarthritis, we have been doing a UKR in those patients. And all these patients did reported very well functional scores in terms of functional joint scores, WOMAC scores and knee society scores, on the sides which were operated with UKR than those which were operated with TKR. Now when I have to compare my HTO long-term results, there are many studies which says the success rate of high table osteotomies varies from 45 to 7. It's very good in 45% to 70%, and the 10-year survival rate is somewhere between 45 to 70%. While similarly, vis-a-vis, if I have to compare unicompartmental knee osteoarthritis, unicompartmental knee replacements, arthroplasties, the success rate is somewhere between 84 to 95%. That itself tells the story of uni knee. That's why the people these days are urging towards more, and it's the unicompartment knee replacements are gaining popularity. Now, if I have to consider UKR, it does give better results, less late onset deterioration, better gait velocity, and better muscle strength, and it has a better pain relief in patients. Now, the most draw some fear, the surgeons, usually arthroplasty surgeons, converting UKR to TKR. If I have, as previous slide I have shown, that the success rate is nearly 95%. It's not a time buying procedure like HTO. It is itself is a definitive procedure if done properly. The patient do survive, the joint do survive more than 95%, and the result is as comparable to a total knee replacement when I have to compare the unicompartmental knee arthroplasty results. Now the dreaded fear is conversion of UKR to TKR. Yes, the converting HTO to TKR is a difficult, while both have HTO and UKR to TKR has a difficult challenges. While revising HTO to TKR, we have joint line changes, and that may lead to decreased results after total knee arthroplasty. While vis-a-vis same in UKR, there is where amount of minimal bone loss is there. The studies are there that we can successfully manage more than 50% of revision UKR to TKR only. But revising a UKR is very, very less difficult as when compared to revising a TKR. It's up to your choice whether the UKR is that innocent or not. And still there is Indian perspectives attached. Now, in my practice, I do favor high table osteotomy in young, heavy, active, particularly male patients, while I prefer old age, light, sedentary patients, middle aged female to undergo a UKR. And when patients with severe deficiency and subluxation, I do prefer to do a TKR in those patients. This is one of my few early cases, initial cases, whom I have operated 8 years back. I just called up day before yesterday to send her a picture. This was a picture she sent me on my WhatsApp, and that's to tell the story. Thank you.
So now Neeraj will
counter it.
Good evening. Actually, this is an arthroplasty meet where people are actually talking about robotics versus non-robotics. So somebody talking about preserving joint is an odd man out. Okay. The topic given was, one second, yeah, I'm just searching my. लगता है उड़ा ही दिया कि यार कोई STO बोलेगा ही नहीं because I had saved. कहाँ गया भाई? STO नाम से STO talk. So before I start my talk, I would say there's nothing as STO versus uni. Actually, there are clear-cut indications for every surgery. Yeah, nothing is supporting because it's an arthroplasty meet. Up and right. So देखिए मैंने इसमें सेव किया फिर भी ये उड़ गया. Probably the computer was not happy. So I think there are clear-cut indications. There is no doubt about it कि when to do an STO, when to do. They may be maybe the surgeon is more inclined or he thinks like so they are doing in unindicated cases also, but actually they are very clear-cut indications. Okay. So I'm not going to talk much about details because I had made some PowerPoints about the details of STO also. Since I am not doing UK, but I'm sure that Vijay is doing both UK and STO. So I'll see, knee replacement is one of the most rewarding surgeries. Patient starts weight bearing very next day, which is quite not possible with joint preservation. Maybe possible with close wedge, lateral close wedge, but I was trained in an era when we were doing medial open wedge osteotomies only. So we start toe touch weight bearing only for almost 1 month, then we start weight bearing. So definitely it cannot match the initial recovery of the patient. Okay, but limitations, definitely range of motion knee. As Vijay said, that patient can squat and do all the activities, but I don't think that the range of motion is as free as if you preserve the patient's original knee. Nothing can beat your original knee, nothing can beat your own biology, and I think everybody must agree with this. Related contraindications are there. Indian lifestyle, as he said, in the third world country, and we are unfortunately still the third world countries, so we must do what suits our patient's need. Okay, Indian lifestyle, and again cost issues, because STO is a pretty cheap surgery. Taboo, we all know that replacement, once we say, people start talking about some great names that they could not be successful, so what about us? So there are knee preservation options that, and those were going for years together. We have even 30 to 40 years of follow-up of people in India itself, and especially in third world countries like Japan, because in countries like Japan and in India and in Malaysia, Indonesia, where squatting is a very important part of their lifestyle. If you tell patient you can't squat, he will say, sir, hum aise hi chala lenge, because they want to squat, they want to sit cross leg. If you tell them that you'll be pain free but you can't do these two things, they'll probably don't get the surgery done and they will continue to bear pain and live like that only. So knee preservation options are very valid. Probably because in the older days we didn't have much of the investigations, we didn't have the scanograms, we didn't have the MRIs, didn't have the arthroscopies, and we were doing mainly close wedge osteotomies. After that, conversion to TKR was difficult because we were actually altering the anatomy of the proximal tibia. But with medial wedge, open wedge osteotomies, we are not touching the anatomy, it is not altered, and the TKR is very, very easy after an open wedge osteotomy. I think everybody will agree to that. If it is middle open wedge osteotomy, the TKR conversion is very easy. It is not a time buying surgery because it will actually, if you have done it properly and the patient is motivated, he may actually not land up in TKR in the whole lifetime, because it may last for 15 years. Even I have seen patients of my seniors who are actually good after 35 years also, after well done close wedge osteotomies. I am talking about close wedge because medial wedge osteotomies, we don't have much follow-ups. Maximum is 15 to 20 years only. Personally, I have 11 years of follow-up in middle open wedge osteotomies. I have just assisted 2 or 3 close wedge osteotomies with conventry staples. I have not done any of the close wedge osteotomies yet. So high tibial osteotomy, old time tested lateral closing wedge, I said it was being done in historical days. Conventry started in long back, and it still many surgeons are in India who are actually doing the Coventry staples, and they are still doing the close wedge osteotomies only. So I'll just skip the history part and other things. I'll just come to our thing. Yeah, this side is very important. The slope and the instabilities in our patients with pain. So if there is instability, the uni or any other replacement, I can say, okay, we're not talking about the TKR, but instability you cannot touch. You need to have STO only. You cannot deal the instability with a uni, because you need to have the ACL intact for a uni. So current indications: middle compartment OA in varus knee, middle compartment OA in ACL and PCL deficient varus knees. So if we say all the other indications, which are the current indications, which are the modern day indications for STO, are actually the new things which we are doing in joint preservation surgeries. So middle compartment OA in an ACL deficient knee or a PCL deficient knee, varus knee, this is only with STO. This we can deal only with the STO. ACL deficient knee, you cannot do a uni compartmental replacement. Again, in posterior lateral corneal insufficiency, you cannot do a uni, you have to do a STO only. In conjunction with cartilage restoration procedures, we do STO. And in compartment of lateral compartment in valgus knee, we do distal closing femoral osteotomies. So double varus, triple varus I have described. We are even doing the cartilage restoration procedures, because most of the people who are doing knee preservation are actually doing arthroscopies also, and many a times we see many things in the knee which we cannot see in the MRI or in the X-rays. So cartilage treatment option right from microfracture to mosaicplasty, other osteochondral allograft, scaffolds, everything is possible. Macrofracture is very easy, which I think many of the cases even I do with STO. The contraindications are if the varus is more than 20 degrees, the flexion contracture is more than 15 degrees, knee flexion is less than 90, tibal subluxation is more than 1 centimeter. Again, this is sometimes we go beyond this also and we do, and we have seen good results. But theoretically it is written that tibal subluxation is more than 1 centimeter, we should avoid. In inflammatory arthritis, we should not do an STO. Obesity, this again is a relative contraindication because even up to BMI 30 many people are doing open wedge osteotomies. STO versus uni. So I think this is a very clear cut indication which we all will agree. A younger patient better do an STO. Older patient, older means near about 70, that we call as older because you don't want to make the patient sedentary. You cannot tell him you be on the bed, do knee bending because they cannot do partial toe touch weight bearing. They don't have much power in their upper limb. So whenever they will weight bear, they will do full weight bearing. So in older patient, more than 70, go for uni because you can make them weight bear the next day. But at 70, it is very difficult to find a unicompartmental osteoarthritis. You would think of doing a TKR because that's a definitive procedure for his life. ACL, PCL ligament laxity with osteoarthritis, only option is STO. Intact ACL you need to have in uni. You need to have correctable varus in uni. Fixed varus you can do an STO. Higher activity level, STO. Low demand patient, uni. So if your patient wants to play, wants to go to the farm, wants to do all his work, STO is a better option. If the patient is low demand, confined to the home household activities, you can go for unicompartmental replacement. So now again how I do, usually I take sclerogram. Scope the knee is not always there. I just want to show something bone on bone kind of picture for which we did again the go. This was a patient having bone on bone osteoarthritis, and I did a diagnostic arthroscopies, and many a times when we go inside the joint, we find that the lateral compartment is very good. So we did an STO and the patient is still fine after 8 years. Even in arthroplasty, you must have seen many a times after opening the joint, you will see a glistening, shiny cartilage on the lateral side. Everybody will agree with that? Many a times we find glistening, shiny cartilage, and actually, if you see from my eyes, I will feel, yaar, isko to bacha sakte the. So just put a scope, you might find that the lateral joint is very good, and you can actually do a STO in that patient and you'll be very happy. So I think there are clear-cut indications. We should not go with a fixed mind of doing either STO or uni. Decide from patient to patient, and all the studies of uni, whatever we are seeing, are mostly from the Western literature. Their lifestyles are very different, their patients are very different, their needs are very different. And in our country, we still don't have much surgeons who are doing uni. As in this hall also, I think 1 or 2 people only raised their hand when it was asked that who all are doing uni. And people who are doing uni also have done just few. Dr. Vipin, how many unis? Few. You can count on single hand. So after 3 or 4 or 5 surgeries, you cannot. 50. 150. How many STOs? 50. Okay. But still, I would say even 150 patient cannot make a. In India, we still have people who are not inclined towards uni. The training is not very good because I have seen disasters after uni and getting conversion to TKR at a very early stage. So I am not talking about the training part, but we do have clear-cut indications. I think if we go by indications and the needs of our patient, we can actually have very good results. So I'll show even the one good result of my mentor himself, there are many cases in which I have done for ligamentous instabilities, but I don't think they are relevant in this debate. So my mentor is now 22 years, bilateral, Dr. Anand Joshi, bilateral STO, and you can see him jumping, running, cycling, as good as a young person. 22 years, no signs of any degenerative changes or any pain in the knee. So if done well, you can actually have a patient who can actually complete his life without any surgery required. Sir, debate part.
Yeah, Dr. Vijay Singh and yourself. See,
as a novice in HTO and unicompartmental, I do very less unicompartmental. The only thing which bothers me before I plan something for the patient, how can I get my result predictable? I think on the predictability, probably unicompartmental scores slightly better than the HTO.
Sir, do an arthroscopy, it will be 100% predictable. That's what I said, no. I always, whenever I'm in doubt, I do an arthroscopy.
In your arthroscopy finding, if you find that the articular cartilage is eroded on the medial side, the lateral side is glistening, femoral component.
Both. It has to be both.
You will add DFO as well, or you will do only HTO?
DFO if the varus is a lot, because till 20 mm I can open.
So how your high tibial osteotomy will help a patient with the femoral cartilage loss on the medial side? How would it will help the medial cartilage?
Isolated femoral cartilage loss and tibia is totally fine. It is not possible without a traumatic. It may be in the young patient, but in osteoarthritis it is highly unlikely because only
in most of the entomedial osteoarthritis it is the both medial as well as the tibia as well as femur being involved. That's where the uni
if the lateral compartment of the femur is gone, then even the uni is not going to work for a long time.
I'm not talking about lateral compartment. It's only medial compartment, both femur and tibia being eroded.
Yeah, that time I'll if the lateral is good, I'll go for STO. It will work.
Because if you critically read the literature, lot of HTO literature is from European things.
True, sir.
And I am sorry to say, European healthcare system is like our municipality. I have worked in NHS for almost 7 years, whereas very few literature of HTO has come out from USA, where customer is king.
Sir,
the customer
actually,
has to have a good result.
Japan, there is lots of literature. The third world countries, I would say, there are lots of literature, and they are doing close
Japan
wedge.
is again state-funded healthcare. It's not a survival of fittest. So Europeans, they do a lot of HTOs, but hardly any literature from the North America. Any reason?
That I need to find. So I don't know about North. Sir, probably.
Femoral osteotomies also. It is the Europeans who have been doing.
Yes. Or the American surgeons want to do a surgery which works.
Sir,
they cannot get sued.
Sir, I'll tell you, sir.
I'm not criticizing.
Sir, I'm not.
I'm asking.
Sir, I'll tell you one thing, sir. Like, we talk about instability of shoulder. So Americans go for soft tissue procedures. If you see Europeans, they go for more of bony procedure. So that differs. If you see, especially Germans and all, they are totally, they go for mini open rotator cuff repairs. They don't go for, because cost effectiveness is something which is more in European countries, because the government is bearing the burden, and in America the patient is paying or the insurance company is paying. In our country the patient is paying mostly. So the cost constraint is a very big factor, more than European country it is for us.
And one more question. A typical 47-year-old patient with a medial compartment osteoarthritis. You scope. I do a knee scopy also.
Yes, sir.
You scope, and if you see a KL4 grade osteoarthritis, do you sincerely believe that after doing a good HTO, the cartilage regenerates?
So there are some studies. I have never scoped my.
What is your
So the cartilage unloads. The cartilage unloads and there is fibrocartilage formation, but you never get the original cartilage. That is true. The cartilage regrows, but that is the fibrocartilage, and that is weaker.
A question to both of you. One of my senior surgeons in UK used to say that there is nothing like a unicompartmental arthritis. It is always tricompartmental. You may see a little bit earlier or later. So always do a TKR. Your answer to that?
Sir, at least see in STO we are taking care of two compartments, because now we are doing biplanar osteotomy. There was in slide also, but I skipped that. The Mackey effect, which unloads the patellofemoral compartment, that is also a very big advantage for our STO. The Mackey effect is not possible in lateral close wedge also, and not in uni also. The Mackey effect.
I would like to add in this. As such, if you ask me the total knee replacement's lifespan, as such, when we do total knee replacement, offer total knee replacement to the patient, we say it will last for 15 years. It will last for 15 years if we do total knee replacements. And up till 20 years, survival rate is somewhere around 60 to 70% for total knee replacement. While a similar data is cropping up with unicompartmental osteoarthritis knee, if you unicompartmental knee replacements, and that itself is a load sharing device. That is not a load bearing device. It's a load sharing device, means both the compartmental two take
part in the load. We do not try to, in unicompartmental replacement, we do not try to shift the load on lateral side. It has to bear the weight. We keep the knee a bit in varus only if I am replacing medial UKs. Being a load sharing device, even that has a survival data up till 20 years. So why to do a aggressive surgery in a first hand rather than
will it prevent lateral compartment getting osteoarthritis?
Sir, the lateral compartment has already been working since last 60-70 years for him, and it will last for another 40-50 years till the time my uni will work. I won't be that aggressive to do a total knee if the cartilage is shiny and its cartilage is good.
Actually, Dr. Vijay's talk, even he said that the talk's half part was uni versus TKR. we are debating uni versus STO. TKR versus uni, they are clear indications again.
That is again another debate.
But with some ligamentous injury, a very young patient, active patient, we must go for STO. And if it is old, that's what the slide which I showed. It is a very clear-cut demarcation. We should not jump into our own, whims and fancies. They are very clear-cut demarcation, which is acceptable worldwide. But we must think about third world country, which we are.
45 age, we do fall into soup then when the female patients around 50 years coming with severe medial OAP. This is a classical picture these days what we get in the patients, and they want complete pain relief. First thing, even if you offer them high table osteotomy, they still keep on grumbling pain. They keep on coming back even after 6 months.
They are very happy. Actually, I feel what we, sir, STO say what I have felt that I am getting results better than what I felt actually, because they are sitting on the floor and they are so damn happy, and they are happy. In my own practice, I have results till 11 years only follow up. I am yet to, and still not even single conversion to TKR in 11 years.
Even
so selection is important.
One thing he said, there are definite indication of both of them.
Yes.
You agree with that?
Yes.
I think we should end on
That's
that.
what, sir. I said it initially only. See, everybody who is doing uni will say this is better, but there is nothing better of us. We have to see the indications. But the third world countries, you need to squat. That is very important. The females are very happy they are squatting.
Right. Thank you.
You can
But not third world, but Japan, squatting is very important for them. Habitual. For them, squatting is even more important than us. Now we have started using Western toilet and all, but for them still they need to squat. And in Japan, they are putting a plate after closed wedge osteotomy and making bare weight on day 1. Japanese are actually, day 1 they are putting the full weight. Thank you. Thank you.
I think now Dr. Swarup Patel and Dr. Amit Jaiswal versus Dr. Uttam Garg and others. Robotic versus non-robotic.
Two people on each side.
Sir, since morning we are debating robotics versus non-robotic, advantages of the robotics and indications and limitations of robotics. And non-robotic part has also been already discussed by Mohanty sir, so will not take much time.
Only robotic की बात हो रही है.
नहीं, अभी non-robotics after then few slides of robotics.
लगा दी ये पॉइंटर दोगे पॉइंटर दे दो है नहीं क्या Thank you, Chairperson, and thank you, Dr. Swarup. So it's not coming. Hello. So my job is already made easy by the Dr. Mohanty is there. Oh, is there. So already you have talked what I am going to say. So definitely technology advanced. Pardon? नहीं ठीक है स्लाइड हम कर लें. So we are going from the CAS to the ISIS and finally the robot. क्या कर रहे हो यार? Yeah.
So basically the aim, the goal of the TK is restoring the overall mechanical axis, which is 0 degree, the balance of the ligament, maintain the normal Q angle, of course they restore the joint line and the perfect implant placement. Already been discussed. So there is no doubt about that the major reason for the early revision was instability and the malalignment when it is more than 3 degree minutes of the mechanical axis. And the failure is lot of failure there, you can see a lot of literature there. So is it the neutral mechanical axis is the goal? It's 0 degree. Because time to time the concept is changing from the mechanical alignment to the adjusted mechanical alignment, then finally kinematic alignment, then restricted kinematic alignment, functional alignment, constitutional alignment, and the native alignment. And lastly, the inverse kinematic alignment. So the things are changing with the period. So changing a neutral mechanical axis, it is called a 0 degree syndrome. If you see the modern instrumentation and technique, if an error in the tibial and the femoral alignment is with more than 3 degrees occur, at least in 10% of TKA, even when performed by the experienced surgeon using a modern system. You can see the graph here, there are outliers of even perform in the well experienced surgeon, the 3 degree of outliers, they are more not in the 0 degree. But if you talking about the result of 15 year, you can see this paper. The mechanical axis goal is 0 to 3 degree is a little practical value for the predicting the durability of the modern knee replacement. Again, you can see this paper in 2010 in JBJS. At the 20-year follow-up, we once again did not find any that the neutral mechanical alignment provided better implant survivorship than found in outliers group. Another paper in 2019 by Journal of Arthroplasty, it clearly says that those high volume surgeons who can afford it do not need it, and a low volume surgeon who need it cannot afford it. Again, the tibiofemoral alignment is a result of knee replacement. It's not only the alignment, it's the factor other than the alignment might be more important to determine long-term follow-up in the TKA. Again, a paper in the clinical ortho, the Ranamat paper in 2017, we found no benefit to computer navigation in TKA in terms of the pain, functional or the survivorship, the main 3 points. Another paper in the pros and cons and balanced view in the robotic knee in the Journal of Arthroplasty. Again, although the perception has been that the improved alignment associated with the robotic will improve the function and implant durability, there are limited data support that notion. Another paper in JBJS in 18, robotic technology in orthopedic. Again, it shows possibility no difference in the long-term result. Another data in the robotic assisted total intervention in Journal of 2019 in Journal of Arthroplasty by the Wujon. Again, it said robotic assisted TKA does not improve long-term clinical and radiological outcome as compared with the conventional one. Another paper in 2020, does robotic assisted TKA has better outcome? It's the minimum of 10-year follow-up, we found that no difference in robotic assisted TKA as compared to conventional one. Now coming to the cost. Hardware cost in India it is roughly about 6 crore. We probably, it will be absolute in further 5 to 6 because technology get advanced. In 5 to 6 it will be absolute and another robot will come. What will be the return on investment, the break-even point? You need an extra income of about 1 crore per year, for which you have to earn about 20,000 extra per cases when you have to do a 40 cases per month. So, who will going to burden this case. At last, who does get benefited? The surgeon? The question is, the company or the patient? The question is yours. The technology is welcome, no doubt, but when it is used for marketing, used for media for spreading disease and lies, exactly what you need to train as young surgeon how to avoid a pitfall in a conventional TKA. So my opinion is, don't make a simple logical surgery complicated by letting it hijacked by the artificial intelligence that allegedly knows what is better for us. To success, there is no elevator to success. You may have to take the stairs. And finally, don't let your loved one to take over by someone else, by the robot. Thanks a lot. Thank you.
Since morning, we are already have discussed a lot about the advantages and indications, clear-cut indications of robotics. So right now, I'll present only 3-4 slides. Should I? Yeah. Dr. Surup, come and join me.
So we are talking about technology. Robot is what, or navigation was what? It is just technology. So I can say so. Everybody has used that keypad telephone, cell phones. So now everybody has shifted to touch screens. Initially we used to get VGA cameras. Now we are on some 22 megapixel cameras. So technology keeps on changing, and that has helped us. Very rarely we have seen the technology not helping human beings, and this is, as sir was saying, if you put garbage in, the garbage will come out. So you have to use it very judiciously, and I think rest my president VOA, Dr. Jaiswal, will continue.
Yeah, sir. Sir, few things I would like to emphasize and repeat again. So I had presented in morning in this case. Once I was operating this without robotics or without navigation, one thing was 100% clear, that joint was opening laterally. And what about the insert? If you are doing it without robotics, what is the expected insert we would have inserted in this case? Minimum 10 or 12. But in this case, one thing I would like to share, that the insert in this case was given 6 mm only, 5 in fact, and this was not possible without the help of navigation and technology. Coming to the few advantages of robotics. So what are the literatures that we have encountered in the previous lecture by sir, that non-robotic surgery has a better advantage or robotics have not extra advantage. All these literatures are basically of first generation and second generation robots. For now we are in the era of the 4th generation robotics. So now robots are more advanced, and initially when robotic surgery was introduced in the TKR, they were basically using the pin positioning guide, and right now we are having navigation along with robotic arm. So time will take, and after few years or after 5 or 10 years we'll be able to judge the long-term outcome. Another thing is that now these robots are 4th generation, is more compact, and these are basically saw-based systems, not a pin positioning guide. They are real-time based, navigated, workflow is even easier, and it's always under the control of surgeon. It is not uncontrolled. Coming to again previous case, this was the initial leg alignment. So during the whole surgery and during an intraoperative period, we can use the navigation and equivalence graph to know which part is opening, which part is not opening. I was the non-robotic surgeon for past 12 years. On table, when I used to see that a little bit opening on a lateral side, 1 or 2 mm, we used to accept it. But when IM started using this navigation technology, what 1 or 2 mm we were thinking that was actually not 1 or 2 mm. On navigation, they are 5 mm, 6 mm. So again, coming to the complex cases like complex severe varus or severe valgus, 1 or 2 millimeter opening was more. So with the help of technology, we can judge it better. And on table, we can give result better. Only time will tell whether it is more beneficial to patient or not. And as in the previous lecture, sir has also told that extra-articular deformity has definitely an indication where we should use the technology. And one few beautiful part during the intraoperative planning, that this 5 degree or 3 degree or 4 degree flexion of the femoral component, that we cannot use, we cannot do with the conventional method. In conventional method, we cannot flex the femoral component as in desired amount if there is a more flexion gap. So in the era of kinematic alignment, we can change the alignment of the femoral component in terms of flexion, in terms of external rotation with the help of this technology. So, and one more literature that robotic assisted devices have given better implant fitting, better alignment of implant versus non-robotic. So long-term results are still awaited, I would say. Though definitely there is a clear-cut indication, or in a simple case, simple varus or non-complex varus, non-complex valgus, definitely results could be equal in both the sides. But in a complex cases and revision cases and extra-articular deformity, robotics has a definite advantage. Sir.
So the debate will go on.
Yes, sir.
Both have their roles, and technology will come. You want to say something, Uttam, for 1 minute?
Definitely technology, we respect the technology and welcome the technology. And the thing is, this technology, how it help it. Every 4 years, 3 years,
yes,
the technology will advance and this system will be absolute.
Just like iPhone changing every year.
And it is the cost worth or not.
One last thing I would like to add, sir. Navigation is started.
Ready now, I think
one last line. Navigation is started in the aviation industry. Now they have reached our cars, in our mobiles, and right now they are inside our OT. And down the line, 30-40 years, navigation robotics is not going to leave our OT. This is the fact.
Okay. Thank you. Thank you both.
Thank you, sir. Thank you, Dr.
Right. Thank you. Thank you.
इसको कर दो, फ्री हो जाए, छोड़ दो। देख लेते हैं।
Dr. Kartik Shukla, sir, can you hear us?
Mic on कर दो। Hello.
Hello. Yeah, sir. This is Dr. Swaroop.
Yes. Good evening.
Good evening, sir. Good to have you, sir.
Thank you. It's a pleasure to be here.
Sir, so we can see you. You are putting the pins.
Yes, we had exposed the knee, inflated the tourniquet, and we are just finishing the pin part so that it saves the time of everybody.
Sir, so we are seeing you putting that pins, and if you want, you can discuss the X-ray. If
it is in the almost same way, in a way we do in total knee. Okay. The pin will go in the same way, not much difference when it comes to uni.
Sir,
it's same.
Okay, you have already taken the incision, sir.
Yes, it's a very small mini arthrotomy.
Sir.
Yes, yes. ये ठीक है? Still we need to rotate it. Good. And this is also good. Let's check this. This is इस साइड होना चाहिए. हाँ, ये निकाल दो. Remove this. Open it. खोल दो. ग्लव्स में फंस रहा है तेरा. Yes. मैं इधर चला जाता हूँ, ठीक है. Yes, yes. So you can see the incision, I think. Am I audible there?
Yes, sir, you are.
Do you have gone through the X-rays of the patient?
No, not yet, sir. We
So
just
let us see the X-ray here.
yeah, sir.
So you can see this X-ray here very clearly. The left and right, both the knees AP X-rays.
Yes, sir.
And on the medial side, there is almost complete obliteration of joint space, hardly a millimeter or two. This is a standing X-ray. So if you go for a varus stress view, there will be a complete obliteration. You can appreciate. If you want to demonstrate this, this can be done.
Yes, sir.
So lateral X-rays, you can just rotate the lateral X-ray, please. Lateral X-ray, इधर थोड़ा ऐसे rotate कर दो, ऐसे. हाँ, yes, thank you. So the lateral X-ray, you can see again the wear pattern is entromedial, this proving the entromedial osteoarthritis, and the cartilage on the lateral compartment must be good. Yes, the ACL must be good, and the patellofemoral joint is not a problem. So it is a very, very well selected case for the demonstration purpose of entromedial osteoarthritis and a medial compartment replacement uni. Patient is male, tall, and we are expecting a quite good bone stock in the knee. The sizes that we have planned on the CT scan, we will just show you that again the bones are so big, so we have a good size of implant on the CT scan planning. Nice, nice, very nice. I'll just use this short one. Okay. All checked? Okay, so we are ready with the pins. You can see, flex a little bit of knee. The finding inside the knee, this is a bone on bone, absolute loss of cartilage in a medial compartment, and I'm not sure whether you can see or not, but the ACL is intact and the lateral compartment is also nice. There is a small trochlear ulcer on the lateral facet, but overall this is a classical medial compartment case.
Hello, Dr. Kartik. Yes. Would you like to do notchplasty or removal of osteophytes?
Always, always. It has to be removed. There is a consistent osteophyte on the medial border of lateral condyle, which is having a decapitating effect on the ACL every time there is extension. So even if you don't remove this, it is going to be a catastrophe because gradually the ACL will get degenerated. So even a well done uni over a period of time will not have that long term result. The second bone that we need to remove is the anvil osteophyte, which is in front of anterior cruciate ligament insertion, which is responsible for the flexion deformity. So usually the four bones that is to be removed is anteromedial bone on the tibia, the medial femoral condyle, medial ridge especially, which is affecting your gaps and kinking or stretching the MCL, deep as well as superficial MCL, anvil osteophyte and the notch osteophyte. These four bones needs to be removed. Here we will do the registration first, so it will not alter the anatomy of the CT scan planning. Anything to be, any question, I am always there to ask. Till we have a time before we start, we can have the questions. We can always take that.
So how do you protect the medial structures?
Yes, there is a beautiful retractor available with the system that is going to help you to retract. It's universal, you can use left and right, same instrument, very easy, user friendly, and it just slips in under the medial border of the tibia and it will stay there like this. So this is how you are going to protect your medial structure, whether it's a manual or a robotic uni, it can be done in the same way. And this is very user friendly instrument. It is not working as a spike actually, the spike is not a good idea, but this is just something which helps and protect without any abnormal forces on the deep and superficial medial collateral ligament. So this is the instrument you can use. The another instrument which is useful is any kind of self-retaining retractor, which is very useful when you do a uni. So you just need to apply this and entire thing is visible without stretching or disturbing the soft tissues.
So like we did in a robotic TKR, we remove the osteophytes later.
Yes, we will do the same. We will do the same. We will remove the osteophytes. Very small amount of osteophyte just you need to remove on the, especially in the medial border of the femoral condyle, so that you will balance the knee very well.
So can you show us the planning expect?
So planning, where is
Planning
the
expect
laptop?
on the planning expect on the.
So we had planned, so that is a good idea. We can discuss the planning part at this moment. So this is just elevate this, just like this. Okay. So this is a planning screen. You can see. No, that's fine. It's almost same as the knee, nothing more. So the planning part is here. The most important part of this software is that you don't need to do anything much, because actually if we understand the procedure, uni as a procedure, it's a bony procedure. So TKR is a soft tissue procedure. So there is an element we call the static element, followed by a dynamic element that you do operatively when you go inside the OT, see the gaps, and you modify your implant position, rotate it, upgrade, upsize, downsize, and so many things you need to do, because you have to think of soft tissues all the time. Here it's by default all 4 ligaments are intact. That is the first and foremost prerequisite of a unicondylar knee replacement surgery. So this software takes the measurements and axis. So if you see carefully, if we start with the femoral implant, the size we selected is a 4. It's a size 4 left side femur, just at the level of linea terminalis, that is the anterior most dent or the loss of cartilage, as well as there is a meniscus indentation. Your implant should not cross on the superior to this. So size 4. Distal medial we have planned resection 5.8 millimeter. Posteromedial 5.9. The thickness of this implant is 6 millimeter distally as well as the posteriorly. Rotation, if we talk about, you do not need to do anything with your rotation, because it is based on your flexion extension plane. It's default 0 degree always. Varus always 0 degree. You don't need to apply your mind here. Rotation, as because the morphology, the shape of the condyle can have a variation. So it starts from the 0 to 1 to 2 to 2.5 to 3, depending on, so you will have the best match and there is no irritation of soft tissue and the implant is not overhanging on the bone. So that's the femur part. If we talk about the tibia, and one important thing to understand, most of the time people says you cannot upsize. So whenever there is active robotics, the safety is more because the automation is more. Both goes very parallel to each other. Second thing, people say there is no haptic in this system. This system does not need haptic. It's an auto haptic system because you had planned the CT scan, the RMSC is calculated, it is safe, your data is not corrupted, and when we do the registration, again the RMSC should come, that is a root mean square error of less than 1 millimeter. So when the robo will do its action, anything like any movement it will detect, it stops. So it's an auto haptic robotic system. So if you have your hand and the robotic arm, you need a haptic. It's auto active robotic system, does not need haptic, it's auto haptic. Tibia, so that you cannot upsize the implant. So sometime if you are in any dilemma, you can select the larger size. Tibia we have selected size 4, left size 5, sorry, size 5, tibia again the size 5. Proximal medial resection is 3.2. To me, it should be always less than 4 millimeter because deep below 4 millimeter, you are going to violate the fibers of deep MCL. So try to preserve the tibia. This is a robust male patient, so this is 3.2. Sometimes it goes up to 2.5 or 2.7.
So how about your posterior tibial slope? Whether you will try to match the native posterior tibial slope?
Yes, yes, yes. I am coming to that point. So proximal 3.2 millimeter, then posterior slope is 4.8 millimeter. See, actually it's a round on flat design. So usually it is not, and as the literature says, you do not need to be that accurate because you have all 4 ligaments, but try to match your posterior tibial slope. On the CT scan, it is always very easy and comfortable. Second thing, there is always a proximal anterior metaphyseal tibial changes secondary to osteoarthritis. So you try to match, but still it is debatable and questionable that is this a native slope, but you try to reproduce as much as possible, and this is almost in this case is 4.8 millimeter. Rotation you are not going to do here because it is going to take the points that you had already done on your mapping. Varus valgus you should not do. So only 2 freedom or 2 things where you need to apply your mind is your tibial slope and femoral rotation. Rest is done by the system itself. So this is the planning part, size 5 femur, size 5 tibia. Sorry, size 4 femur, size 5 tibia. So you are okay? Then we have to do manual. So I think there is some problem with the burr because this system needs a separate burr for the uni and separate burr for the total knee. They do not have, I think, the uni burr here available. So if it is not there, I think the whole thing that we need to shift is to do a manual surgery. So let's understand what is the final verdict.
So can you tell us the difference between uniburr and
It is very small in diameter. The TKR burr is very robust because it has to work like a horse. So this is a very delicate surgery, and this is TKR. It is already there. It's already seen the TKR burr. They know. So it is smaller in diameter because it's very small area where we need to work upon, and it's in almost 1/3 portion of the total knee where you are working. So it's a very small burr which is going to do the same job, but the dimensions are very small.
Probably we are waiting for the UKR burr to come, sir.
Hello.
Hello.
We are still waiting for the burr.
Okay, sir.
We just wait for 5 minutes. They are just searching the burr. It is already sent, so that they are just looking forward in CSSL department. So just wait for 5 minutes, and then I'll just update you in 5 minutes.
First TKR which got operated, the opposite limb was also operated on the same sequential. So in first TKR, Dr. Sanjay Londhe did, then he asked for the circulation, but somehow our agent responded, but he thought everything is good. Typical time was 2 hours 10 minutes. Just half an hour before I received the call, post of no circulation, patient feeling ischemic excruciating pain. Warm up किया, movement pulse oximeter negative, little to was positive but grade 2 was negative. Recollection या फिर NTG कुछ infuse Doppler CT angio. Now everything is normal. Spasm, sudden spasm. Now everything is normal. But this happened. Bring the burr for the UKR, so UKR procedure is abandoned. He will do open UKR.